Good morning, everyone. I'm Dr. Madhura from SIMS Hospital. Today I'm going to present our study of uterine endometrial vascular assessment using three-dimensional ultrasonography with power Doppler angiography in the prediction model of outcome in frozen embryo transfer cycles. Aim and objectives of this study was to assess whether the uterine endometrial vascular indices measured using three-dimensional power Doppler ultrasound can predict pregnancy outcome following frozen embryo transfer cycles, and to compare the differences between variables in pregnant and non-pregnant population. This was a prospective observational study from October 2019 to February 2020 at our IVF unit at SIMS Hospital. 86 infertile couples who underwent frozen embryo transfers were included. The inclusion criteria was infertility of variable duration. Age of the women were between 21 to 45 years. Those who were on IVF ICSI cycles undergoing frozen embryo transfer cycles. The uterine cavity was assessed by three-dimensional ultrasound or prior hysteroscopy and found normal. Exclusion criteria in the study were like uterine pathologies like severe adenomyosis, fibroid, endometrial polyp, uterine adhesions, intrauterine adhesions, or low resolution on ultrasound, inadequate data, or previous gynecological surgeries if she had undergone. In this study, the endometrium was prepared with the increasing dose of estrogen, and then starting from 2 milligram and increasing up to 8 milligrams up to on day 12. On day 15, progesterone was started. Just before starting the progesterone, two-dimensional and three-dimensional ultrasound was done using transvaginal ultrasound on the S10 machine by a single operator. No embryo transfer was done if the endometrial thickness was found less than 7 mm. All the data which was calculated on the third dimensional, all the data which was calculated using three-dimensional ultrasound as well as power Doppler angiography was, clinician was unaware of the data because it was carried out afterwards in the study. When we compared the various parameters in the study, we found that the maximum number of patients, around 43%, they were between 31 to 35 years of age group. 38% were between 26 to 30 years of age group, as compared to the other age group like between 21 to 25 or more than 36 to 40 years or more than 40 years. Then when the causes of infertility in our study group was assessed, we found that only female factor was present in 62%, only male factor it was present in around 5%, and combined both male and female it was present in 24% of the study group, and 9% of the study group was unexplained infertility. When the pregnancy outcome we compared, it was found that 26.7% were the pregnant patient and 73.3%, that is 63 out of 80, they were non-pregnant patient. Now, pregnancy outcome, it was assessed by measurement of serum beta-HCG on 14 days after the embryo transfer. When it was more than 25 milli-international unit, it was considered positive, and it was around 26.7%. Biochemical pregnancy was seen in 3.4% of the population. Clinical pregnancy was assessed by ultrasound at 6 weeks. It was positive in 20.9%. Miscarriage rate was 2.3%, and twin gestation was 4.6%. Various baseline characteristics between pregnant and non-pregnant population was seen. Almost always similar only, like age distribution, duration of the infertility, BMI, basal hormonal profiles were similar in both the groups, except for the percentage of infertility patient, both primary and secondary, it was more in non-pregnant population. When the ultrasound indices were compared between pregnant and non-pregnant population, it was found that endometrial thickness was same in both the groups. Endometrial volume was also same. Vascularity index was also same in both. Only the flow index, it was more in the pregnant population, and vascularity flow index was also more in the pregnant population as compared to non-pregnant population. So conclusion of my study is endometrial flow index and vascularity flow index on starting of the progesterone are probably predictive of pregnancy occurrence during FET. Three-dimensional power Doppler ultrasound may be an useful and effective method for assessing the endometrial blood flow in frozen embryo transfer cycles, and these findings may allow earlier prediction of non-receptive endometrium and provide information during the cycle of interest about whether to perform FET or to cancel until the endometrium is receptive during future cycle. Thank you for your patient hearing.
Thank you, Madhura.
Thank you, sir.
A
Thank you,
nice
sir.
innovative thought. Was there a correlation between the actual thickness and the flow index?
No, sir. Not, sir.
Was the flow index independently predictive of the outcome
Yes,
without
few.
the thickness being included?
Yes. Yes, sir.
Can I just ask you, how did you
morning,
standardize
sir.
the settings on the machine to make sure that each patient was standardized to the same
Yes, sir.
measurements?
We have standardized the things, but I don't remember exactly what were the things like flow for all the patients. It was standardized software, what was focal and the parameters.
And if you make several measurements in the same patient,
Sorry, sir.
if you make more than one measurement in the same patient, how much variation is there in measurements?
Around 2 to 3 mm in the thickness, it was this. And flow index were almost similar. If we take three measurements, we took for each patient, and they were almost near to each other.
That's a very interesting study, Madhura. Thank you very much.
Thank you,
Very
ma'am.
nicely
Good morning.
presented as well. I just wanted to ask you that there was quite a significant number of women who were young
Yes.
and who had come to you with infertility. Was there a difference in the reason for the infertility in them? Did you compare it based on age? I know you said there was no, this is the distribution of the age.
30.
Did your endometrial findings have any correlation with the age of the mother?
We didn't do this study, but we'll surely find out if there is any correlation between the age and thickness and vascularity.
But you said there was no change in the hormonal status.
No, almost
between
similar.
the pregnant and the non-pregnant. But we didn't look at the pregnant younger women and the pregnant older women to see if there was any difference.
With the vascularity and all.
Yeah.
No, we have not done.
The other thing I also wanted to ask you is you're saying there's a difference between one group and the other. Did you do any statistical workup? Because your numbers are not, it's a good number for your study, but it's a small number. Did you,
Yes.
to take this forward into clinical practice, we need to prove statistically there is a difference. Did you apply any statistics to it? You've given some plus or minus. I think I'm assuming that's mean and standard deviations. Did you apply any statistical?
Yeah, we applied for this, mean with standard deviation for the some data, and then for other, we have calculated, I think.
Mean and standard
Standard
deviation is
deviation.
what you have used, basically. Okay, thank you. Is there any question from the audience? Anybody wants to ask him? Thank you very much.
Thank you.
Thank you, Madhura. We'll go ahead with the next presentation by Dr. Sensen Bhutia from Fernandez Hospital.
Good morning, everyone. I'm Dr. Shiten, Fellow in Fetal Medicine from Fernandez Foundation, and today I'm going to present on perinatal outcome of placental chorioangioma, a single-center experience. So as we all know, placental chorioangioma is the most common non-trophoblastic vascular tumor of placenta with an incidence of around 1%. There can be a small size which might be asymptomatic, or the larger one which are more than 5 centimeter can lead to various maternal and fetal complications, that being polyhydramnios, preterm labor, preeclampsia, fetal growth restriction, anemia, thrombocytopenia, leading to non-immune hydrops. So the aim of my study was to review the prenatal complication management and perinatal outcome in pregnancies complicated by placental chorioangioma. And the primary objective was to know the incidence and perinatal mortality rate of placental chorioangioma in Fernandez Hospital. The secondary objectives were to assess fetal complication, coexisting maternal complication, need for any fetoscopic intervention or in utero therapy, to know the mode of birth, and to know the composite adverse neonatal outcome. So it was a retrospective study done in Fetal Medicine Unit, Fernandez Hospital, Hyderabad, from 2011 to 2021, and all the cases during this period were included. Looking at my inclusion and exclusion criteria, all singleton pregnancies diagnosed on prenatal ultrasound and confirmed postnatally by histopathological examination and who were delivered with us in our hospital were included. And multiple pregnancy, any pregnancy with structural anomaly and postnatally detected chorioangioma were excluded from the study. Outcome variables were obtained by reviewing the medical record, and the diagnosis was based on ultrasound and color Doppler, where we saw a well-circumscribed placental mass with clearly delineated vascular supply, and it was confirmed postnatally by histopathological examination. So coming to the result, we saw 26 cases of antenatally diagnosed cases, out of which 17 was confirmed postnatally by histopathological examination, which gives us an incidence rate of 1 in 10,000 in our series. The mean maternal age was 29 years. Coming to the booking status, we have almost equal number of booked and referred for second opinion, that being 47% each. Looking at the gestational age at detection, majority, that being 53%, were detected beyond 29 weeks. That is merely because of our hospital is a tertiary referral center as well. In terms of size of chorioangioma, 76% were a large chorioangioma, that being more than 5 centimeter. 2 out of 17 cases has increased in size with gestational age and developed fetal anemia later. First case had intrauterine transfusion and the second case spontaneously birthed at 34 weeks. Looking at the maternal complication, majority were gestational diabetes mellitus, followed by gestational hypertension and preeclampsia, and to note that 53% of the cases didn't have any complication. Coming at the fetal complication, we saw polyhydramnios, fetal anemia, cardiomegaly, and non-immune hydrops, and the majority, 10 of 17 cases, developed polyhydramnios. Interesting to note that 4 out of 17 cases had uneventful antenatal course. Looking at the growth status, 65% had appropriate for gestational age. We had 3 cases of intrauterine therapy in our series. All were detected in 3rd trimester because it was a referral case, and all were beyond 5 centimeter in size. The first case had intrauterine transfusion at 30 weeks, 2 days, and after 2 weeks, she had spontaneous preterm vaginal birth. The second one had non-immune hydrops with severe polyhydramnios, and we had intrauterine transfusion done twice, followed by amnioreduction, and she also birthed at 30 weeks, 2 days. The last case was only polyhydramnios with placental mass, where we had done amnioreduction at 28 weeks, 3 days, and we could pull her up to term. All the babies at present are alive and healthy. Looking at the gestational age at birth, 59% we had a preterm birth, that was 10 out of 17 cases. 5 of them was spontaneous preterm birth, and 5 was a nitrogenic case because of fetal indication. Coming to the mode of birth, we have almost equivalent rate of cesarean section versus vaginal birth. Coming to the composite adverse neonatal outcome, we had 7 respiratory distress babies, 1 had neurological outcome, and 1 had infection. That makes around 11 of them had an NICU stay at our hospital. Looking at the prolonged NICU stay, this baby had anemia, cardiomegaly, polyhydramnios, and non-immune hydrops, and birth at 26 weeks, 3 days. The hospital NICU stay was 81 days. At present, she is alive and healthy, had normal milestone, but has a profound hearing loss. And we have no neonatal mortality rate. So concluding my series, ultrasound is a gold standard for diagnosis. The incidence in our series is 1 in 10,000 with no perinatal mortality. Timely diagnosis, close and regular monitoring helps in early recognition and prevention of adverse event. Intervention in selected cases yields an optimal result. And considering the preterm delivery rate in our series, I would suggest timely referral to tertiary center for optimizing the outcome. Thank you so much.
Thank you. Were those outcomes better than you expected?
Sorry, sir. I didn't get you, sir.
Were the outcomes better than you expected?
Yes, definitely, sir. In terms of neonatal mortality, yes, sir.
How do they compare to the outcomes in the literature?
Yes, sir. When we compared with the other literature, like say, for example, mine was a 10-year period. So I went through the literature where there were 10-year period. It was almost similar, like 15 to 17% with a mortality rate of 2 or 3 in such cases, sir.
And do you think we should take any other measures to avoid preterm birth in these pregnancies?
Yes, a timely intervention we could have done, but sadly everyone were referred in the third trimester. So that is my emphasis of the study, that if they refer on time, we can do some interventions for such cases.
Thank you.
Thank you very much for the wonderful presentation. Half of the cases were referred. So do you still want to call it incidents?
Sorry, sir?
Half of your cases were referred. Do you still want to call it as an incidence of chorioangioma? Technically, it will not be. It's just the frequency in your series. Okay? And chorioangioma, the complications, you can divide them into sequestration and shunt. Which is the definitive therapy?
Sequestration, sir?
It's the shunt.
Shunt.
Sequestration is a small component. That's why in some of the cases, they end up in a very stormy neonatal outcome. Which is the definitive therapy for chorioangioma, giant chorioangioma? The definitive therapy.
Treatment, sir.
Treatment, yes.
So,
In utero.
so fetal laser coagulation, radiofrequency ablations are there. Some have written even
So
alcoholic.
some form of devascularization has to be done. Then the outcome will be better in those cases, especially the last one which you said.
I was going to ask you the same as well. How many of them actually had any laser therapy or radiofrequency ablation?
No, ma'am, we didn't. Out of 3, one of the cases were actually referred to Mediscan, but because of severe polyhydramnios and being in third trimester, it was technically difficult. So we just gave an supportive therapy.
Okay. You had some babies with hydrops and some without hydrops.
Right, sir.
Was there any difference? Did that make a difference?
No, ma'am. At present, all 3 of the cases, we had given them intrauterine transfusion, and they are alive and healthy. We could retrieve them.
And do you understand the pathophysiology of why these babies present with fetal anemia?
Yes, ma'am. And because of the tumor mass and AV shunting, there can be hemolysis, and because of that, it can lead to non-immune hydrops.
And how long did you follow these babies up after birth?
So far, ma'am, at least for 3 years at present. The last one was 2 years back, yeah, the latest
Just out
one.
of curiosity, there are a lot of placentas get examined. In your hospital, did you find any incidental chorioangiomas in any of the pathological examinations of the placenta which was sent for something else?
Yes, ma'am, it is there, but exactly I cannot say. Like undetected antenatal one, like especially the few ones, it has turned up. But we have not included in our case because those were very small and we had not detected antenatally.
A corollary for that, did you have a false positive diagnosis where you thought it's chorioangioma?
Yes,
but
definitely, sir. Out of 26, only 17 were diagnosed postnatally. Thank you. Thank you, everyone.
Thank you very much. I call upon the next presenter, Dr. Shraddhanjali Sahu from Fernandez Hospital.
Good morning, everyone. I'll be
Not
present.
this one. This is over. AV team. Hold on, doctor.
Good morning, everyone. I'll be presenting my study, Prenatal Diagnosis and Outcomes of Fetal Cystic Hygroma. The cystic hygromas are abnormalities of the lymphatic system characterized by single or multiple cysts, usually in the soft tissue involving the neck region. These cystic hygromas are associated with chromosomal defects and structural abnormalities in around 80% of the cases, and the prognosis depends on the associated anomalies, chromosomal aberrations, and the presence of hydrops. The presence of hydrops carries a 100% risk of mortality. So this study was aimed to evaluate the diagnostic features of the fetuses with cystic hygroma, as well as study the association with the chromosomal and major congenital defects and the composite perinatal outcomes. It is a retrospective study that was carried out in Fernandez Hospital between June 2005 and June 2022. The data was retrieved from the electronic database, and the associated anomalies, hydrops, genetic test results, and the perinatal outcomes were noted. In our study, we have excluded the cases of isolated increased NT, multifetal gestation, presence of meningocele, cephalocele, and calvarial defects. Coming to the results, out of in this period of 17 years, we have obtained 258 cases in which the maternal age was around 27 years and the gestational age at diagnosis was 14 weeks. In 9% of the mothers, there was a previous history of anomalous baby. We have observed that most of the cystic hygromas were septated, accounting for 78%, and associated hydrops was seen in 38% of the cases, systemic structural abnormalities in 31%, and there were 141 cases of isolated cystic hygroma. So out of the 258 cases, we had only 80 cases with structural abnormalities, and the majority had cardiovascular system defects, accounting for 30.6% of the cases. Next, commonly gastrointestinal, skeletal and craniofacial anomalies were detected. Of the 258 mothers, only 28.6 had opted for invasive prenatal testing, and depending on the gestational age, amniocentesis was carried out in 30 cases and chorionic villus sampling in 44 of the mothers. Karyotyping was previously the main genetic test which was carried out, but in the recent years, along with it, chromosomal microarray and whole exome sequencing are also being done. After the cytogenetic tests, we could find 30 cases with chromosomal abnormalities, and there were 2 variants of unknown significance. Of the 30 cases with chromosomal abnormalities, the maximum had Turner syndrome, around 60%, and next being trisomy 21, and also we had 4 cases of trisomy 18 and 1 case with trisomy 2. Coming to the perinatal outcomes, of the 258 cases, majority 64% had undergone termination of pregnancy, and only 91 mothers continued with their pregnancy, of which 19% were lost to follow-up, and we had a live birth rate of 3.8%. Among these live born, the median birth weight was 2.7 kg, and these babies had good Apgar scores at birth. Of the 10 live borns that we had in our case, 6 had undergone prenatal resolution of the cystic hygromas, and these babies had good neonatal outcomes. Whereas of the rest 4 cases, 1 baby had Noonan syndrome with exomphalus, 1 baby had Abernathy malformation, 1 baby inborn error of metabolism, and 1 baby underwent surgery for dilated lymphatics. Sadly, out of the 167 cases which had opted for termination of pregnancy, only 13 parents went for fetal autopsy, but fetal autopsy did reveal some additional findings like agenesis of the corpus callosum, hypoplastic kidneys, and heterotaxy syndrome. So to conclude, cystic hygromas are abnormalities of the lymphatic system, and they are usually associated with a poor prognosis. So once detected, it is necessary to carry out a detailed ultrasound examination along with fetal echo to rule out any associated abnormalities. Invasive prenatal testing with chromosomal microarray should be offered in all the cases, and in the absence of chromosomal anomalies, it is necessary to do serial ultrasound examinations to look for the resolution of the hydrops and any evolving resolution of cystic hygroma and any evolving hydrops. The parents should be counseled at every step, and in case they opt for termination of pregnancy, they should be encouraged for fetal autopsy. Thank you.
Shraddhanjali.
Yes, ma'am.
Thank you. It was a very nice talk. My question is, why did you choose this topic? I think there's a lot of literature already on cystic hygroma. What prompted you to look at this?
Ma'am, because the study from Indian population is scarce regarding cystic hygromas. All those literatures we have is from the outside only. Mm-hmm. So we conducted this study so that we have we can study the perinatal outcomes in our population, in our mothers, which will be helpful in, means if they ask us what is your experience in your setting, we can counsel them in better way.
Exactly. So from this study, what have you learned that will make you change how you're counseling the patient?
Ma'am, like we have seen that most of the mothers didn't go for any prenatal testing, and they opted for termination of pregnancies. So in my study, there were some cases which I spoke about live births. Most of these live births had isolated cystic hygroma, and those were non-septated. So we can tell them that in case they go for prenatal testing and there are abnormalities, chromosomal abnormalities are absent, then we can have a good prognosis in those cases.
Okay. Just one more question before I pass it on. Out of the women who opted for termination, How many of them had isolated cystic hygroma? Because
Yes.
that is what you will be wanting to convey to your mothers who are, you're going to scan again, you find a cystic hygroma. I just thought that would be interesting. Perhaps you
Ma'am,
should.
this isolated cystic hygromas, I have excluded the chromosomal abnormalities.
Yeah.
But only isolated cystic hygroma, in the absence of hydrops only, there were around 73 cases. And of those 73, around termination of pregnancy has been done in 26 cases.
Okay, thank you.
Shraddhanjali, thank you for the wonderful presentation. All these deliveries or abortions, did they happen within your institution?
Yes, sir.
Do you have data on the gender?
No, sir.
Will that be useful?
Because only Turner syndrome, which was seen in the chromosomal abnormalities, it means indicates that most of these chromosomal abnormalities were in the female population. But we don't have any specific data regarding the gender.
Have you stored you had stored the DNA in some cases, I believe?
I'm not sure, sir.
Not. The only one case of Noonan was presented.
Yes, sir.
What do you think is the reason for such a low prevalence?
This is maybe due to the most of the cases had undergone termination of pregnancy or IUDs. So we don't know whether
We didn't look for it.
Yes, sir.
Okay. Okay, thank you.
Thank you, sir. Thank you, everyone.
Thank you. Next, I call upon Dr. Apurva from Mediscan for her presentation.
Good morning. I'll be talking about prenatal case series of focal femoral dysplasia, case series and lesson learnt. FFD is a congenital developmental disorder. It affects the subtrochanteric region of the femur with varying degrees of shortening of proximal femoral segment. Etiology of this is uncertain. It can be due to poor diabetic control. It can be due to exposure of teratogens like drugs, viral infection, radiation. Management of FFD is highly individualized. Aims and objectives of my study are to analyze the prenatal characteristics of FFD, to see their perinatal outcomes, and to correlate the prenatal ultrasound and the autopsy correlation of these cases. It was a retrospective study done at our center over a period of 15 years. Totally, we had 82 cases of FFD, out of which we had 6 cases which was diagnosed in first trimester, 67 cases were diagnosed in second trimester, and in 9 cases we had a third trimester diagnosis. Mean gestational age at diagnosis was 23.4 weeks of gestation. Now, out of 82 cases of FFD, when we come across the split up between the isolated cases and associated findings, it was almost equal. When we look at the laterality, we had more of bilateral cases compared to unilateral cases. On the contrary, literature says unilateral is more common compared to bilateral cases. We had 37% of diabetic patients in our study. Now coming to the cases which we have diagnosis in first trimester period, in all these cases we had done a transvaginal ultrasound. In this, only one was unilateral and rest all was bilateral. And 2 had associated findings which also prompted us to do transvaginal, which increases the diagnosis of these conditions. Now coming to the outcomes of these cases, total of 82 cases and 11 lost for follow-up, out of which 61 case decided to terminate the pregnancy, out of which 32 came back to us for autopsy. In that 32 case, 30 was totally confirmed the autopsy findings, and in 2 case, autopsy gave a different diagnosis of osteogenesis imperfecta. In this 82 case, 10 patients decided to continue the pregnancy, out of which 1 had a neonatal death at 5 days because the baby also had associated IUGR, and 9 babies are alive. This is an example of case which autopsy confirmed FFD. First picture shows the ultrasound diagnosis of FFD. The second is a fetogram. You can see clearly the difference between the two femurs, and also note the other long bones are normal. In the third image, you can see both the knee joints are not in the same level. This is the autopsy picture of the two femoral head. This is the affected one and the normal one. The comparison. Hip joint assessment is very important to prognosticate and the treatment of FFD, but this is very difficult to do antenatally. These are the few associated anomalies which we have seen in our case series. One is dysmorphic facies, micrograthia, and fibular hemimelia. Now coming to those two cases which autopsy gave as an osteogenesis imperfecta, one case we had diagnosed it at 16 weeks and we didn't recognize the poor mineralization of the bones. In another case, we had diagnosed it as 22 weeks. In that case, along with the both femur was 4 weeks lag, other long bones were also 2 weeks lag. That's why we had given a differential diagnosis of FFD and other differential diagnosis as non-lethal skeletal dysplasia. This is the summary of the 9 babies who are alive. In this, 4 babies who are in the age group of 3 to 7 years of age, these babies are walking with a shoe race. And one baby, right now he is 9 years, at 7 years he underwent Ilisaro technique for the lengthening of the limb, now he is walking. In this, 3 babies are under 1 year of age and these babies are not in the walking stage. In this one, we had a bilateral diagnosis of FFD at around 22 to 23 weeks. In this, the parents say the baby is of normal height, normally walking. This is a fallout of telephonic conversation. We have not physically examined the baby. In this 2 cases which had 3rd trimester diagnosis, we have reported target scan as normal. In these 2 cases, it was unilateral FFD and the affected limb was in the far field. This reiterates the fact that the importance of taking both the femur with the knee joint at the same level. So coming to conclusion, prenatal diagnosis of FFD should be made with certainty by 2nd trimester. Symmetry of femora with knee joint at the same level helps the accurate diagnosis in 2nd trimester, especially when the affected limb in the far field and it is unilateral. Urinatal FFD is difficult to diagnose in 1st trimester. Extended skeletal imaging helps narrow down the diagnosis between the bilateral FFD and osteogenesis imperfecta. Evaluation of the hip joint is difficult antenatally. Thank you.
Thank you very much. Wonderful presentation. What are the ultrasound criteria for FFD you had used?
The difference of this, both the knees are not in the same level, and the difference of both the length of the femur.
So it's basically a short femur.
Short femur, bowed femur.
Otherwise a normal skeletal system
yes.
by ultrasound.
All the other long bones are normal.
Okay. So you also answered my question when the OI, the cases were whether they were of the 1st trimester. Now answer this question. If you have unilateral or if you have bilateral, which is outcome wise better?
Unilateral, sir.
Bilateral. As the orthosurgeons, they will say bilateral easier to treat.
Do you think that these women should have some type of genetic studies done?
Sir, it is not really needed in FFD.
Do you think you need it to
If it is
exclude-
bilateral, and associated findings are there like fibular hemimelia, tibia hemimelia, there are cases which shows genetic correlation. Otherwise, FFD as such doesn't have genetic correlation.
So do you think you need to do those studies to exclude those other diagnoses?
Yes, sir. I didn't get you, sir, sorry.
Do you think you need to do those genetic studies to exclude those other diagnoses?
Yeah, might be in those cases which we had associated anomalies.
Yeah. Okay. Thank you.
Thanks.
I was going to ask you the same thing. Did you consider offering them an invasive test? Because, we are in the era where we are actually finding more and more associations, not necessarily etiological associations, but some association. It may be worth documenting it. My question was, before you did this study, was there a routine protocol to check both femurs, to measure both femurs?
Yes, sir. Yes, ma'am. In Mediscan, we take both the femur at the knee joint, both, yeah, we take it like that.
Okay. And all long bones, both sides?
Yes.
Okay. And transvaginal scan is done routinely. How do you consent these women for transvaginal scan in the first trimester? Do you actually explain to them why you're doing it, what it is? Have there been any objections?
Ma'am, routinely, only if it is needed and if it is any associated findings are there, then only we will do transvaginal. Otherwise, routinely is not done.
Okay, I think what I think is a big call out to the pathology team, because they've done a fantastic job
Yes.
of looking at all these babies, without which you wouldn't have been able
Yes,
to
yes.
correlate this. Just one last question before you go. Do you think the majority of babies with this finding are actually alive because the gestational age of diagnosis was quite late in them?
Yeah.
Thank you. It's the largest series, so you should
Yeah.
try and publish it. Thank you.
Thank you.
A very big thank you to all the presenters and our esteemed judges, especially for sticking on to time. Thank you very much. Next, I welcome all our dear delegates to day 1 of conference, and I'm sure a great academic feast awaits you.
Good morning.
Great.
It gives me great pleasure to welcome you all to the 17th edition of CUSP. We started in 1989, and over the years We have seen increasing attendance, and this year we have over 800 delegates. We always believed that CUSP is not a conference, but a platform for exchange of information, and we are acutely aware that delegates come to CUSP in the hope of getting some firm take-home messages which can help change practice. And that happens because of our excellent faculty we have every time. And I extend a very warm welcome to our faculty who have not only come from India but from Australia. We had a faculty from Germany and also from Hong Kong. It's a statement to say that CUSP is a conference. CUSP is a meeting where we exchange information with each other. You can call CUSP as a platform where young minds are given a platform to exhibit what they can, and you just saw a few excellent papers being presented. It all happens because there is faith which is reposed in us by all of you. And for that, I once again welcome all of you for this meeting. Today is a very packed day. We try to keep to schedule, very tight in our schedule, and hopefully we should be able to reach. And I also want to extend a very special warm welcome to Dr. Arun Kinare. Arun Kinare is our, today he is being honored, he is one of our legends, because every time we take it a point to have one of the legends in this field to be honored. And when I actually read his citation, you will realize why he has been chosen this year. So thank you all, and hope you enjoy the sessions today and tomorrow.
I request all delegates to stand up for a few minutes for prayer.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்பரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்து எந்து செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
I call upon Dr. Jyoti for the first presentation on reporting nuchal translucency, the ground. Dr. Jyoti Singh is a consultant in fetal medicine and Mediscan. She actively involves herself in all academic activities and NABH accreditation processes. She is a keen observer and is presently developing fetal medicine unit of Mediscan at Rela Hospitals. Over to you, Jyoti.
Good morning, one and all. Welcome to CUSP 2022. Today will be the first talk, that is increased nuchal translucency. How do we define it? A mouse. Excuse me, I need a mouse. The commonest concern which we face in the first trimester is an increased nuchal translucency. The concern even arises more because the normal range of nuchal translucency changes with gestational age in euploid fetuses. So how do we define an increased nuchal translucency? Do we take a percentile cutoff, that is 95th centile or 99th centile, or do we take an absolute value as cutoff, whether 3 mm or 3.5 mm? So what do the guidelines say? The Fetal Medicine Foundation, who have laid the definition of defining nuchal translucency, have taken an absolute cutoff of 3.5 mm, above which the abnormal results are noted. ISIOC doesn't give a well-defined definition for increased nuchal translucency. The ACOG has defined an absolute cutoff of 3 mm, and Society of Maternal Fetal Medicine has defined more than 99 percentile. So each of their guidelines have got their own references and they perform their investigations. So that is more concerning to how do we define increased nuchal translucency. Why do we need to define nuchal translucency? Deciding for diagnostic testing, what diagnostic test to do, assessment of structural malformations, that is triaging the fetuses which are at a major risk for malformations, defining the cutoff for which we should not perform a cell-free DNA testing, and counseling of the respective parents on the outcome. The concerns with an increased nuchal translucency are common chromosomal errors, then pathogenic copy number variants. With the advent of newer chromosomal microarray, more number of pathogenic copy number variants we are able to identify. Then structural malformations which are commonly associated with increased nuchal translucency, and the single gene disorder. So if we look at the evidence, the chromosomal aberrations which are noted with an increased nuchal translucency increases as the value of the nuchal translucency increases above 3.5, and they are significantly more when it is 6.5, that is almost 50% of the fetuses are abnormal. The pathogenic copy number variance is found out equal in the entire subgroup, and structural malformations increases significantly when we look at the increased nuchal translucency. If we look at these chromosomal errors, there are typical chromosomal errors which we find out in the chromosomal karyotyping commonly which we perform, that is for 13, 18 and 21, and the sex chromosomal aneuploidies. The atypical ones are the pathogenic copy number variants, autosomal trisomies, polyploidies, unbalanced translocations, which can be identified either by chromosomal microarray or further testing. This was a recent publication which was published in 2021 that defined the NT in 3 different subgroups, that is less than 3 mm, in which the typical and the atypical problems which were identified were equal to the general population. However, which in the subgroup which we look in 3 to 3.4 mm, the typical were around 3.9% and the atypical were 0.37%. If we look at the number of more than 3.5, the typical were around 30% and the atypical were significantly more, that is 4%. So when we see the criteria cutoff, that is 3.3 to 3.4, it is around 1.9% of atypical abnormalities which were noted. However, if we see the same thing, if we take the increased NT criteria of more than 99 centile for the particular gestational age beats CRL, the yield increases significantly to around 4.5 to 3.5 to approximately 6.1%. So that is a significant increase in the yield if we take a value that is more than 99 centile for the gestational age. And this was a previous meta-analysis which was published, which characterized the fetuses structurally normal and abnormal. So they have taken the cutoff of more than 3.5 mm. The yield of chromosomal microarray was around 5% in structurally normal fetuses and around 7% in the structurally malformed fetuses. The most common copy number variants which were identified were 22q microdeletion and 22q duplications. The next form of testing which we do is whole exome sequencing and Rasopathy clinical exome sequencing. So if we look at whole exome sequencing, the yield which is given is around 3 to 8%. It has got a range. And if we use the Rasopathy clinical exome sequencing, this is a subset of group which has got specific genes which are be tested with specific panels. So if we have taken the subgroup of isolated increase NT above 3.5, the yield is around 3%. However, if we look at the fetuses with structural malformations, specifically like increased nuchal translucency, polyhydramnios, pericardial effusion, hydrops, then congenital heart diseases, the yield increases around 14% in this particular subgroup with ultrasound identifiable structural malformations. And if we take an absolute value cutoff for which we need to offer rasopathy testing, the NT value can be more than 5. So in this particular subgroup, we can offer specific clinical exome sequencing. The next thing which we are looking at, the risk of structural malformations in increased nuchal translucency, the number is quite significant, like almost 1 in 10 fetuses which are having an increased nuchal translucency can have structural malformations which can be identified in around 41% in the first trimester, that is around 11 to 14 weeks, 31% by an early assessment around 16 to 18 weeks of gestation, and rest of the 27% we are able to diagnose at 20 to 22 weeks. So almost 97% of the abnormalities with increased nuchal translucency can be identified, and if the fetus is structurally normal at around 20 to 22 weeks scan, it has got a better outcome compared to the other subgroup. If we want to take an absolute value or number, anything above 99 centile will be a good number, for which we should do an ultrasound assessment to look for structural malformations, as the yield in this subgroup is like around 1 in 10 babies can have it. This is a new paper which was published in 2021, which looked at the fetuses with an CRL of less than 45 mm presenting with increased nuchal translucency. The nuchal translucency cutoff value which they took was more than 2.5 mm in this subgroup. The total number of fetuses which they evaluated were around 120, which is a good number, and then of which 46% were having chromosomal abnormalities, and out of this 46%, most of the fetuses were in NT more than 3.5 mm. If we look at the number of congenital abnormalities in this subgroup, 1/3 was noted in the NT subgroup of 2.5 to 3.4 mm, and almost 2/3 were noted in NT more than 3.5 mm. If we look at the KT abnormalities specifically, 2/3 were common chromosomal aneuploidies, that is the typical aneuploidies which we see, and out of this 18 trisomy was the commonest of the lot, and around 17% were structural malformations which were not identified by the common karyotyping analysis or the typical malformations. So if we perform an NIPT in a subgroup which becomes normal at 11 to 14 weeks, this subgroup of cases can be missed. That is, overall 17% can have atypical chromosomal abnormalities which may be missed at 11 to 14 weeks scan if we offer them NIPT. Single gene disorders can be noted in around 3.3%, which number is similar to the number which are done like in the previous subgroup of 11 to 14 weeks. So if we have to take that in the call while assessing the fetus structurally on scan and given the family and the significant pedigree details. If we look at the adverse outcome in this particular subgroup, the NT are of around 2.5 to 4.5 mm. Even if the NT became normal at 11 to 14 weeks of gestation, 24% had an adverse outcome. And with an increased NT which was noted at around 11 to 14 weeks, 78% of them had an adverse outcome. So if we are looking at the fetuses at less than 45 mm, the NT defined cutoff can be 2.5 mm if the nuchal edema is reviewed at 11 to 13 weeks of gestation. If it is resolved, then whether to perform diagnostic testing or do NIPT, it is better to do a diagnostic testing as we may have a better yield over it. If we have already noted that the NT was more than 99 centile or more than 3.5 mm, definitive testing is recommended. So if we take gestational age based cutoff for CRL, for 60 to 84 mm, 3 mm NT or 99 centile is 1. So we can offer, both are the same, so we can offer them testing at that particular gestational age. For 45 mm and 60 mm, between 2.5 to 3 mm, they are 99 centile, but if you offer testing for all, there may be more false positives. So it is preferable to use 3 mm as cutoff and offer them testing for the same. So to conclude, nuchal translucency more than 3.5 mm, we should definitely do chromosomal microarray. Depending on the size of the nuchal translucency and the fetal structural malformation, we can decide upon whole exome sequencing. If the nuchal translucency is between 3 to 3.4 mm, the karyotype analysis and the microarray can be offered. NIPT, we can miss some atypical chromosomal malformations, which we should take a look and only take it. Structural assessment should be done at 16 to 18 weeks of gestation, and if NT is more than 2.5 mm for less than 14 weeks, we should reassess and plan further. Thank you.
Thank you, Dr. Jyoti. I now invite our next speaker, Dr. Sineesh Kumar, to talk on the fetal nasal bone. It's a value or a pain. He's a chief consultant in fetal medicine and fetal therapy at ARMC Hospital. He's undergone special training in feto-maternal medicine, clinical genetics, fetal cardiology, and special fetal therapy in various renowned institutions. He has several national and international publications to his credit. Over to you, sir.
So, good morning, everyone. First of all, hearty congratulations to Team Mediscan for a successful planning, conduct, and execution of CUSP. We have been waiting for this since 4 years. And and I was also blessed to have the eternal teacher at my own place 3 weeks back, where he blessed our scientific meeting on fetal medicine and shared his knowledge with the obstetric and fetal medicine community there. Now, the salient point of my presentation today is that it is largely based on our own data. It is a study done by me, along with Dr. Manikandan and some of our other colleagues from our neighboring states, on a highly controversial topic about the second trimester nasal bone, how much it is significant for the prenatal detection or screening of Down syndrome. Now, this study was actually a part of my thesis for my MSc Clinical Genetics, which I did with the Chinese University of Hong Kong. And the first question they asked is, why the need for second trimester assessment for the nasal bone when you have a robust first trimester combined test for screening for Down syndrome? And I had to convince them that in India, we have a private healthcare model. The uptake of combined test is still very much limited. This point we all know. And therefore, an anomaly scan is almost always the scan that is done in all cases, and we have to rely on second trimester markers, of which nasal bone is considered to be the most strongest one. But this is an area with there are a lot of gray areas when we come to second trimester markers, and second trimester nasal bone is not an exception for the same. First of all, nasal bone hypoplasia, we might be overdoing it. There is no uniform criteria. In fact, I tell my juniors, nasal bone is the most democratic marker because everybody has an opinion about what constitutes a hypoplastic nasal bone. Some people follow 2.5, some follow 3, 5th, 2.5 centile. The practice hugely varies. But the important question is hypoplastic nasal bone significant when it is the only marker? So, at least after this presentation, I invite all of you to do an audit of your own data regarding the same. Now, you will argue that there is a very robust meta-analysis from the Fetal Medicine Foundation UK, which has put a isolated likelihood ratio in the range of 6 for an absent or hypoplastic nasal bone. So why the need for this study? Now, if you consider data, or these 10 studies, which are largely based on absent nasal bone, they more or less agree on the significance of a totally absent hypoplastic nasal bone. There is no controversy regarding the same. But when you further analyze the data, you see, you consider 12 studies, which have both taken into consideration the absent as well as hypoplastic nasal bone. You will find that the sensitivity and the positive likelihood ratio actually varies a lot. And the criteria that has been used to define hypoplastic nasal bone is also hugely different in these 12 studies. And the gray areas continue. Most of us follow the Sonic et al. Chart for labeling a fetal nasal bone as hypoplastic, and have a few very interesting data to present later on. And as of now, no nasal bone chart in our country has been validated for the prenatal detection of the Down syndrome. So the objective of study is both to create a nasal bone as well as do a validation in a cohort of Down syndrome fetuses which has been exclusively diagnosed by fetal medicine specialists. So we are sure that the nasal bone has been properly assessed in those cases. Now, the inclusion criteria, we had singleton pregnancies with good dating scans. We excluded multifetal pregnancies and pregnancies which had lethal anomalies in them. We had 2 data clusters in this. The first data cluster consisted of women who came to us at 11 to 13 plus 6 weeks gestation and who were randomized for a visit between 15 to 23 plus 6 weeks so that we could avoid selection bias. And we had a data cluster 2, which were the cases of Down syndrome that were diagnosed by us, the fetal medicine specialists, from all the participating institutions, where we could validate the nomogram that we have created. And for this, we use a methodology the original methodology that has been proposed by Altman and Chitty way back in 1994, which is the best technique or the best methodology to create fetal nasal bone nomogram. Because of lack of time, I'm not going to details of the same. And the nasal bone measurement was done by the standard technique as proposed by Sonic et al. Now, we compared the nasal bone nomogram chart that we had created with some of the 5 to 6 other studies that were already existing. And for the starters, or those who are not aware of this Z-score method, this is a semi-quantitative method to assess an estimate or a fetal biometric measurements from different studies. And to simplify, what this comparison showed is 3 charts performed almost same when with respect to the centiles. That was from our study, from Narayani et al. From the Pratima BFMC group, and from the Akshata Sharma Delhi group. Whereas the other charts, which didn't have the standard method or methodology to create them, had a lot of huge variations. Similarly, we compared our nasal bone chart with the same method with the international charts, and no surprises here. Our nasal bone is the shortest. So if you see here, that line represents the 5th centile for 15 to 24 weeks of gestation, and it is the shortest of all the charts that has been used in this study. Now, the interesting part of our study is the 60 cases of Down syndrome that we had during the last 4 years. And since our study was limited to the second trimester, we took the 42 cases of second trimester nasal bone, and 60% of that had absent nasal bone, whereas nearly 40% had a measurable nasal bone. I'm not saying it is hyperplastic or it is normal, but around 40% cases had a measurable nasal bone, and no surprises there, none of them were isolated. That is to say, the 40% cases of prenatally diagnosed Down syndrome cases which had a measurable nasal bone, they always had some additional abnormality. Now, regarding of those 40 cases, when we compared the nasal bone centiles from different charts within our country, as well as from Sonic et al. And Cicero, we found that there is huge variation in labeling those nasal bones as short or hyperplastic if we use 5th centile as a criteria. So you can see here, this is the 5th centile from our chart, and all those marked are the nasal bones. Of the 17 cases which had a measurable nasal bone, only few would have been labeled as less than 5th if we use the Indian charts. Now, we did a performance evaluation, that is, we assessed the screening parameters using different cutoffs. So we used a cutoff of 3 mm, 2.5 mm, and less than 5th centile. And when we compared this, we found that the detection rate was maximum when we used a cutoff of 2.5 millimeters. Also, the positive likelihood ratio was also highest when a cutoff of 2.5 mm was used. Now, this is compared to the meta-analysis from FMF, which had a much higher detection rate, but positive likelihood ratio was less than the cutoff of 2.5 mm, which was analyzed in the study. Now, there are potential cost implications when we use different cutoff. For example, the 300 normal cases, that is the 300 cases which were used for creating the nasal bone nomogram, and if we applied the cutoff from our study, Sharma et al. And Sonic et al., we find that the hypoplastic nasal bones in our study as well as those from Sharma et al. Was almost similar, but almost 37% of euploid fetuses would be labeled as potentially screen positive for Down syndrome if we use the most commonly used Caucasian chart from Sonic et al. Now, if we assume that about 10,000 rupees is spent for each amniocentesis, around 11 lakhs would have been spent if we had performed amniocentesis for all these cases, compared to nearly 1 lakh. So what this potentially shows is, in a private healthcare model like ours, the different cutoffs that we use can have huge cost implications for the community. So what are the important practice messages to be taken? Now, just like the fetal biometric parameters, we know the growth charts, right? How much they vary for the fetal biometric parameters. The nasal bone is, at the end of the day, also an anthropometric variable, and hence it's prone to ethnic variation. Multiple studies have found huge differences in the nasal bone between different ethnic communities. And when I compared our nasal bone with the Asian charts as well as the Caucasian chart, it was what we observed is that our nasal bone is the shortest. In fact, it is shorter than even the so-called Oriental population, which is supposed to have a small nasal bone. And it was only the Korean charts where some of the centiles, some of the fifth centiles for certain gestational ages were more than us. But for all the gestational age between 15 to 24 weeks, our nasal bone was the shortest when compared to Asian and non-Asian communities, as well as the Caucasian chart from Sonic et al. The difference between the nasal bone is not limited to the ethnic variations. It is also affected by what methodology is used, like the technique to measure the nasal bone, the angle, zoom, where the caliper is placed, whether a mean value is taken or the largest value is taken, whether the chart that we are using had a retrospective data or a prospective data, and there is huge intra-operator as well as inter-operator variation in measuring the nasal bone length. For example, this is a case of nasal bone, absent nasal bone, which was diagnosed from outside to have a normal nasal bone, because as you can see, that's a parasag plane on the left side. And when the angle was corrected, we found that the nasal bone was absent in this case, and we did a amniocentesis, the fetus was found to be euploid. Similarly, speckle reduction imaging helps us to identify the ends of the nasal bone more accurately and helps us to measure the nasal bone length with greater accuracy. 3D and 2D don't differ much in assessing the fetal nasal bone length, but this study from Papazzo-Minao et al. Found that in assessing the bilateral nasal bone, taking a 3D and assessing, doing a navigation would probably helpful. Apart from that, 2D or 3D techniques don't have much difference in assessing nasal bone length. So what are our counterparts from other countries doing regarding nasal bone length? So for example, in NHS, a combined test is uniformly offered to all women, history, NT, and 2 markers. Cutoff of 150 is used if it is high risk, CVS or amniocentesis. If it is low risk, anatomy scan. There is no scan in between. If there is an absent or a hyperplastic nasal bone, straight away the woman is assessed for an anatomy scan. If nasal bone is absent or hyperplastic, they do a recalculation and then offer an invasive procedure if required. The cutoff that they use is 4 millimeter. Almost similar protocol is used by the Fetal Medicine Barcelona also, though they have what is called as an intermediate risk, where they offer a NIPT. First, they offer additional markers such as a ductus venosus, and if it is screened in the intermediate range, they offer an NIPT, but rest of the protocol is same. Now, if you compare data from first trimester, we will almost get back with the same figures. So, of all the studies that have been done in this field, the one from Manikandan et al. Showed that I think the study had about 27,000 sizes of 27,000 sample size, and they found that of the fetuses who were proven to have Down syndrome, in none of them, unossified nasal bone was an isolated marker. In none of them, isolated nasal bone was an isolated marker. So let us keep things simple. First trimester, nasal combined test with 2 markers to all. Nasal bone present, absent or uncertain, but whatever it is, it should be included in the risk assessment. If the woman is low risk, she can proceed to an anatomy scan. The middle scan between 6 to 17 weeks can be avoided. It sounds reassuring, but the yield is very low. Also, waiting till anatomy scan allows more time for bone ossification, and with the prolongation of the MTP window to 24 weeks, now there is no difference in further management. And in the second trimester, you have to assess the nasal bone length. These points all of us know. So if we have an absent or hyperplastic nasal bone in first trimester, what most of the studies and data, including from our own, shows that we can proceed with combined test using 2 markers. And in our country, as we know, 250 is used as a cutoff. Now, the cutoff of 250 is so high that it is not 90%. The sensitivity with this protocol would be somewhere between 95 to 98% if we just use a combined test 2 markers, right? And if women are found to be low risk, an anatomy scan where we can assess for the nasal bone length. If again the nasal bone length is short, we can recalculate the risk where the combined test risk is taken as a background risk, not the a priori risk of the woman. Similarly, if you see an absent or hyperplastic nasal bone in the second trimester, first thing that you should look at is there a good quality first trimester screening performed in this case? Has this screening been done as per the FMF guidelines, as per FMF accredited softwares and algorithm? Is the lab accredited for the same? If there is no good first trimester screening, one can proceed with an invasive test. But if there is a good quality FTS, it is high risk, obviously invasive test. But if it is low risk, one can reassess the risk using the second trimester nasal bone length. But having said all this, the important area is how to define the second trimester hypoplasia, 3 mm, 2.5 mm, 2.5 centile or 5th centile. So, coming to my topic, the title was nasal bone value or pain. The important thing is nasal bone is definitely of value when it has no value. That is, if nasal bone is absent, definitely there is a high risk for Down syndrome. One can go ahead with the invasive test. But the pain is to find a uniform definition for a hypoplastic nasal bone. And the only way we can achieve this is by collating our data. And we, along with my co-authors, Dr. Manikandan, would be soon sharing a platform where all of you can share your own data about the Down syndrome cases, the markers in them, so that we can come up with a huge data and we can standardize the practice of usage of second trimester markers for the Indian population. With this, I conclude my presentation. Thank you so much for the patient listening.
Thank you very much, Dr. Sinish Kumar, for highlighting the ethnic differences in nasal bone and for that clear presentation. Dear delegates, as you are aware, we have a grand sono quiz in the evening. Budding sonologists who wish to participate can please drop in your names at the Medialogic stall before lunch. The only criteria is that you should have 3 or less than 3 years of experience in ultrasound. Next, we go on to the next presentation. I call upon Dr. Gauri Shankar Paramasivam for his talk on emerging fetal extremities in the first trimester, grabbing the opportunity. Dr. Gauri Shankar is a consultant in fetal medicine and interventional fetology and is the director of Chennai Fetal Care. He is the ISWAG ambassador to India. He is an honorary lecturer at the Imperial College London. He is passionate about fetal medicine and is a wonderful teacher. Over to you, sir.
Okay, pa. Okay, pa. Thank you. அனைவருக்கும் வணக்கம் and a very good morning to all of you. Dear colleagues, friends, ladies and gentlemen, it's a great pleasure to be part of this wonderful Congress, and I thank Suresh sir and the organizing team for giving me this opportunity to share my views. For the next 15 odd minutes, I'll be talking to you about imaging fetal extremities in the first trimester, how to grab the opportunity. We all should remember this gentleman, Professor Ian Donald, who in his 1950s invented this little toy which has transformed the way we practice modern obstetrics today. And we have gone very far from 1957 to 2022. So much so, we are able to identify abnormalities in the first trimester. So we don't say it's just an NT scan, although it was designed to start in the beginning. We call it as a first trimester screening because it gives you a lot of information about how this pregnancy is going to proceed in the next 7 to 8 months. And I'm just going to limit myself to looking at the fetal extremities in the first trimester. So, first trimester screening is a detailed scan and it's not a dating scan. That's the first message. So what are the objectives of performing a first trimester scan? We all need to ensure that we perform a uniformly agreed program to an agreed level of quality, achieve competence in performing ultrasound to the international standards. We're able to identify normal and abnormal fetuses. And with that, we can decide whether these abnormalities are life-changing events or they can be correctable. And if they are correctable, you always refer them to a higher center and then they take it further from there. So when Sir asked me to talk about limb defects, I was just looking at the literature, and this was the paper which we published in 2010, spanning data of over 10 years before that. So it's only 9 cases, so you can see how rare it is. And the good thing we saw is all these were diagnosed at the second trimester. That was because the expertise and availability was not widely available. This I'm talking in the UK. But then, as technology has moved forward and the learning curve has improved significantly, we are now able to identify much of these abnormalities at an early gestation. So much so, Professor Nicolaides decided, or he wrote his paper of inverting the pyramid of care, saying that much more emphasis should be made on the first trimester than the conventional second and third trimester assessment, so that we can see a lot of things in the first trimester. In fact, first trimester scan forms a bedrock of modern obstetric care. So, how good is first trimester for screening fetal anomalies? If you look at this paper, which clearly says that there is 13% of all anomalies can be detected, of which the majority are lethal, about 90%, so that you can exclude a wide range of lethal abnormalities in the first trimester, of which the majority are chromosomal as well, compared to the second trimester. So we all can understand that first trimester is an important opportunity for us to look at the window to the womb. And this systematic review of first trimester screening also supports the data showing that around 60% can be diagnosed in first trimester, and this detection increases if you have a high-risk fetus. If there is an NTS more than 3.5, then this baby is going to have additional problems as well compared to the low-risk population. So what are the current recommendations which we have for fetal limbs? And these are the various bodies which are suggested these follow recommendations. They are essential ones. We have to look for the presence of upper and lower limbs, measure the femur diaphysis, look for the metacarpals and the metatarsals. Digit counts are not really included in a screening for first trimester or even the second trimester for that matter. And in fact, some, apart from ISWOG, doesn't even look at the fetal movements. So that is the recommendations which we have at the point. So most of you will be knowing him, and that's the Bible. And this book is available free online, as well as there are internet courses you can learn, and you can update your skills for all the beginners who want to specialize in fetal medicine. And I was lucky to be part of the program in 2004 to 2006. Being an ambassador to ISWOG to India, ISWOG has also performed a practice guidelines to do an effective first trimester ultrasound scan. And I'm very proud to say that Suresh sir is one of the contributing authors for this first trimester fetal ultrasound scan. And in that, when you look at the limbs, what it says, it looks that we have to look at 4 limbs, each with 3 segments, and you look at hands and feet with normal orientation. So that's what is recommended by the ISWOG as well. So to know an anomaly better, it's always important to understand the embryology and genetics. We all know that this appendicular and axial skeleton follow a programmed pattern of endochondral ossification. And this position, the growth, and the pattern are all genetically regulated. So it's just not as simple as we think. Everything has got a process. And we all know from early ultrasound that limb buds develop as early as 4th week, and upper limbs take precedent over lower limbs. The ossification appears by 8 weeks and is usually completed by 12 to 16 weeks. That's the basis of limb development. So what we know about limb anomalies? The prevalence is not very common. It's 6 per 10,000 live births. It can be isolated or it can be multifactorial in etiology. We have observed there is a high incidence of upper limb abnormalities compared to lower limbs, and it can either be a part of a multiple anomalies complex. So although it's very rare, but when it is there, it is usually not an isolated one. It can be associated with other problems as well. If you look at the etiological classification, again, it can be chromosomal, genetic, part of the multiple anomalies complex. It can be due to vascular insult, maternal diseases, and teratogenic exposure. Again, we can have another pathological classification where it looks like how it is formed, whether there's phocomelia, talipes due to deformation, or disruption due to amniotic band syndrome. So whatever it is, we have to classify and categorize them accordingly. So what are the commonly detectable limb anomalies? We know that the common things are, if you don't see them, they are absent, phocomelia, aplasia, there is radial or ulnar limb hyperplasia, and transverse limb defect. These are the most common which we encounter in clinical practice. So what I do in my clinical practice, I have a rule of 6. First of all, you find out whether the limbs are present or absent. And if they are present, you assess the morphology of that. Then you look at the size, whether they are small or long. then you look how they are moving, and then you see whether they are aligned normally. And lastly, look at the numbers of the digits. This is what I do in my routine practice, and it's easy for you to do it in a matter of a couple of minutes. You can finish the whole survey. So you have to put your hats on to look, because the more you know, the more you see. So all I do is you have to make sure that you have a systematic and a sequential approach. Always follow both limbs together, and you follow proximal to distal. And I always believe that transabdominal and transvaginal scan, it's important for us to look for these limbs together. So these are the small slides. I can see here, it's also important the gestation as well, because if you look at 11 weeks, we can just barely see them, but as the baby gets bigger, it gets better. So you can see the phalanges clearly at 13 weeks, and so much so for the lower limbs as well. Some people use 3D if you're having problems, especially that's good for transverse limb defects. That gives you a better idea and understanding. Okay. So it's important when you look for the baby, you look at the survey and you see how this baby is there. You can look at the humerus, the radius ulna, and the digits very clearly. And also, by looking at the limbs, as I said earlier, they are never isolated. So you always have to look for much in detail, because there will be hidden clues. If you see a limb abnormality, you should look at the skull, look for the calvarium calcification, ossification, look for the spine, look for the chest, because it's all going to help you if there is an abnormality. So these are some of the slides which I use. So we can use as a survey. So once you finish your scan, you can run through a survey. You can see here, I'm looking at both limbs together. You can see it here, and then you can clearly see that you can see both the humerus, radius ulna, the limbs they are all oriented very well. So it's important that by end of this 2 minutes, you can clearly say that, okay, this baby is okay. And similarly, a sagittal view will also help us to look. And this, you can see here, I'm looking at the movements of the limbs, because that's important. I'll just tell you how these are all important in my clinical cases later on. So, looking at the performance of screening for fetal limb abnormalities at first trimester, how good it is. So this was a study published by the Chinese university, and they looked at around 10,000 babies over a period of 4 years. And what they found was they can find out some abnormalities for 100%, and that's absent radius and club hand, transverse limb defects for camellia, and lethal skeletal dysplasias as well. But you looking at the digits, it drops to really half. So that again, it's down to individual expertise, and the more you look, the more you see. And clubfoot is the same, it drops to 57%. I will tell you why. And this is another article which also looked at a single center experience over 20 years. And what they found was, if you look at the polydactyly, the detection was only 14%, jumps to 88%, 85% in the second trimester. So, summarizing, you can see from this slide that majority of the major fetal limb abnormalities are detected in the first trimester. And coming to our very own Professor Nicolaides study, which looked at 100,000 babies, and this was a study published in 2019. And if you look at this, it clearly shows you the major abnormalities are detectable, always detectable, compared to the digits and the talipes. You can see talipes, how poor it's been the first trimester. So certain things you need to stop overcalling. That's the message I'm going to give you here. Right. So the proof of the pudding is in the eating. So we'll have a look at some clinical cases and see how much have you absorbed. So this is a 32-year-old lady, para 2, non-consanguineous marriage for first trimester screening. And this is a 3D construction, and you can clearly see this limb is abnormal. There is a transverse limb defect. And when you look at transverse limb defect, this is the most common thing which you encounter in clinical practice. And this is 6 per 1,000 births. It can be a complete absence called amelia or partial absence. It's usually multifactorial in etiology, but bear in mind it can be isolated or part of a multiple anomalies complex. So look at the etiology, the vascular disruption is the most common thing, and these cases have been associated with the early chorionic villus sampling. That's why we don't do before 10 weeks. Genetic causes are the next one. It can be associated with teratogenicity, as studies have shown that misoprostol have been associated with increased risk of limb defects. So when you have a lady who has got a failed MTOP, comes for a first trimester screening, make sure you look at the limbs carefully. And moving on to case 2, 25 years old Asian, last childbirth 5 years of age, natural conception. Oops, the diagnosis came early, sorry. But then still you can have a look. You can see the limbs are definitely abnormal. There is bilateral radial club hand. And when you see radial club hands, you have a wide range of differential diagnosis. It can be chromosomal, it can be genetic, it can be isolated, but it's morely multiple anomalies complex. And then, if you look at it, as I said, the diagnosis obviously on the board, it was trisomy 18. That's the most common thing because you had a small exomphalus there. It can be part of Vactal anomaly, and it can be a part of TAR syndrome or Fanconi's anemia. So, you know, the whole point is this limbs give you a clue how to take it forward. So, you look for more, that's why I said when you do a survey, you look at many things. You look at the bones, you look at the skull, everything, so that you can come to reasonable diagnosis. That moves to case 3, 32 years for first trimester screening again. And I think the clips are not working, so for some reason. So, yes. So you can see here, I was talking about motion. So you can see these limbs are just stick together and they're moving together. So this is diagnosis of serinomelia. So I'll take a couple of minutes more, thank you. And again, you can classify them according to the type of serinomelia. Case 4, again, raised nuchal translucency, and the kidneys are echogenic, and there is polydactyly here. So put everything together, that can give a diagnosis, and then this turned out to be a trisomy 13 baby. So polydactyly, again, it's more common in the post-axial type compared to the pre-axial, usually part of trisomy 13 or Meckel-Gruber syndrome. But again, make sure that when you deal with Afro-Caribbean population, it's much more common as well. So always ask the history. Case 5, last case. You can see the skull bones very well, but the calvaria is not very well ossified. And this is a case of skeletal dysplasia. For some reason, I'm sorry, the clips are not working. Yeah, it's working. You can see the limbs are very short. And this is a case of a lethal skeletal dysplasia. Right. Again, look at the chest, look at the lungs, and look at the heart. And this is a case of Ellis-Van-Creveld syndrome, where you can see polydactyly, short ribs, and then heart abnormalities. So the talipes, again, can be reported first trimester. It can be isolated. It can look for additional abnormalities. Majority are positional due to non-ossification of ankle, so beware. So there is controversial data. Sometimes they say it's diagnosed, sometimes they don't. And all the previous papers which I showed you earlier have failed to detect 100% of them. So conclusions, you should not do a first trimester diagnosis if it's associated, if it's an isolated finding, and it has to be reviewed at 16 weeks. So take-home messages, limb abnormalities can be isolated or part of a multiple anomalies complex. The prognosis depends on the underlying etiology. Always have a systematic and sequential approach, improves detection. Early detection results in counseling and further management. Say, don't overcall, practice make perfect. So with this, I've modified the pyramid. So I said we have to emphasize, make sure the basement is very good. The 12-week scan, put more emphasis on it so that you diagnose many things clearly, so the rest of the journey is breeze for you as well as for the patient. And I thank you all for the kind attention.
Thank you, sir. Now let's move on to our next session on how to and what if. We have Dr. Jitta to talk on how to, the cerebellar vermis, our fetal medicine fellow, Mediscan, and Dr. Raghav on what if abnormal vermis, fetal medicine fellow, Mediscan.
Pointers. Pointer. Sir, excuse me. Next slide is. CV. Slide open. Okay. A very good morning to one and all. Today, in the first of How To series, let us try to understand and image normal vermis. The vermis is the unpaired median portion of the cerebellum that connects the two hemispheres. Divided into a smaller superior lobe and a larger inferior lobe by the primary fissure, which develops by 7 to 8 weeks. It is separated into 9 lobules, with the culmens superiorly and the uvula inferiorly. Fully formed by the 15th week, the vermis grows inferiorly and laterally to cover the roof of the fourth ventricle. The apparent closure of the fourth ventricle by the inferior vermis completes by around 19 to 20 weeks. The primary fissure, though develops by 7 to 8 weeks, is imaged only at later gestations, better so with MRI. Identifying vermis in ultrasound is done by the relational anatomy. In the axial transcerebellar plane, the vermis is visualized as an echogenic structure wedged between the fourth ventricle anteriorly and the cisterna magna posteriorly. Occasionally, the anechoic cisterna magna contains septae, which is nothing but the fenestrated remnant of the fenestrated Blake's pouch. In the mid-sagittal section, vermis is imaged below the tentorium, marked anteriorly by the fastigial point of the fourth ventricle. In the mid-sagittal section, attention should be given to the ovoid pontine belly of the brainstem seen anteriorly, as it is flattened out in certain vermian lesions. The T-shaped choroid plexus of the fourth ventricle are 2 in number, the right and the left. The 2 vertical limbs seen near the midline and 2 horizontal limbs extending to the lateral apertures. In the mid-sagittal section, it is imaged as an echogenic structure inferior to the vermis, and identifying the location of the choroid plexus might give clues to accurate diagnosis of vermian abnormalities. The vermian morphology is well appreciated in ultrasound from 19 to 20 weeks onwards. The size of the vermis increases with gestation, as seen in the ultrasound images depicted below. Sometimes in the mid-sagittal section, we get confused between the vermis and the hemispheres. The classical differentiating features is the increased echogenicity of the vermis due to the deep vermian fissures and the accompanying blood vessels, which give it a classical spoked wheel appearance in the mid-trimester. The superficial cerebellar foliae make the hemispheres hypoechoic and smooth in appearance. The shape and morphology of the fourth ventricle with its fastigial point is characteristic to vermis. Technique of imaging vermis. From the standard transthalamic plane, the probe is rotated towards the occiput to image the transcerebellar plane. Extended imaging in the mid-sagittal section is done by sliding the probe laterally and angulating it through 90 degrees with slight rotation. Indications of extended imaging are smaller transcerebellar diameter in the axial plane, failure to image echogenic vermis between the cerebellar hemispheres, and a posterior fossa fluid collection. 3D ultrasound can be used to reconstruct the mid-sagittal section by acquiring a volume containing vermis in the axial plane. With the 3D multiplanar technique and the pointer reference dot placed at the plane A on the vermis, we can get the corresponding mid-sagittal plane in the plane C. The choroid plexus of fourth ventricle is imaged in the coronal section, and it gives clues to diagnosing and differentiating between various vermian abnormalities. Using 3D multiplanar technique with the volume acquired in the mid-sagittal section and the reference dot placed on the choroid plexus, we can get the corresponding coronal section in the B plane. Objective assessment of the vermis is done by measuring the supro-inferior length from the most cranial portion of the culmen to the most caudal portion of the uvula. Reference charts are available for anteroposterior diameter, superinferior diameter, and circumference, which are seen to increase with gestation. The angle subtended between the lines drawn tangential to the anterior border of the vermis and the posterior border of the brainstem form the brainstem vermian angle, which remains constant throughout pregnancy, normal being less than 18 degrees. There are pitfalls in imaging the vermis. Even at 7.5 weeks, around 6% of normal fetuses are shown to have open fourth ventricle. Thus, vermian agenesis should not be diagnosed at less than 18 weeks. At 20 to 21 weeks also, a lower axial plane, or the one that is angled too steeply towards the coronal plane, may erroneously lead to the false diagnosis of vermian defect, as demonstrated in the video clip. This is because of the length discrepancy between the vermis and the cerebellar hemispheres. Thank you.
In next couple of minutes, we'll run through what if cerebellar vermis is abnormal. If cerebellar vermis is not seen in the axial plane during routine target scan, the differentials could be posterior fossa fluid collection, Blake's pouch cyst, inferior vermian hypoplasia, Dandy-Walker malformation. The rarer ones includes Joubert syndrome, Romben cephalosynapsis, global cerebellar hypoplasia, pontine tegmental cap dysplasia, and pontocerebellar hypoplasia. In Blake's pouch cyst, we can see open fourth ventricle in transcerebellar plane. In sagittal plane, we can see the vermis is elevated, resulting in an increased brainstem vermian angle. The shape and the size of the vermis is normal for the period of gestation. As the gestation advances, the Blake's pouch cyst can regress. If it is an isolated finding, the prognosis is favorable and there is no increased risk of recurrence. Coming to Dandy-Walker malformation, in axial plane, we can see the cerebellar hemispheres are splayed by the large midline cyst. Same is seen in the autopsy picture. We can see the cerebellar hemisphere splayed and compressed. In sagittal plane, we can see the elevation of the vermis, which is flattened and compressed, and increased brainstem vermian angle around 90 degrees. The tentorium is elevated by the posterior fossa expansion. It is associated with cranial and extracranial anomalies and has a poor prognosis. In between the spectrum of Blake's pouch cyst and Dandy-Walker malformation is the inferior vermian hypoplasia, characterized by open fourth ventricle, small and misshapen vermis. The point to be noted is that the vestigial point is lost in the anatomy, the brainstem vermian angle is increased, and the prognosis is equivocal. Summarizing all three, Blake's pouch cyst, the vermis is normal with mild to moderate upward rotation. In inferior vermian hypoplasia, the normal shape is lost with increased brainstem vermian angle. In Dandy-Walker malformation, there may be agenesis or hypoplasia of the vermis with compressed and flattened anatomy with elevated tentorium. Certain syndromes are associated with inferior vermian hypoplasia. For example, Joubert syndrome. It is characterized by abnormal shape of the fourth ventricle and the parallel superior cerebellar peduncle, resulting in characteristic molar tooth appearance. Same is depicted in the autopsy specimen. It is an autosomal recessive ciliopathy with a poor prognosis. It is associated with renal, hepatic, and polydactyly. In Romben cephalosynapsis, there is dorsal fusion of the cerebellar hemisphere, resulting in a typical convexity. It has a poor prognosis, and same is seen in the autopsy specimen. The cerebellar foliae are seen continuous from one hemisphere to the another. No vermis is identified. Flattening of pons is seen in certain anomalies like pontine tegmental cap dysplasia and pontocerebellar hypoplasia. It is a rare hindbrain malformation with poor prognosis. It cannot be detected on USG antenatally, but it can be detected on prenatal MRI, which is characterized by flattened ventral pons. How to improve accuracy? By 3D imaging. Caution is warranted in diagnosing vermian anomalies too early in the gestation because of the incomplete development of the cerebellar vermis. Identification of pontine hypoplasia because it alters the prognosis. And when there is ambiguity in diagnosis, a follow-up scan later or fetal MRI after 26 weeks may be advised. Summarizing everything, if cerebellar vermis is not imaged in standard transaxial plane, we do vermian imaging in the sagittal plane. If it is a normal size and shape of the vermis with mild to moderate upward rotation, it is Blake's pouch cyst. If there is abnormal size and shape, we should look at the tentorium level. If it is elevated, it is Dandy-Walker malformation. If the tentorial level is normal, the differentials could be inferior vermian hypoplasia. If there is abnormal fourth ventricle, it could be Joubert syndrome. Global cerebellar hypoplasia. Flattening of pons is seen in pontocerebellar hypoplasia, pontine tegmental cap dysplasia. And if it is not imaged in axial plane, you will see fused hypoplastic cerebellar hemisphere with dorsal convexity. It is rhomboencephalosynapses. Thank you.
Thank you, Dr. Jitta and Dr. Raghav, for highlighting the pitfalls in imaging the cerebellum and how to overcome them. Next is our keynote address. The first trimester scan, ensuring an optimal value, by Dr. John Hyatt. I invite Dr. Suresh to introduce the speaker.
Good morning. It's an absolute pleasure to invite Professor John Hyatt to give the keynote address today. He's a clinical professor and head of high-risk obstetrics at the Liverpool Hospital, Western Sydney University, and also a clinical professor in obstetrics and gynecology and neonatology at the Central Clinical School, Sydney. More than that, John has been a pioneer in first trimester screening, and one of his earliest papers, the 10 to 14 week scan, increased nuchal translucency and cardiac defects, literally set the tone that we should be doing fetal echocardiography in the first trimester to detect cardiac defects. He has enormous number of publications to his credit, and he also has a passion for setting screening, always thinking about the population as such, how it can be impacted with screening, and is in the process of instituting screening principles in Australia at this point of time. So John, thank you for participating. We had an excellent session yesterday, and he continues to inspire us all the time. John, the floor is yours.
Thank you. Thank you. That's great. Okay. Good morning, everybody. I'm going to talk about the value of a detailed first trimester scan. I'm actually giving a slightly defensive talk because the first trimester scan is endangered in Australia, and it's endangered because of a test called NIPT. So what I wanted to look at was the potential integration of these two modalities, a genomic test with an ultrasound scan. But let's just take a step back and consider what we should be trying to achieve when we're screening in the first trimester of pregnancy. This is Australian data, so Indian data may look a little different. But essentially, these are the nominated causes of perinatal death, so that's stillbirth or neonatal death in our population. And you can see that the commonest cause of death is actually related to congenital abnormality. That's the column on the left-hand side. I could actually split that column in two. Roughly half of those are structural anomalies, and roughly half are related to aneuploidy. One of the next tallest columns, the second from the left, is related to preterm birth. It's a very significant problem in our population. It's also a very expensive population problem, which means there's potential to shift money by reducing rates of preterm birth into effective screening programs. Preterm birth essentially falls into three categories: iatrogenic delivery, often related to preeclampsia or IUGR, or alternatively spontaneous onset preterm labor, either by itself or following rupture of membranes. let's go and look a little bit at chromosomal abnormality. So this is a paper published after the development of chromosomal microarrays that reports the range of different forms of chromosomal abnormality that you see in a population. It's an American-based study in 5,000 women. The take-home message is that trisomy 21 represents about 30% of all chromosomal abnormalities. And if you then include trisomies 18 and 13, you have about 50% of chromosomal abnormalities. So in other words, the current screening paradigm that we have, giving risks for trisomies 21, 18, and 13, really is looking for 50% of all potential chromosomal abnormalities. And certainly in an Australian population, there is a disparity in the contextual understanding of what we are screening for. So most clinicians will say to a patient, we have screened you for trisomies 21, 13, and 18. Most patients will interpret that as, we have been screened for chromosomal abnormality. And they are two very different statements. Obviously, the process of aneuploidy screening has changed markedly over the last 50 years. We used to screen purely on the basis of maternal age. That has a lot of value as a screening test. Women know how old they are. It's a simple question. You can use a dichotomous cutoff to define women as either high or low risk. The problem in our population is in the 1970s, about 5% of women were over the age of 35, which was the arbitrary cutoff used to define a high-risk group. And now, in our population, about 25% of our population will be over the age of 35 in a pregnancy. So we'll have a 5-fold increase in the proportion of women we would do a procedure on. You can see that we then go through a process of having second trimester, scan detail, then we move to the first trimester. We talk about the combined first trimester tests, so we've integrated ultrasound with biochemistry. And then we have the potential to add additional first trimester markers. The main value of those additional first trimester markers, like the nasal bone, was putting downward pressure on the screen positive or the false positive rate of screening. But actually, we now have a better means of doing that, a test called NIPT. So this is my first trimester fetus. A picture tells 1,000 words. Immediately, you can see that this fetus has increased nuchal translucency. You can also see that it has an absent nasal bone. So immediately, you know the risk for aneuploidy, specifically for Down syndrome in this fetus, is very high. We can place that in a screening algorithm, as you've already heard, I think, this morning. That combines that with the biochemistry. We know that serum HCG is increased in Down pregnancies, serum PAP-A is decreased. And so when we combine all of these things together, we actually have a very effective screening test. On the right-hand side, you can see that for a screen positive rate of 5%, so identifying 1 in 20 women in the population as being as high risk, we would identify 90% of Down babies. So then we come along with this disruptive genomic technology. It's interesting to me because at the moment the technology is really looking for a limited range of conditions, chromosomal abnormality. Ultrasound looked for a far wider range of conditions. Yet in Australian practice, we're now sometimes replacing an ultrasound scan with a genomic test. We're moving away from looking at the phenotype to looking at the genotype. And I don't necessarily think that's a good thing. NIPT is highly effective. If you're allowed to ignore the cases where you can't get a test result, then you can demonstrate that you will have over a 99% detection rate for Downs, and you'll have a very, very low false positive rate. So this test is almost generational improvement in terms of screening efficacy compared to what we've been doing. But in Australia, it's expensive. The minimum cost in Australia is probably $350 to $400. And if you look at that in the context of public health program, where everybody has had first trimester screening, and where that means that the background prevalence of Down syndrome in our population has dropped to about 1 in 5,000 pregnancies, then spending $400 on each pregnancy to detect one additional Downs case in 5,000 pregnancies is not cost effective. And I can't see this test ever being incorporated into our Medicare schedule because it's not cost effective. And that means it's offered to people who can afford it. And that means that the whole process of screening that we have is really been falling apart. And that means that people who are disenfranchised and can't access this expensive test potentially no longer have access to the baseline test that we've been offering them for the last 20 years. Some more facts about NIPT. This is NIPT reported in one of the biggest series, Mayor and Norton, New England Journal. 3% of cases you can't actually report the NIPT test, and the rate of aneuploidy in that cohort was 1 in 38. Now, in my practice, 1 in 38 is a high risk, and you would get an invasive test. So if we had been made to report these cases in this population screening series, either the detection rate for Downs was not 100%, it was in fact only 92%, or alternatively, the false positive rate wasn't 0.1%, it was in fact 3.1%. And when you look at the impact of NIPT on a population level like that, it actually looks no different to combined first trimester screening. If we're going to use NIPT, it's important we take advantage of the potential added benefits. So that means that if we use a SNP-based process, we can effectively look for things like chorionicity in twins. And it also means that we can extend the number of forms of aneuploidy that we're screening for, look at sex chromosome aneuploidy, look at common microdeletions. So let me just say a few words on those issues. Chorionicity is probably the single most important feature in twin pregnancies. If you ask me what are the 3 most important things you should look at in a twin pregnancy on a 12-week scan, I would say it's chorionicity followed by chorionicity followed by chorionicity. Because if you are monochorionic, you have a 6-fold increased risk of miscarriage, twice the rate of perinatal death, fetal growth restriction, and preterm delivery. These pregnancies need to be identified and need higher levels of surveillance. The best time to determine chorionicity is on a 12-week scan. The top video clip shows the lambda sign that you get when 2 placentas abut against each other in a dichorionic twin pregnancy. And down the bottom, you can see the monochorionic twin pregnancy has this thin T-like insertion of the membrane into the single placenta. In the context of chromosomal abnormalities, once you have 2 babies there, the relative risk that one or the other of those babies will have a chromosomal abnormality goes up. So if in a population you thought that the threshold for risk assessment was related to a 35-year-old, by the time you apply that to a twin population, it's more like a 31-year-old. So inherently, these pregnancies have higher levels of risk. There are 3 studies that have looked at combined first trimester screening in large populations. They show that it works, but it's not as effective as it is in singletons. So there's certainly potential value here to use an NIPT test. We also know that we have problems screening in twins because some of the markers that we use on ultrasound are also abnormal in twin-twin transfusion syndrome. So both nuchal translucency and the ductus venosus could be abnormal in that condition. There is data to suggest that using NIPT in twins is very effective. But what I want to do is just take a sort of slightly sideways tour to this. So most NIPT tests work by counting fragments of DNA. And on the left-hand side, you can see that the proportion of fetal fraction, which is the white bars, compared to the maternal fraction, which is the yellow bars, is relatively small. And so when you count all the fragments, a subtle difference in numbers of fragments will be found if you have trisomy 21 compared to normal chromosome complement. And because that difference is quite subtle and quite small, you actually have to count millions and millions and millions of fragments to have the resolution to be able to tell the difference. And that's perhaps best illustrated on the bottom right-hand side, where the lower your fetal fraction is on the x-axis, the less able you are to discriminate your case of Downs from a general population. Now, if you go to the graph on the right-hand side, the problem with twins is that when you talk about fetal fraction using a counting test, you can't actually distinguish between the two babies. And this just shows you that for a significant proportion of twin pregnancies, either one twin or the other twin will in fact have a low fetal fraction. So I would advocate that you need to do a NIPT test that actually tells you what the fetal fraction is for both twins, so it needs to be a SNP-based test if you want to use this as a screening tool in twins. And just to show you why, if you take the table, a low fetal fraction, here we've got 4% in the top line, is associated with a very low negative likelihood ratio. So in other words, if you were a 40-year-old coming along with a 1 in 40 risk of Downs based on your age, and you had an NIPT test with a fetal fraction of 4%, your risk reduction is only to 1 in 120. It's not as significant as is generally reported. So if we're going to screen using NIPT, what else should we add? This is the relative prevalence of different trisomies. In the middle, you can also see the prevalence of the abnormality of deletion 22q11. It's not age-related, so in fact for young women, they're at much more significant risk of this condition than they are of the others. Some of the screening tests commercially are trying to take advantage of the way their technology works. So they're doing something called a low-pass genome-wide test that can identify things called rare autosomal trisomies. From an obstetric perspective, 99% of these results are completely irrelevant. You can see of all of these cases, the orange ones are the ones that potentially had some obstetric relevance. It's a relatively tiny proportion. If we're going to screen for deletion 22q11, I think there's value in that because often these abnormalities that we see in utero are quite difficult for us to detect in early pregnancy. On top of that, we know that these babies have very significant neurodevelopmental complications after delivery. We took part in a study looking at using NIPT to screen for 22q11. We were one of 21 sites enrolling 20,000 women where we had genetic truth because we actually karyotyped all of the infants in this study. This is a test that was done with a commercial group called Natera. We specifically looked at 22q11 deletions, trying to look across the whole of this potential microdeletion so that we could see microdeletions of various different sizes. The test also used an AI algorithm for risk prediction. So how did the test perform? Well, if we look at basic trisomies, it's actually highly sensitive, highly specific, and one of the advantages that we have of this AI version is that it's actually also reduced the number of false negative or no call cases that we get. If we come to looking at the impact on 22q11, it's interesting that because we now have a test that can look for these smaller microdeletions, we actually have identified that a high proportion of women that have a baby with 22q11 actually have one with a smaller microdeletion, although they still have the same significance from a phenotypic perspective. And this test again performs very well in identifying fetuses with 22q11, about an 83% detection rate, and has a much lower screen positive rate than previous versions, which means that the positive predictive of the test value of the test has now increased. Overall, we found that the prevalence of 22q1 was about 1 in 1,500 in a population. The test had value. If you compared it to the ultrasound, we were actually more likely to determine that you had 22q11 from the genomics rather than from the early scan. So I think there is a place for NIPT. I think we've got to be careful about which tests we use, and I think we've got to think about how we're incorporating that in our first trimester package. Obviously, if we're doing NIPT for aneuploidy, that now gives us more time with the scan to look for major structural abnormalities. We know that a first trimester structural survey will pick up at least 50% of structural abnormalities. We know that markers like increased nuchal translucency are not just markers for aneuploidy, but they're markers for other structural abnormalities. So, for example, increased nuchal translucency is associated with increased risk of cardiac abnormalities, and then if you overlay other hemodynamic findings like abnormalities of the tricuspid valve and abnormalities of the ductus venosus, then you have very significant rates of detection of cardiac abnormalities. Of course, I don't think that we should just limit ourselves to looking at nuchal translucency in the first trimester if we want to assess the heart. It's important nowadays that we go on and make sure that we examine the heart in the same way as we would essentially at 20 weeks, possibly with slightly more reliance on color Doppler to demonstrate the outflow tracts. We now know that we can pick up significant CNS anomalies on the 12-week scan. So this is an example of how we can use the intracranial translucency as a screening tool for spina bifida. It's been identified prospectively as being a screening test with about 80 to 90% sensitivity for spina bifida. We have novel markers like this marker looking at the cleft in the palate. Palatial clefts are very difficult for us to see at 20 weeks, and now we have a clear, simple test at 12 weeks that enable us to identify and diagnose this condition. So there are screening standards for how you should do an anatomical survey in the first trimester. This is the ISUOG standard. It's a sequential process of screening through different systems. And let me just move to the risk prediction. We talked a bit about this yesterday, but we know that preeclampsia is a phased disease. We know that we can predict early onset preeclampsia at 12 weeks, and that allows us a point of intervention before women have symptoms of this illness. The original work by Leona Poon basically showed 90% sensitivity in screening for preeclampsia using a 12-week scan. We've repeated this in Australia. This is looking at the uterine artery Doppler. We've demonstrated and validated the fetal medicine algorithm in our own population. You can see it on the left-hand side. The ROC curve is very significant. And we've gone on to show that if we give the intervention that has been talked about, aspirin, we do see a 90% reduction in rates of preeclampsia before 34 weeks in our population. And what that means is that we're not delivering babies at 24, 26, 28 weeks with preeclampsia. We have far fewer babies in our nursery for 100 days at a time. These babies cost $4,000 or $5,000 a day. This is a significant cost saving to us, and that's where the value of screening comes in. There are other models for other adverse outcomes. This is a model for spontaneous preterm birth. You can see it has cervical length as the ultrasound component. This is a model for preterm, pre-labor rupture of membranes. So I think that there are going to be significant developments in the prediction that we do in the first trimester, and now is the time to get skin in the game to be in a position to offer this test to the whole of our population. And I just wanted to end by saying, how many tigers can you see in this photograph? There are 16, but you're only going to see what you look for. Thank you.
Thank you very much, sir, for that exhaustive presentation. We are indeed privileged to have you here for CUSP 2022, and I request our director, Professor Dr. Suresh, to honor him. Next, we have a short discussion session. Most of the questions that you have put in through the app have been answered, and we encourage the delegates to put in your questions, input your questions into the app. If any questions, I request our speakers to kindly answer them. There are a few questions which have come in through the app. Dr. Sinish Kumar, can you come to the front here? Dr. Jyoti, Dr. Gauri Shankar,
Dr. Sinish, when the NB status is not clear in the NT scan, then how do you proceed with the FTS risk calculation?
So I had put in one of the last slides. Sorry. So nasal bone status in first trimester, you think of only three things: present, absent, or undetermined or uncertain. But make sure that the lab has included all these risk categories into the calculation part. So if you're not sure of the nasal bone status, you can put as undetermined or uncertain.
Do labs consider unsure nasal bone during combined first trimester screening?
Yes, there is a risk category for that. So you have to specifically fill that in the TRF form, and also, if possible, inform the lab personally. Because many times, even if the nasal bone is absent, in risk calculation, it is given as present, or it may not be included, which can all hamper the performance of first trimester screening.
Yeah, Dr. Sinish, there is one more question. Say you have used the nasal bone status as present in the risk calculation, and you have the combined screening report, and then you're seeing the same patient at 18, 19 weeks, and you put them on the centile charts of what you have done, and the nasal bone is small. Now, how you said you will be able to recalculate the risk. How would you do that? Because the initial screen, you said you use the combined risk as the baseline category, but the combined risk has already used the NB status as present and it's been calculated. Wouldn't that skew the risk recalculation?
The FTS is actually a mathematical model, and if the nasal bone, you said the nasal bone was
Small in the second trimester.
Small in the second trimester.
And in the FTS, it has been given as present and calculated as present.
Okay. So in that case, actually, you can relook at the images. And if the image is of not good quality, maybe you can recalculate it's basically a mathematical model. It's an algorithm, the first trimester screening. So you can recalculate by mentioning nasal bone as absent or hypoplastic in the first trimester. Absent. And use that as the a priori risk for the second trimester screening. Or if you can recalculate the second trimester risk using the nasal bone as a hypoplastic straight away.
So you basically have to revisit the first trimester
Yes.
screening report again.
If possible, that is should be the first line option. But mostly when the scans are done from outside and they don't adhere to FMF standards, it may not be possible always.
The next question is to Dr. Gauri Shankar. Can you please give your take on amniotic bands leading to limb edema and after normal first trimester scan?
Well, that's a very good question. Usually, amniotic band syndromes usually occur in the first trimester because of the close proximity of the fetus to the amniotic band. It gets more sticky. Having said that, sometimes we do expect these to have constriction following a procedure, like for example, we do a laser, and if there is a problem, and then probably this fetus will just go through, then that can a mechanical construction. But mainly, it is the first trimester diagnosis.
In the invited paper, a question was asked about the gender. What words to use for reporting ambiguous genitalia?
Any of you can take that question?
Yeah, you can use it as ambiguous genitalia, that's it. And then it requires a further evaluation. So Cyrus there.
Yeah. No. This is a very controversial question because your Form F specifically says, I have neither seen nor revealed the sex of the baby. So how can you say ambiguous genitalia without seeing genitalia? So you are lying. So this is the problem. But when I asked the authorities here, at least in Chennai, there is also a thing that if there's an abnormality, a genetic abnormality can be reported. Because this baby actually requires a karyotyping to say what is the genotype. So you can go for further testing, but counseling is very difficult. But there are few cases where we have reported it, and we have given an explanation of why this report has been given. So as long as you have clear records, because the patient has a right to know. Patient has a right to know, because otherwise it's a lifelong problem.
The next question is to Dr. Jyoti. If we get a case with NT more than 95th centile, say for 60 mm it's 2.7, then how do we proceed? Do you use 95th centile as the cutoff or 99 only?
We'll use 99 centile only as the cutoff. If it is 2.5 mm for 60 CRL, it will be considered as normal, and you can evaluate the fetus structurally in the first trimester scan. And if it is a structurally normal fetus, you can offer biochemistry.
Thank you all.
Thank you, ma'am. Again, a democratic question. So I searched while preparing this paper and doing this study, we searched a lot of paper for unilateral and unilateral presence and absence, but there is very limited data actually on that. So coming to your question, you asked whether unilateral should be taken into consideration. I think we should take the mean of the two nasal bones and first trimester it's present. Just take a simple approach: present, absence, or undetermined. So it's too difficult to assess the two nasal bones in the first trimester. They're too short at that point.
So what do we do when we offer invasive testing when NT is above 99 centile, but patient does NIPT, NIPT is low risk? NT reported 99 centile, NIPT is low risk.
You have to do a detailed examination, and after do detailed ultrasound examination, and after doing that ultrasound examination, you can decide what invasive testing you want to do, if at all there are any structural malformations, because chromosomal microarray has reported some atypical pathogenic variants in this subgroup with NT more than 99 centile. But after evaluation with an ultrasound, you can decide whether you want to offer further testing or not.
Thank you so much, all. Thank you, sir. Thank you, Dr. Jyoti. Thank you, Dr. Sinish.
Thank you very much for that excellent discussion. The next will be an important debate, a debate on routine fetal echo in the first trimester, an achievable goal. Dr. Chinmayi Ratha and Dr. Manikandan will be the speakers. The stage is equally balanced, and Dr. John Hyatt will have the difficult task of being the moderator here. Dr. Chinmayi Ratha is the Director and Lead Consultant of Resolution Fetal Medicine Center, Hyderabad, and Chairperson of Perinatology Committee, FOXY. She conducts several workshops and training sessions for fetal medicine. She collaborates with physicians across the country to provide a shared cared approach for difficult fetal medicine scenarios. Dr. Manikandan, we all know, is a lead fetal medicine consultant in the Fetal Clinic Pondicherry and KMCH Coimbatore. He is passionate about fetal medicine and is an eminent teacher. He has several papers and projects to his credit. Over to you, debaters.
Okay, just to say that you'll first go for, each of you will speak for 10 minutes, and then there will be some rebuttal time, I suppose. Okay, right.
Thank you, sir. And it's an honor to be here in CUSP yet again, Professor Hyatt. And I stand before you on the 1st of October 2022 in this phenomenal gathering of specialists in fetal medicine to reconnect, recharge and refresh. It's a day when India is stepping into the new technology, and our Prime Minister is launching the 5G in this country. And we are talking about using this technology to do not 5G per se, but just using a new aspect of technology to do a routine fetal ultrasound, a routine fetal echocardiography in the first trimester. And we think it is an achievable goal. But then I'm supposed to debate this, I'm supposed to defend this. I don't know why are we even debating it. You just heard Professor Hyatt say that you should do a very good first trimester scan, and you should not stop at just seeing those two tigers. You should try and see all the 16 of them in that picture, because the attention is that's required at that point. So the ISWAG guideline of how to do a first trimester scan says that the advantages of doing first trimester reporting is early detection and exclusion of major anomalies, early reassurance to at-risk mothers, earlier genetic diagnosis, and easier termination of pregnancy if it's required. So we still stand here and debate whether or not we should see more. There are limitations. There are limitations that if you try and do things very early, you may be looking at things in a perspective that's not yet defined. There is an uncertain cost-benefit ratio, and some anomalies develop late. So we are not saying that you try to do everything early. Nobody is talking about diagnosing osteoarthritis in pregnancy, in the fetus, of course. But what we are trying to say is whether a good fetal echocardiography can be done in the first trimester. So the ISWAG says try and look at the normal position of the heart, establish the 4 chambers, and beyond that, using the color Doppler can help, but we have given some caution because these are the general guidelines of the first trimester scan, which should be done by everybody. But you can do a more detailed anatomy. It has been demonstrated to be feasible in the 11 to 14 weeks period. What you need is intention, equipment, training, and of course, to make it all sensible, you need common sense. Now, is that possible? Is it achievable? I think every journey begins at small steps, and it is definitely possible. So there was this opinion paper where they said, is the first trimester echocardiography useful, or is it just a research tool? And they definitely said that it has contributed to our understanding of cardiac malformations, and it has been, useful in showing the structural and functional aspects of the fetal heart, progression of these malformations, and when you combine it with your NT, you can give a more meaningful direction to that pregnancy as such. Can you complete a fetal echocardiogram in the first trimester? This study was, of course, between 12 and 16 weeks of pregnancy, but they went up to the limit of looking at all these views. You see the systemic and pulmonary venous connections, atrial, ventricular, and septal sweeps, outflows, great arteries, pulmonary arteries, the arch, everything. And they found that in most of the conditions, they were able to get most of the views. The color Doppler interrogation always enhanced the outcome of whatever they were getting, and this was found to be feasible. This particular study about first trimester fetal echocardiography again was aimed at looking at the feasibility of performing a complete fetal echocardiography, and they also said that the absence of a statistically significant difference between these disproportionate findings which you find in first trimester may mean that they are yet to be developed, and therefore whatever you see in the first trimester can be seen, only it has to be interpreted with caution. So you will try and make an attempt at looking at the heart in the first trimester. What you will not do is jump into a conclusion. If there is slight disproportion, you don't get very excited. If the coronary sinus is slightly dilated, you don't get very excited. You may have to add the second trimester echo as an adjunct to your diagnosis when you're not completely sure. But in case you're very sure, in case you see that there is an AVST, in case you see something grossly abnormal at that stage, then why not give the woman the advantage of a first trimester diagnosis? Safety has to be ensured, precautions have to be taken. And this people have repeatedly written in every treatise on the first trimester that there are pitfalls. You might overdiagnose things and you might lead to the if you're very, very enthusiastic, there might be a condition where a woman is contemplating terminating a pregnancy which is otherwise normal. So this paper, which was the opinion paper, finally said that we should recommend or we should commend the people who have started this concept of first trimester echocardiography. However, the adoption of this practice with others should be tempered with caution. Even in expert hands, there is a relatively high false positive ratio. So we agree it is definitely a risky thing to do, but it doesn't preclude the possibility that it is an achievable goal. So if you look at the performance of the first trimester fetal echocardiography, the meta-analysis said that good performance of the first trimester echocardiography, because kinds of progressing heart defects, minor congenital heart defects that can only be diagnosed later, you need to have the second trimester echocardiography, but you should have a high value for the first trimester echo. In the Lancet, this was the year 1998, Dr. Charland sent a letter saying that first trimester scans can be more time consuming and they cannot be realistically offered to everyone. A subset of high-risk patients can be selected, however, for whom the reassurance provided at early stages has an immeasurable value. Now, this was his opinion in 1998. What was the excuse? The time taken to do something is what we have to decide whether it's worthwhile. So we know that when we start practicing things better, the time that we take to do the same thing gets reduced. So why not just practice routine echo on everybody? Who is high risk for congenital heart defects? We have a subset of women where we think they are high risk, but the actual number of congenital heart defects occurs in what is called an apparently low risk population. So who deserves this reassurance that nothing is wrong at this stage? Don't you think a normal woman who has otherwise no risk factors predetermined deserves that reassurance? So why can't we just expand our gamut of the first trimester scan and give her that reassurance? This was again a feasibility study. It was a flash study done over a 2-week period where every observer was requested to perform a simple echocardiography without modifying the time and methods that were needed in the first trimester scan. And there also they found that it is possible for a trained operator to perform simplified fetal echocardiography during a routine first trimester ultrasound in a low-risk population. In most cases, the basic heart examination can be used to reassure patients or identify potential problems to be clarified as early as possible in the second trimester. We are looking at a time where people might do NIPT and get very reassured, and they might come for their second trimester scans very late. So what will you do if you find a correctable fetal anomaly at 23 weeks in this country, because you don't have time for genetic workup then? And we know that genetic workup is important in the workup of these conditions. So in this particular study of doing a routine first trimester echocardiography, they saw that most of the planes, apart from the pulmonary veins, most of the other views can be achieved in the first trimester without what we call as undue pressure on time and resources. So with they had a good follow-up of their outcomes, and they have written that we were able to show that only 5 additional cardiac defects were diagnosed during further fetal life and postnatally without increasing the neonatal mortality. So a good first trimester screening of the fetal heart led to diagnosis of almost 90% of their cardiac defects in the first trimester. This was in 2011, and I was glad that it was like a futuristic thought that they were looking for more indications of doing first trimester scan. In obese women, where second trimester imaging can become a challenge, doing things in the first trimester where even a transvaginal approach is feasible is something to look at. Not going backwards and saying that we should not be doing. We are talking about using the spatiotemporal imaging in the first trimester, not saying that we should not even do a routine fetal echo in the first trimester. So there is a paper now which says as early as 8 weeks we could use the ultrasound to diagnose cardiac structures. Of course, the ideal timing would be after 11 weeks, but we are trying to go backwards in terms of gestation, where we are trying to look at heart defects, not thinking that we can't do stuff. So first trimester fetal echo with high frequency, high resolution transducers, both transvaginal and transabdominal, permits the evaluation of fetal heart as early as 8 weeks with a near complete anatomic assessment in majority of cases at 11 weeks. So the factors which affect the feasibility of a routine first trimester screening is how competent you are in looking at that particular organ, which will come with practice, which will come with supervised training. And if you want to do it, it is very much an achievable goal. This was actually a paper from 2014, and I'm sorry that at 2022 we are still debating this. So this is a paper, sort of a review paper by Asma Khalil and Professor Nicolaides, where they again said that the detection rate could be improved if ultrasound assessment at the first trimester followed structured protocols. Detection rate of congenital heart defects could be improved by the use of transvaginal ultrasound and new techniques. So at every step where we are trying to enhance our technology, we have to look at what we can do better. Can things go wrong? Of course they can go wrong. And when you have this is something which happened recently in our country, and we are all aware. This was one of the safest vehicles when they sell it to you, but things went horribly wrong. And when they went wrong, we didn't know what went wrong. We kept on looking at things. But what we learned from that is anything can go wrong if we don't follow the proper security mechanisms. So again, I reiterate, intention, equipment, training, and common sense. Don't be the only one thinking backwards, my worthy opponent. Please accept a responsibility of a first trimester routine echo. Do no harm, train yourself better, and do better. Thank you very much. So I finish by saying nothing is impossible.
Thank you. I think we're going to hear the other side of the story now. So, Dr. Mani.
Thank you very much, and I thank CUSP team for having CUSP back and also giving me this opportunity. So it was told in the 1990s, then why are we still not having it? So there must be something to the other side, and that's what I'm going to tell you. I'm not going to show you Modi's photo. I'm going to go back and show you this particular victim of execution without trial, and we know what the community paid for that act. So say no, but before that I have a disclosure. I do scans, very detailed scan. I do release reports, but only when it is necessary, not as a routine. What is the problem I have with that? I have problem with these red lettered words here in the topic. Routine. We'll see one by one. When you say routine, in medical parlance, it loosely translates to standard of care. That's not going to be good for us. And for the young guns here, know that fetal echo is not an expanded set of heart images. No, it's the mindset of a fetal or a pediatric cardiologist. So you use all the modalities available to dissect the anatomy, physiology, rhythm of the heart, and where abnormal, find out all the prognostic markers so that you can give a complete management plan to the prospective parents. You defend the unborn baby. And first trimester is obvious. Now, what are the corollaries of these words? There is specialized, which implies that you need to have a particular reason to do. You escalate it in the hierarchy of training and specialist knowledge. Also, we have cardiac screening. Chinmay conveniently put the cardiac screening as echo. These are simple views that all of us can obtain in the limited time that we have with our patients. Obstetricians can do, radiologists, general radiologists need not be fetal medicine specialists. And where it is abnormal, you can escalate it. And this is available for both the first trimester and the second trimester. So I will put forth my argument. I will have 4 arguments, 4 points, and then I will have a closing remark on why we should not do it as a routine in the first trimester. Let's first look at what are the standards that we have to actually follow in the first trimester. You know this person, right? He spent about a decade trying to teach and standardize one particular view of the fetal head and neck and the upper thorax. It's called the NT image. He founded the Fetal Medicine Foundation, and through various means he has been trying to teach people all over. Now, he runs an audit program for the NT. You can submit your NT image and your data so that you yourself are accurate. It's sort of a self-discipline. Of the thousands of people who do NT in our country, do you know how many of them are actually getting audited themselves? Just 231. That's the reality. We may be having so many motivational speeches, but this is the reality. Now, why am I concerned about this reality? Is it lack of discipline or, the attitude, why should somebody monitor me? Whatever may be the reason, the effect is that. This is the quintessential NT image that I see whenever I see a referral in the first trimester or second trimester. A baby is there somewhere, looking somewhere, the caliper is placed somewhere, but all the time the NT will be 1 or 1.1 millimeter irrespective of CRL. Jyoti, so much, it's only 1 or 1.1. Now, what does the fetal medicine say about the practice protocol? When you have a first trimester screening for cardiac, they clearly write out what they do. Training and certification. Only then the sonographers are allowed to do. They use a high-end equipment and they do the screening views. Once the screening views are done using lot of time, 30 minutes per fetus. So if it's a twin, it's 1 hour. And then they will escalate the case if there is a concern to the fetal medicine specialist or the fetal cardiologist on the same day. This is the protocol, the way they practice, where there is ample resources. I'll take you to what is our resources. I used to follow SS whenever he gives talk to note down the philosophy statements. So once he came to Pondicherry and he told, as a nation, we should look inwards. So I was thinking, what is he telling? And then I understood this. Let's look at only Pondicherry Union Territory. 20,000 pregnancies we have to manage annually, 20,000 live births, so more pregnancies, and it's being catered by 250 obstetricians, 150 radiologists, 4 people specially trained in obstetric imaging, 3 of them from here, 2 fetal medicine specialists, 1 is not working today, and only 1 pediatric cardiologist. So my argument is, in the first argument is, standards already we are not following. The vast majority is not following the standards. The second argument is, this is a resource intensive thing that you are asking to do in a very resource restrained setting. The system is going to collapse. So what do I have from my own clinical practice? Look at this quintessential typical patient I have. Dentist, software, some knowledge to use Google, okay? So was referred because first trimester screening was intermediate risk, done elsewhere, I don't report intermediate. And then she comes, and then I, being the fetal physician, does a very neat scan, and then I say, it's all well, but there is unossified nasal bone, okay? But don't worry, this is quite common. I give a very lengthy counseling. Don't worry about it, it's not a malformation. You have a first trimester screening concern, I can sort it out, don't worry. NIPT, CVS, or even don't do anything. She said, no, I want CVS. Pakka answer I want, I'll come tomorrow. The next day, we have all gone through this. It's very disheartening to see this. So it makes me wonder, what is my goal of prenatal diagnosis? Am I like the Navy, which also uses sonar, to seek and destroy? Certainly not. Do I want to show off my scanning skills at the very early, make some exotic diagnosis? No, not at all. My goal is to give meaningful choices when faced with an abnormality to the parents with a complete and honest discussion of every angle that they want. So I asked my team, okay, let's pull up the data 5 years we have been doing, let's see what happens. About 1700 anomalous reports we have released, of which 17% are cardiac, which is quite acceptable because it's a referral center. And if you see, 40 reports we have released as first trimester cardiac abnormalities. What happens? Guess what? 38 have been terminated. No further testing. What are the 2 remaining? They are one of a twin. That is why it is remaining. Continue. Okay, let's look at some other data. This is Czech Republic. They released their data after they systematically introduced first trimester screening. Look at the TOP rate once you release a report in the first trimester, cardiac, skyrocketing compared to just 60% in the second trimester. Why do I have a problem with this? I have a problem because when you decide to terminate a first trimester fetus because of a cardiac finding, if not in all, in the majority, you will be doing it without finding the full facts of the case. That is breaching the cardinal principles of criminal justice. It is execution without trial. We shouldn't repeat it at all. All the papers tell that, at the end they will tell. They want to just show off that we are very good in doing an early scan. But at the end, the conscience will come. No, it's perilous because some of them will get terminated. So these will be fine print. My problem is not even the terminations of favorable CHDs. My problem is terminations of the false positives. Nobody can justify that. What do parents want? A number of papers are there. What do they want? Yes, most of them ask in our practice, can we not find it before? Yes, but they also equally want the entire facts of the case. They want to know the treatment, the natural history, short-term, long-term prognosis, everything. How can you give it without knowing everything? And when they take a decision, they want us to be supportive. Can you do it with a conscience when you don't give the full picture, when you don't have the full picture? And no discussion is complete without them asking, will it recur, doctor? Should I do something to prevent? It's not possible to give these answers in the first trimester because it's very difficult to get the full picture. Take, for example, these 2 cases referred for abnormal cardiac views in the second trimester. Yes, there is a TOF, but there is also a clinodactyly. There is a duodenal obstruction. There is an abnormal portal venous system. There is irregularity of the lateral ventricles. Very difficult, if not impossible, to see this constellation in the first trimester. Say another example. In addition to the cardiac finding, there is a spinal dysgenesis, sacral dysgenesis. There is an esophageal atresia. Very difficult, if not impossible, to pick this polymorphometive association in the first trimester. So you will be giving a half-hearted, incomplete report. I will close my argument with these remarks. If you make the stamp of first trimester echo as routine, you must be prepared to have an increased number of false diagnoses. She told many things, allocate more time, do the training, all okay, the baby will be jumping, other patients will be under pressure, patient will become aggressive, maternal habitus, obesity is on the increase. For what you are doing all these things? It's impossible to confirm because autopsy is not going to tell us anything when you terminate in the first trimester. As I told you, because of the evolution of the findings, it will be an incomplete diagnosis in the majority when you do it in the first trimester. And it will be incomplete evaluation. Genetic, you will be shooting in the blind. You may want to do it whole exome sequencing for all. You may want to do CMA whole exome, whole genome. If you don't have the phenotype, where are you going with the genetic evaluation? And because it's going to be an increased termination out of fear, then it's going to be useless. So it will set in a vicious cycle. You do a first trimester echo because it is standard, but you are not able to see everything. The patient comes to the second trimester, you tell something more, they are going to get aggressive. Already aggressive behavior is there. Then what happens? Your first trimester backlash will be tell everything now itself. Let them take a decision whether to continue or not. And then there will be indiscriminate TOP, and then this will strengthen your first trimester echo. I will finish with what my professor used to say, one more philosophy. The simplicity of a procedure in skilled hands is directly responsible for increased morbidity and mortality in its universal application, routine. Okay? Also think of what Einstein says. Don't try to be a success, don't try to be show off, but be of value. So please vote against. Thank you.
thanks. So I think we're going to do some rebuttal next. Only 2 minutes. And I don't know if there's any questions in the audience. Please just make yourself obvious to me as well. Thanks.
I thank my worthy opponent for starting from where I finished. I said, is it achievable? Nothing is impossible. And he took it very literally, so he decided, let's do nothing. So, is it an achievable goal? It is, if you start looking beyond the glass walls where you've trapped yourself. Setting standards. Now, you know, when we started doing NT, all we were doing is CRL and the NT and a fetal heart rate at max, and we were giving the, findings. And I think this gentleman on stage, our moderator here, was responsible for establishing the association of an increased NT with cardiac heart defects, and then congenital heart defects, and it came to be that, okay, start looking at the four-chamber view, start doing a tricuspid regurgitation, start doing a ductus venosus. And the standards of an NT scan have changed since when we first got our certification to now when we send our audits. So standards change. Let's not get stuck by what were the standards earlier and start looking ahead. Look inwards, but don't stop looking outwards. Things are changing. And if you're only looking inside, you will not stay abreast that change that's happening. We will make mistakes. Yes, false diagnosis will be there. But mistakes are a proof that you are trying. And don't be afraid to make mistakes. Just be afraid from learning from your mistakes. So what will we learn when we will make false diagnosis? That vicious cycle of false diagnosis, incomplete evaluation, and indiscriminate termination will only be stopped if we evaluate the whole thing. If this is a first trimester finding, it may evolve into something different. Other organs may get involved. So all it requires is some extra time in counseling your patients. Well, takes fewer number of patients if that is what it takes, but don't cut down on the time that it takes to care for a patient. Tread carefully because fetal life is at risk both ways. If you don't spend time in the first trimester, you will not have time in the second trimester. Here you might have false diagnosis. There at 23 weeks, 5 days, if somebody comes with a cardiac defect, how many of you are going to spend time with her for genetic evaluation and further workup? So the do no harm principle holds true there also. What can you do to make the first trimester fetal echo safe? Skill enhancement, understand embryology, and accept the responsibility, accept the power that comes with that responsibility, and do better with your counselings. So what we need to do with first trimester echo is, you need to use your common sense and counsel effectively. Be prepared and not scared. So to do no harm, you say that the first trimester echo is possible. Making it routine is also possible as long as you take small steps every day. You will get there one day. Thank you very much.
Okay, well, I think we've heard from both sides of the argument. Perhaps if you both wanted to approach a microphone might be a good idea. So I might just ask a question of you both. Manny, you're obviously concerned about the issue of a false positive diagnosis.
Yes.
So you've decided not to look because there might be a false positive diagnosis.
Let me clarify that. I showed the example of the NT because when you put a rule in the audience that NT is a routine in the first trimester, all those who hold the probe are going to report entry. It's not going to stop just because they are not trained, just because they are not understood, just because they have not audited themselves. It's not going to stop their practice. So the moment you say NT is a must, they do the NT anyway. So my argument is a bad NT is worse than no NT, and it says the same for this also.
Okay, so a bad echo is worse than no echo.
Yes.
So what would you do to make sure you counter the risk of a false negative diagnosis? How would you couch this examination in a process that allows an opportunity to reflect on whether the diagnosis is correct or not?
I think first and foremost, we should make a checklist for what we call as a routine echo. And if that checklist is completed, then what all can be reasonably ruled out gives a great degree of reassurance to the lady. If suppose we think there is something amiss, but it's not really fitting into a diagnosis, and we are standing on unsteady ground because we are in first trimester, and from embryology to uncertainty in diagnosis is all with us, then we counsel them. And we increase the level of their knowledge and their understanding and our understanding, telling them that let's not terminate the pregnancy, let's not do anything funny at this moment. If at all, maybe it will increase the number of invasive procedures, because probably we'd want the genetic information in the next 2 weeks, already with us by the time we see this anatomy better. And I think if we go in a reasonable manner, we are going to improve the standards of fetal health care with this policy.
Okay, and I guess the other thing that I was thinking was that you might also get a second opinion for any anomaly prior
if that
to
is that's a
termination.
luxury sometimes for us,
Yeah.
but if it's possible,
Yeah.
I would like a second opinion, definitely.
Yeah. Okay. Look, I think we better move to a vote. So I'm going to ask the audience if you support the motion that we should be doing a first trimester echo for all patients. So that's a routine first trimester echo. Support the motion. Please raise your hand. Oh, that's at least 99% of
John,
the...
before that, can I put a statement?
the
I
ones
can
who are
apply to
raising
ask
up.
both of them. Dear friends, both Chinmay and Manikandan, you did a great job, but Chinmay, I'm sorry that the crowd is against you today for a change.
The crowd, Rachita. She said the crowd.
Yes.
The crowd means the majority.
Yeah. Mani, but the thing is, as you rightly mentioned, the number of terminations definitely is going up with your first trimester false positives. I of course agree. But even with the raised BMI, John, will you agree with me that because South Asians, being South Asians and anywhere in the world, even a transvaginal scan is difficult at times in first trimester, because if they have fat in the tummy, it is sometimes difficult to do a transvaginal too, to look at the detailed fetal echocardiogram. I have to put that message.
Okay, I'm happy with the message. I've got to carry on with the vote because we're near time. So I think we had just a sprinkling of supporters for a routine echo. Who does not support a routine first trimester echo? Show of hands, please. So there's more hands going up this time. I think the majority of the audience seem undecided. So perhaps you can come back next year with some good examples of why we should be doing it. But thank you to both speakers. I thought it was a great debate. So thank you.
Thank you, sir.
Thank you very much.
Thank you.
A very big thank you to the debaters and our moderator for making this session so enlightening. Thank you.
We will now have the program honoring a legend, the Grit and Determination Award.
Good morning, one and all. It's my proud privilege to welcome you all for this important event in CUSP, honoring the legend. At CUSP, in the past few years, we have been honoring luminary medical professionals amongst us in appreciation of their significant contribution to medicine. So far, in the past CUSP, we have awarded the honoring the legend to Professor Arkat Gajraj, who was a very famous radiologist and renowned radiologist from Barnard Institute, Chennai. Professor Chittaranjan Yagnik, who is a very great scientist and a lot of work in diabetology from Pune. Dr. Mukund Joshi, whom you all know, and he is a famous ultrasonologist and a radiologist. And Professor Walfredo Sumpaiko from Philippines. And now 2022 CUSP finds great pride and happiness in awarding this award to Dr. Arun Kinare.
We invite Dr. Suresh, Dr. Indrani Suresh, and Dr. Nitya Kalyani to the dais, please. And we now request Dr. Sudarshan to lead Professor Arun Kinare and Mrs. Smita Kinare to the dais.
Traditional welcome.
We now invite Dr. Suresh to the podium to introduce Dr. Arun Kinare and to read the citation.
Can we, Ambika?
Herzlich willkommen bei uns, Herr Dr. Kinare. Es ist eine große Ehre für uns, einen so wunderbaren Menschen als unseren Hauptgast vorstellen und begrüßen zu dürfen. Wir freuen uns, Sie hier zu haben. Es ist uns eine Freude, Ihnen die geschätzte Auszeichnung des Grit und Determination zu überreichen.
Okay, I hope all of you heard. What is that language? It is German language. Because Smita here is a specialist in German and she teaches German. So we welcome you traditionally in German. Arun, it gives me great pleasure to welcome you this day, and first of all thank you very much for agreeing to travel all the way from Pune to here. Dr. Arun Kinare was born in Maharashtra and had his schooling in Kolhapur, and then completed his radiology from Mumbai, and then he's been practicing ultrasound since the last 43 years. And of course he's 3 years senior to be in ultrasound now, and he's a honorary professor at radiology at the Bharati Hospital in Pune, and consultant at the Hitanshu Kawasaki Medical Research Institute, Jahangir Hospital, and he's also well known for his work in diabetes, along with Professor Yagnik at the research unit in KM Hospital in Pune. He has done quite innovative research in the field of diabetes and pregnancy, and he's also been the past president of the Indian Federation of Ultrasound Medicine Biology. His interests also include veterinary ultrasound, helping the poor and needy, and his never give up attitude and help ever and hurt never philosophy endears many, many people to him. I am blessed to have him as my friend who has always been there, literally just a phone call away. Mrs. Smita Arun has been a pillar of support and stood by him solidly through the years in her own right. She is a very proficient in German and teaches German to a large number of students. I am delighted and thankful that she has kindly consented to be present here today. On behalf of the entire Mediscan family, welcome Arun and Smita, and thank them for accepting our invitation. It's also my honor and privilege to read the citation. A little bit, Sujata has told you about the award. We try to honor somebody who has contributed very significantly in more ways than one. It need not always be in ultrasound field, but because for us, you have to take life as a whole. So it gives me pleasure to read the citation to Dr. Arun Kinare. Born on the 1st of August 1948 in rural Maharashtra, Dr. Arun Srinivas Kinare was born to Dr. Srinivas Krishnaji Kinare and Dr. Mrs. Vimal Srinivas Kinare, who instilled the values of righteous life from his early childhood. At birth, he welcomed this world with a gentle smile, which he retains to this day. This is the essence of his persona, which has captivated the hearts of his friends, students, and anyone who comes in touch with him. Motivated by his father, he took to radiology as his career and ensured that he gave his very best to each and every patient that he had the opportunity to serve. Realizing the value of the emerging field of ultrasound, he was fortunate to be trained in Denmark by Dr. Hans Henrik Holm, a pioneer in this field at that time. Dr. Kinre's commitment to serving the community in his own country brought him back to India and established his practice in Pune, and also served as the head of the department at 2 leading hospitals in Pune. Sensitive to the needs of the poor, he often reached out to them by giving a helping hand. The luminaries of the day sought his opinion and always had a praise for his professional approach. He continues to pursue his research interests and is well published. His love for animals and concern for their health led him to use his knowledge and skills in doing veterinary ultrasound and help solve problems for many a pet. Principled, punctual, warm, generous, empathetic, and ever willing to share his knowledge are some of the qualities that have set him apart from the crowd. His never-ending quest for knowledge takes him around the world to seek what is new in the field. The fact that grateful families continue to seek his help for over 3 generations stands as testimony to his professionalism combined with empathy. What more can a doctor aspire for? Nurturing and caring for his team with love and affection is a quality that is worth emulating, and this has kept his team bonded for over 3 decades. What sets Dr. Arun Kinre apart from the crowd is the fact that he is a person who confronts the most difficult situations with a determination to live and continue his service to the community. His life story, The Diary of a Doctor Patient, reveals the innumerable situations where he has overcome extreme personal health problems. He has faced every situation with absolute calm and assured his family and friends that he will bounce back and be amongst them. This indeed is a rare quality, and every person in this world should draw inspiration, learn lessons, and have the courage to face the journey of life. Dr. Kinre has been blessed to have a loving wife, Smita, who teaches German, and who has also stood by him solidly through his difficult journey and continues to smile. The couple have a loving son, Siddharth, who has blossomed into a fine gentleman and is always at his father's side when needed. The organizing committee of CUSP 2022 is pleased to present this Grit and Determination Award to Dr. Arun Srinivas Kinare as a mark of recognition of his extraordinary journey in his professional and personal life, and to show the world that there is joy in life even in times of extreme adversity. Thank you.
Thank you, sir. We invite Dr. Suresh to present a Ponnadai and memento to Professor Arun Kinare. We request Dr. Suresh and Dr. Indrani Suresh to present the citation to Professor Arun Kinare. We also request Dr. Indrani Suresh to present a memento to Mrs. Smita Arun Kinare. Thank you very much. We now request Professor Arun Kinare to give his acceptance address.
Good morning, everybody. Friends, I'm so happy to be here, and Chennai is the city which will always remain in my heart for two reasons. One, my relationship with Suresh, Indrani, Sudarshan and the entire medical scanner family. And secondly, 4 out of 6 tents in my heart were put in Chennai. So they are going to be there permanently. Today I recall my first encounter with Suresh when he visited my clinic in the year 1984 when he came to see one of the equipments I was using those days. I started my career in obstetric ultrasound using a mechanical sector scanner, which was a practice not well digested by many other ultrasoundologists. And then I also recall the year 1978, the month of June, when I went to Denmark, and that was my first exposure to this fascinating field. I was well prepared. I was very confident because I had read each and every word in the chapter of ultrasound. And it wasn't difficult at all for me. Why? Because there were only 6 lines in the entire book. And that was the Bible of radiology, David Sutton's textbook of radiology. So that was, I was very confident of myself, but in short, I knew nothing. So I was very happy. Then I realized that in life, when you want to progress in this field, you need to have mentors. Those days, the technology of mobiles, internet was not available, and it was only the hard work one had to put in. Most of the time I spent in Denmark, where it was more intervention oriented. Of course, the basics were good, and I had the opportunity of doing interventions in my first 3 months of visit. Denmark never required patient consent, so it was possible. Then I realized that that was not the end. I had to learn more. So rest of the training, especially in gynecology, I completed in Vienna under Professor Kotokvil. Clinical part of ultrasound, I acquired and I studied in the United States. And then I realized that at every stage in your life, you have to have some mentors. So I had mentors in Denmark, I had mentors in Japan, and I had a mentor in the United States in the form of Peter Burns. And Peter Burns was the person who helped me in learning Dopplers. And I, till then and still today, I think that he's a king of Doppler. But when I wrote to Peter and I said, I want to learn Dopplers, he said, yes, I'll send you to the best place. And mind you, he was working in Thomas Jefferson, which was Mecca of Doppler. So he said, United States is not the place, and I will arrange your entire program. You go to Sydney, to Prince Alfred Hospital, and that's the place you should go. So when you have mentors in life, there's no end to it, and you can progress. Then the second part of life started in India. I flourished in my practice from day one, because the first patient in my life I saw was a ruptured ectopic at 5 weeks. And I diagnosed that, and then I never looked back in practice. But everything is never smooth. A positive side also has a negative side. And so in the year 1997, it all started, and later on, that series of catastrophes continued. I had cardiac arrest, multiple heart attacks, stroke, cancer, but I'm happy that I'm back here with all the energy. And as I said, every positive thing has a negative part. The only thing which doesn't have a negative side is the passion for ultrasound. And today I'm so happy to be here, and this conference has been a wonderful platform, super class, quality, academics, and really a wonderful meeting. Suresh, I shall always treasure and cherish this honor of the award you gave me. Thank you very much and all the best to you. Thank you.
Thank you very much, sir. Yeah, with this we come to the end of this program and we take a short break for coffee. And we will see you all in 15 minutes, 11:30. Thank you.
A quick announcement before you leave for coffee. For those interested in giving your names for quiz, please give your name, phone number, CUSP ID and institution at the Media Logic stall. Thank you.
there, it will be changed here also. I'll change from here. Then here also.
Monitor.
I'll see here.
Good afternoon. Good morning, everyone. People who are interested in participating in the grand quiz can give their name and phone number and CUSP ID at the Media Logic counter, which is counter number 10, 11 and 12 for the grand quiz. Name, phone number, cusp ID has to be given at Media Logic counter. We will move on to our next session. I would like to call upon Dr. Shweta Shilpi and Dr. Khushbu Malhotra. They are both pursuing fellowship in fetal medicine at Amrita Institute in Kochi. They will be talking about how to and what if about fetal in IVC, inferior vena cava. Over to you, Dr. Shweta Shilpi and Khushbu.
A very good morning to everyone. First of all, I like to thank you, Suresh sir and Vivek sir, for giving us opportunity to present at such a prestigious platform. So my presentation is about how to evaluate the fetal IVC. So to evaluate the fetal IVC, all in all, we need to assess its position, its course, its tributaries, its size, and the Doppler waveform. So to begin with, how to see the IVC. The IVC is seen in the very basic axial views first. In the upper abdomen at AC level and in the lower abdomen at umbilical cord insertion site. So in both of these axial views, the IVC is seen slightly anterior to the aorta and to the right of the spine. The only difference being as we move Kefler towards the fetal heart, the proximity of these two great vessels decreases. That is better appreciated in our next views, that is also called sagittal view. So the sagittal view for IVC is also called bicable view, as we can see the IVC and SVC together. Hammock view or flying eagle view due to resemblance with the same. It is obtained at the right parasagittal plane. Here we can see the IVC entering into the right atrium. As it enters, it gets widened. As it enters, it gets widened due to the confluence of ductus venosus and hepatic veins. In the same long axis of IVC in lower and middle abdomen, the widening of the gap is very well appreciated. So this is the widening of the gap that is very well appreciated in sagittal that I was talking about in the axial views. In the same sagittal view, we can see the different segments of the IVC, that is infradiaphragmatic, below the diaphragm, intrahepatic and intrathoracic, where all the different tributaries of IVC will drain. To see the IVC tributaries, the setting is kept at the low velocity setting. And to begin with right common iliac vein and left common iliac vein, it joins and forms the IVC. The next tributary is left renal vein and right renal vein. The next major tributary of the IVC is ductus venosus. Here occurs a special mechanism to prevent the mixing of pure blood in the DV and impure blood in the IVC, that is called double streaming, whereby the aid of the Eustachian valve and the crista terminalis, the blood in the DV is directed towards foramen ovale and left atrium, and the blood in the IVC is directed towards right atrium through tricuspid valve. This is the proximal most draining tributaries of the IVC, that is hepatic vein in all its branches, where it's draining into the intrathoracic portion of the IVC. This is the 3D rendered image of the intrathoracic portion of the IVC, showing the different contributaries, the hepatic vein and ductus venosus, which is confluence, causing the widening also, and as it enters the right atrium. Also the widening is very much appreciated. Now how to assess the IVC size? Up to our best knowledge, there is no such published normogram to assess the IVC size. However, subjectively we can assess the IVC size in comparison with the aorta in the axial views and in the sagittal views with the SVC. The last point to see in the IVC is the Dopplers. So It is best obtained in the sagittal views at the entry into the right atrium. Also, we can see it in the segment between entrance of renal vein and ductus venosus. Like all other venous waveform, it is triphasic. The waveform almost looks similar to the ductus venosus. The only difference being the A wave will be always reversed. And this reversal will decrease at the period of gestation advances because of the increase in the ventricular compliance and decrease in the peripheral venous resistance. So to conclude, IVC should be seen as a part of routine fetal echocardiography, suspected congenital heart disease situs anomalies. It is best evaluated in axial and right parasagittal views. Position, size, course, tributaries and Dopplers need to be seen. Doppler waveform, it has limited clinical application today. Thank you.
Good morning, everyone. I'm Dr. Khushbu Malhotra from Amrita Institute, Kochi. Now that we have seen how to evaluate fetal IVC, I would be dealing with what if IVC is abnormal. Then what do we do? What if IVC is not seen in its normal position? So here you can see the AC section where IVC, when it has to be anterior and right to the aorta, you're not seeing IVC there. The same with the parasagittal view, you can see the SVC draining into the right atrium, but you're not seeing the IVC. So there has to be an alternate channel for the blood from the caudal part of the body to drain into the heart. So what it has to be is, as is seen here, the IVC is interrupted. There's failure of the right subcardinal hepatic anastomosis. So the alternate channel formed here is the azygous vein through which the blood from the caudal part of the body drains into the SVC. The same shown on the ultrasound image, the axial section, you can see instead of the IVC, which is anterior and to the right of aorta, we see another vessel just beside the aorta, that is the azygous. That is a double vessel sign with the Doppler image showing the opposite blood flow of the same. This is a video which is showing the two vessels arranged side by side. The vessel posterior to the descending aorta is the azygous, the AC section as well as the four-chamber view showing the opposite blood flow in the azygous as well as the aorta. So this, now we know it's an interrupted IVC with the azygous continuing posterior to the aorta into the right atrium. This is a marker of left isomerism, most commonly in 80% of the patients, also associated with polysplenia syndrome. Interrupted IVC, it is also associated with the cardiac and extracardiac anomalies, which we should look for. The cardiac, most common being the AVSD, and the extracardiac being GI atresia or malrotations or the right-sided stomach or mid-liver. So this is the 3D rendered image showing the opposite direction of the blood flow, the azygous, the blood flowing towards the heart, and the aorta, which is flowing, the blood flowing away from the heart. The line diagram showing the same beside it. The prognosis depends upon the associated cardiac anomalies. Accordingly, the prenatal as well as the postnatal evaluation with follow-up is mandatory. So since the azygous drains into the SVC, you can see the three-vessel view with the dilated and prominent SVC. The same, the azygous draining into the SVC, which you can see in the video. Now, just a variation, this shows our own paper which was published in Fetal Echo. It shows the double vessel sign along with the hemiazygous vein draining into the left SVC. So the alteration is, what if the blood from the caudal part of the body, instead of through the azygous, which is normally seen here, the blood drains to the hemiazygous, draining into the left SVC and then to the heart, with the coronary sinus prominent. So this is just a variation with interrupted IVC with hemiazygous continuation. Now what if IVC is seen in the midline with the aorta? You can see here there's juxtaposed IVC, that is the IVC which is placed directly anterior to the aorta instead of being towards the right. So this we can see in the right isomerism. For comparison, I have shown the image of the left isomerism we saw already with the azygous and aorta side by side. So you can compare the images, the placement of the vessels in each. Now right isomerism, as you can see, the IVC and aorta position, which is different from the normal, it is again associated with extracardiac and cardiac association, with most commonly being AVSG, pulmonary anomalous connections,
Accordingly, the prognosis depends on the same with the associated findings. However, the right isomerism prognosis is comparatively worse than the left. So what if IVC is seen on the left? That is, in situs inversus. You can see the liver and IVC is on the left with stomach on the right. Stomach and the heart seen on the right. So situs inversus, it is also associated with cardiac findings like TOF, TGA, VSD, DORV. However, if isolated, the prognosis is excellent in situs inversus. Now, what if abnormal tributaries are noted draining into the IVC? First being the umbilical portosystemic venous shunt, that is agenesis of DV, where umbilical vein is draining directly into the IVC. The next being the downward displacement of the DV, which you can see, which is draining into the IVC. The video showing the same, the DV is draining directly into the IVC but downward displaced. Another example is the portal vein, which is directly draining into the IVC. That is a type 3 portosystemic shunt. Another example of abnormal tributary is the common pulmonary vein anomalous drainage, that is an infracardiac type of TAPVC draining into the IVC, and the scimitar syndrome, that is the anomalous drainage of the right inferior pulmonary vein into the IVC, which looks similar to the Turkish sword, that is called as a scimitar sign. Now, what if IVC is dilated? First thing, as I already mentioned, is about the shunts. You can see the parasage view where the IVC looks dilated compared to the SVC. Here in cardiac dysfunction or cardiac failure in hypertrophic cardiomyopathy, where at the same gestational age showing side by side, the IVC looks comparatively dilated. Also in the hydropic babies, the IVC, as you can see in the axial section, as compared to the aorta, the IVC looks dilated. In the hydropic babies, the same shown with the coronal section. As already mentioned by Shweta, the normal Doppler flow, which is shown on the left of your screen, the reversal segment, that is the A wave, is comparatively increased in case of severe FGR. So that is in case of IVC abnormal Doppler pattern. To summarize, what if IVC is not seen in normal position? You see in interrupted IVC with a zygous continuation, a marker for the left isomerism. IVC in the midline with the aorta, it gives a clue regarding right isomerism. IVC seen on the left, it gives a clue in situs inversus. Abnormal tributaries to the IVC, you can suspect the umbilical vein portosystemic shunt or TAPVC or PAPVC. IVC, if dilated, could indicate shunts or cardiac dysfunction or high drops, and abnormal Doppler in case of severe FGR. So to conclude, evaluation of IVC gives a valuable clue towards diagnosis of cardiac and situs abnormalities, especially those with isomerism. Thank you so much.
Thank you.
Thank you, Dr. Shilpi and Dr. Khushbu. Next, I would like to call upon Dr. Vivek Krishnan. He is the head of fetal medicine unit in Amrita Institute, Kochi. He is involved in teaching and training in fetal medicine students in the same institute. He has several publications to his credit and is a fond alumni of Mediscan. He will be taking us through the extended imaging of fetal brain, when and how.
Yes. So good morning, ladies and gentlemen. As the saying goes, conferences may come and conferences may go, but CUSP goes on forever. Extremely thankful to the entire CUSP team for this opportunity. And when I walked in yesterday and I saw that revolving logo of Mediscan, I feel extremely proud and humbled to have been a part of the 40-year-long legacy of this institute. I've been asked to speak on extended neurosonography, and I hope you would bear with me if I extend my lecture a little bit beyond the allotted time as well. I'll try not to, but please do bear with me if I do. For a long time, until not so long ago, I used to have this kind of impression that the extended neurosonogram was something that really extended beyond our reach. But then, with time passing by and with the experience of having first learned and then taught fetal neurosonography, I realized that this belief that all of us have at some point in our careers is just a problem of perception and nothing else. It's a failure or a refusal or an inertia to look beyond the obvious that makes us feel so. So my reasons for that is that over time we've been so much at ease with the 3 axial views and the 2 fluid spaces in the brain that we just don't want to look beyond. We're very, very comfortable doing that, and anything beyond that drives us a little crazy. And if you're forced to do something like that, you set your brains on fire and then try and find either excuses or disclaimers as to not do it. Obese patient, unfavorable position, poor acoustic windows, fetus in breach, excessive shadowing from the skull bones, subtle anomalies may evolve later, conventional views of standard planes are normal, and so on and so forth. So my job over the next few minutes is to try and break down this myth that the extended neurosonography is only for the experts. And I'm trying to tell you, if you're willing to apply yourselves, how all of us can actually do an extended neurosonography without breaking too much of a sweat, or at least try and initiate the process for the time being. Now, with due apologies to the scientific chair, I've taken the liberty to change this topic slightly around to targeted neurosonography from extended neurosonography, because I'm sure that the scientific chair is not going to extend my time for the lecture. But more importantly, because the 2020 ISWA guidelines on neurosonography have changed the terms basic neurosonogram and extended neurosonogram to the screening examination of the fetal CNS and targeted fetal neurosonography. The screening examination, of course, being a very basic examination that you would do as part of your routine mid-trimester anomaly scans in low-risk mothers, whereas the targeted neurosonography is a diagnostic examination. It is reserved for fetuses who are at high risk for CNS anomalies, or when you do your screening examination, there is a suspicion of a fetal CNS anomaly. So I think that pretty much answers the question of when to do a fetal targeted neurosonography, because as I said, either the fetus is at high risk, like for example, there's a family history of inheritable CNS malformations, there's a previous pregnancy that has been complicated by one, you have a fetus with congenital heart disease which automatically puts them at a higher risk for brain abnormalities, monochorionic twins, suspected intrauterine infections, exposure to teratogens, or if your chromosomal microarray shows a finding of unknown significance, you have to rule out an intracranial abnormality. And as I said, if we've done a routine scan, there's a suspicion of a CNS malformation, then again, you would want to do a targeted neurosonogram. Then the question is, the question of when can also mean at what gestational age would you do a targeted neurosonography. The guideline is not very specific on this, but I would presume that it would be prudent to do it at the time of the mid-trimester anomaly scan in these high-risk mothers. Or, as I said, when you've done a scan and that shows an abnormality at any point in gestation, you would want to do a targeted neurosonography. The guidelines also mention about targeted neurosonography at 14 to 17 weeks, which I will not venture into because that I don't think too many people in this part of the world do a targeted neurosonography that early in gestation. So I'd stick to the mid-trimester scan as a prototype. So now we come to the second part of the question as to how to do a targeted neurosonography. Well, again, for a long time, I'd always believed, like I'm sure a lot of you would have as well, that the targeted neurosonography is about the 10 views of the brain. 3 sagittal views, 4 coronal views, and the 3 axial, the 4 coronal, and the 3 sagittal views. But now I know that this is exactly how you do not want to approach targeted neurosonography. The reason being, the brain is not a series of views. Rather, it is a volume, it is a whole. It's not just section of views that you can look at and say that the organ is normal or not. Like the elephant and the blind men fable. You look at one part, you do not get the whole picture. Which is why the views are just meant to facilitate and not replace the evaluation of the fetal brain as a whole. Because very often what happens is the information that you seek may lie somewhere in between these 10 views, and if you're stuck with those 10 views, you're missing out on vital information. So therefore what I do is to deviate from looking at fetal targeted neurosonography as 10 views to giving myself a 10-point target as to what constitutes a fetal targeted neurosonography. And these 10 target points for me are head size, the midline forks, CSP, corpus callosum, ventricular system, brainstem, posterior fossa, cortex, vascular malformations, and clastic lesions. If at the end of my scan I'm able to say that these are normal or these are ruled out or the abnormalities that are ruled out, I've done a good targeted neurosonography, irrespective of whether I've seen all the 10 views, whether I've done transvaginal, or whether I've done a multiplanar imaging. So it does not really matter to me. If you've documented that all these are normal, then you've done a good targeted neurosonography. And I use the views, the 10 views, as just a means to this end. And I don't use them as water-type compartments. I walk through the brain volume and look at information that I can glean from between these views as well. But of course, it's good to have checklists, wherein, again, I do use these views, but if you notice very carefully, I do not compartmentalize them as transthalamic, transcerebellar, transfrontal, and so on and so forth. I just look at axial sections, I just look at coronal views and the sagittal views to get the information that I'm looking for. So if you look at these in detail, the first thing that I look for is the head circumference. Every targeted neurosonography should start by measuring the head circumference, and this of course is best done on the transthalamic plane. We are all too familiar with this. There are charts to tell you if the head is small or big. We use the Cherevanak charts, and if the head circumference is less than 2 standard deviations is when you start to get suspicious, and if it goes below 3 standard deviations, that by definition is microcephaly. And once we have seen and measured the head circumference, the next thing that we come to is the axial imaging of the fetal brain. And I start off the axial imaging by looking at the anterior complex of the brain. Now, the anterior complex, as described by Vinyals et al., is nothing but the CSP and its boundaries. In the axial sections here, you can see the interhemispheric fissure or the midline forks, which is your first landmark. That is interrupted by the T-shaped callosal sulcus. Below that, you have the corpus callosum. You have the 2 frontal horns on either side, and then the box-like fluid-filled CSP. Now, a few things about the CSP. The CSP has to be seen in the anterior 1/3 of the fetal brain. Rather, if you find a fluid-filled box in the middle 1/3 of the fetal brain, you're probably dealing with a high-riding third ventricle in corpus callosoligenesis and not a CSP. Shape-wise, the CSP is mostly rectangular, but of course, it's not uncommon to find a triangular CSP, which is also normal. 25% of them could show a triangular shape. Irrespective of what shape the CSP takes, it is important that the length of the CSP is always more than the width. Now, this is what we call the CSP width to length ratio being less than 1. Now, once I'm done with the anterior complex, and I'm giving away the checklist that we use. It's supposed to be a very secret document, but yeah. But because I like all of you today, I'm just giving it away to you. I'm going to deal with this step by step. We have done the anterior complex. Now we move on to the ventricular system. By ventricular system, I mean the lateral ventricles, the third ventricle, the aqueduct, and as the fourth ventricle as well. Now, the lateral ventricles, we look at 2 frontal horns and the two occipital horns. And if you're in good visualization of the CSP, you can also document a CSP, a choroid plexus cyst if there's one. Now, this is also the plane that you would measure the lateral ventricle in its atrium. The landmark being the parieto-occipital sulcus there. This is the best view to make the measurement. This is the transventricular view, if you want to call it that. But very often what you find is that the near ventricle does not come into picture. It's because of the reverberation artifacts from the proximal parietal bone. And the workaround for that is to move your probe in an angled arc and try and look at the near ventricle from either the squamous part of the temporal bone, which is suture-like, or from the mastoid fontanelle, avoiding the thick reverberations from the parietal bone. So this is how you do it. You move in an arc to image from the squamous part of the temporal bone or from the mastoid foramen, and then you can see the near ventricle very, very clearly. The ventricular system also involves the third ventricle. Remember, the third ventricle is a cavity of the diencephalon, so it's best seen in a transthalamic view between the 2 thalami. That slit-like space. A normal third ventricle is not visualized on scan. You'll see it as a very thin slit-like space. The aqueduct is a cavity of the midbrain or the mesencephalon, so it's best seen on images of the midbrain there. So I move slightly caudal from the transthalamic plane and try and see the cap hat-shaped midbrain, and then look for the aqueduct to find out if it's patent or not. Lastly, I would also look at the fourth ventricle in the ventricular system, for which I need to go to the transcerebellar plane and then give a slight caudal tilt, because in the strict transcerebellar you may not see it, which is why I said you need to move up and down to see the structures that you want to. So I've moved cauded from the transcerebellar plane, and I can see the fourth ventricle there. Remember, the fourth ventricle is always, unlike the CSP, or quite contrary to the CSP, the fourth ventricle is always wider than longer, which is what was called as the fourth ventricle index, and this has to be more than 1. If it's less than 1, which means the fourth ventricle is longer than wider, then you have to suspect serious abnormalities of the vermis in the absence of an open fourth ventricle sign. So it's going to be a very important clue to diagnosing conditions like Joubert syndrome and related disorders, rhombencephalosynapsis, pontocerebellar hyperplasia, cobblestone malformations, and so on and so forth. In each of these cases, the fourth ventricle may not be open. So you will not have another clue but to look at the fourth ventricle index. So once we are done with the ventricular system, we come to the third of the axial views, which is to look at the brainstem. Here again, this is not part of your conventional view, so we'll have to move slightly cauded from the transthalamic plane. You can see that the midbrain is below the thalamus, so I move my probe caudal, and then I can see a beautiful cap-shaped or a hat-shaped midbrain that we are so fond of seeing in anatomy textbooks. So you can actually image the midbrain if required. And like my friend Dr. Khurshid always mentions, it's also a good practice to look at the midbrain complex, or the cisterns around the midbrain, the interpeduncular, the ambient, and the quadrigeminal cisterns. Lastly, in the axial views, we come to the posterior fossa structures, again very important structures in the axial views. Here you look at both the cerebellar hemispheres, the vermis, and the cisterna magna. Now you would of course not rely on this one view to diagnose abnormalities of the posterior fossa, but this again is good practice to document these in the axial sections, because here is where you're going to diagnose the open fourth ventricle sign. And then comes the sulcations in the axial views. The only two sulcations that you need to really document in the axial views would be your lateral sulcus and the parieto-occipital sulcus, because these are best seen and appreciated in the in the axial views of the fetal brain. So the lateral sulcus down there and the parieto-occipital sulcus best seen in the axial views. So once I'm done with my axial imaging, I decide to shift on to coronal sections. Now the point that we need to understand about coronal sections is that when the fetus is in a vertex presentation, you're imaging coronal sections like this, you're cutting it like that, and what happens is the parietal bone again comes in your way, which is why coronal sections in a vertex presentation is always best done by a transvaginal route, because there you're aligning your transducer with the sagittal suture. So you can see between the bones, and that gives you much better views of the coronal sections of the brain. That's why coronal views are always much better seen in the transvaginal route. There are of course 4 coronal sections, again not important. What you need to see is a continuum. The first thing I'd look for is the interhemispheric fissure. Intact interhemispheric fissure is best seen in this view. If there is holoprosencephaly, you will find it very clearly in this particular view. So I look at the interhemispheric fissure and the 2 frontal horns, and of course also in the frontal views is where I would look at the olfactory and the cingulate sulci. Cingulate sulci, of course, I would look in the sagittal views as well, but this is one of the first views of the cingulate sulci that you can get. And then comes the transcaudate plane, where again we look at the anterior complex in the coronal views, the 2 caudate nuclei there. You can get a very clear view again of the interhemispheric fissure, the corpus callosum, the callosal sulcus, the frontal horns, and the CSP. The lateral sulcus again can be imaged in the coronal sections, either in the transcaudate or in the transthalamic or somewhere in between. So this is again the view that you would want to use to look at the germinal matrix zone, because that's the site that you can get an intracranial hemorrhage first. So that is where you would look at the germinal matrix in the coronal views. And then comes the third ventricular position. That is the position of the third ventricle and its recesses. In corpus callosal agenesis, you would find a high riding third ventricle, which is again best appreciated in the transthalamic coronal views. The transcerebellar plane for the coronal section is best used to see the calcarine sulcus, because this is the best view that you can see it, because you cut perpendicular to the calcarine sulcus. You can also use this if there's a suspicion of a posterior fossa anomaly to try and look at the choroid plexus position as to whether it is up or down. And then we move on to the sagittal views. Again, sagittal views, if you have to align yourself with the transducer, it's best done when you go transvaginally, which is why you get good pictures of sagittal views in the in the TVS sections. But if the fetus is in breech, you have a problem, you cannot do a transvaginal scan, then you would use this technique of asking the patient to sit up and lean forward so the stomach falls forward, and then you can use the sagittal views through the sagittal suture to get good sections. So in the sagittal views, the first thing I would document is the position of the tentorium cerebelli. Now remember, the normal insertion of the tentorium cerebelli has to be at or below the level of the pontine belly. So anything above that is an elevated tentorium, which is one of the classical hallmark features of a Dundee-Walker malformation. And once I've documented the tentorium, I then look at structures above and below the tentorium. So above the tentorium, first and most important structure would be the corpus callosum. I look at all the parts of the corpus callosum. I measure the length if I feel it is small. And if required, if I feel anything suspicious, I can also take a look at the pericallosal artery for documentation sakes. The other midline structures, of course, would be the tila choroidea, the roof of the third ventricle, the tectum of the midbrain, the cerebellar vermis, the pons, and the medulla as well. Now, once that is done, I move from the mid-sagittal to the parasagittal planes. I try and look at both the parasagittal planes, which is the best view to look at the three-horn view of the lateral ventricles. I look at the ventricular border specifically to see if there are any bumps. I look for signs of hemorrhage. I look at the choroid plexus. I look at also the caudothalamic groove. Even though you can see it in the coronal planes, you also get a very clear picture of the caudothalamic groove in the parasagittal planes, and that is where you would expect to see the caudothalamic groove. Lastly, in the sagittal planes, I'll also make it a point to document all the convexity sulci in both the mid-sag and the parasagittal planes. So then I come to the infratentorium. I look at the most important structure there, which is the vermis in the brainstem. And if required, I can also look at the morphology. I can measure the craniocaudal and the anteroposterior diameters of the vermis. And maybe if required, if there's a suspicion of a posterior fossa anomaly, even the brainstem vermin and the brainstem tentorium angles. So if you follow this continuum process of evaluation with these sections that I've just described, you've looked at the head size, the midline forks, the CSP, all these structures. What we've not looked at is basically the vascular malformations and the clastic lesions, but I'm sure if you followed this protocol, you would pick up vascular malformations or clastic lesions somewhere in between these sections. They're not outside the brain. They're well within these sections that we've just described. So it's not that you have to go and specifically look for these as separate sections. So we have covered all the 10 target points of the targeted neurosonography in under 10 minutes. I know it's a lot easier said than done. It took me years to get there. But of course, all of us have to start at some point. Well, there are tips and tricks to do it, of how to make the best use of your machines to get to these views, but that's for another lecture sometime later for want of time. Thank you very much for your patient listening.
Thank you, Dr. Vivek Krishnan. Next, I would like to call upon stage Dr. Khurshid Alam. He will be speaking about color Doppler during targeted scan, cosmetic and diagnostic value. He is a consultant of fetal medicine, currently working at Fetal Medicine Consultant and Fetomat Foundation and Care IVF Center, Kolkata. He has several publications to his credit. He has presented at various national and international conferences. He has authored several chapters in textbook, and he is also a past fetal medicine fellow from Mediscan.
So good morning, everybody. I would first like to thank Suresh sir and the entire CUSP team to call me upon to talk in front of such a big gathering. And I would admit at the onset, I am nervous and I'm also excited. Nervous because to talk in front of all the experts, and excited because this was my dream to come to podium on the CUSP. So to get rid of my nervousness, I want to just show some game changer. And I'm sure all of you are having smartphones. I don't mean to put it on silent mode. I just want all of you to just look at what is the meaning of ushers. It's an anagram I want to show. By changing the alphabets, can we create a better meaning out of it? So usher means basically to guide somebody, to show the light. And if I do an anagram trick, it comes to this gentleman. And if you have better example, if you don't have a better example, you can clap for this. Because this is a game changer, and he is really a game changer of my life to shift from radiology to fetal medicine practice. Now, this was the topic given to me by sir, and I would just like to give you 5 messages in my talk and see how it goes in that time of 15 minutes odd. So what is the evidence when we are doing color Doppler? The evidence in the current article 2022 ISIOC practice updated guidelines is they have not emphasized on pulse wave Doppler, but they have gone on and said color flow Doppler imaging should be encouraged and can assist in examination of fetal heart and vessels. Then coming on to the more focused article just on Doppler velocimetry, again on ISIOC side, they have shown in this article how to perform, but at the same time, the safety precautions which we should take. Now, these are the various gamuts of color flow imaging modes, and we all in the high-end machines are used to using that, but I will just like to clarify how much value does it add in a day-to-day practice. Now, coming on to how far can we go? So when we answer these questions, I would like to play some of the clips which was done in a silhouette mode plus color plus magic cut to show you, to give you a 3D dimensions, and last but not the least to impress you with all these imagings which I have done. Now one thing is sure, what I can do from here is I can go to the best image contest, and I'm sure I can get at least, maybe not first, second, third or fourth, fifth, whatever. But we understand the finishing line is same for all these contests, but the starting points are quite different. We are working on all different ends of machines, and hence it's not justifiable to reach the finishing line with different kind of gadgets. Now, the important concept which I'd like to give is how close we can go, because this is more important. And still the bread and butter vessels, are we doing them properly? Look at the Doppler standardization. We'll begin from uterine artery, how we have to insunnate the uterine artery at the crossover of iliac vessels, downstream 1 centimeter or whatever, we never measure it. And then you take waveforms on both the sides. Look at the peak systolic velocity. Only take those waveforms which have peak systolic velocity 60 and plus. And then you calculate, if you have a uniform waveform by auto method, see the PI and then take the mean PI. And then you can put it in calculator and see whether it is normal, increased or whatever. Similarly, looking for the umbilical artery and the middle cerebral artery, again follow the basic standardization, follow basic rules to get a good waveform envelope, from where you can extract all your necessary informations. And ductus venosus, I still remember my days in my Mediscan days when I used to struggle for this ductus venosus, and then I called upon Jayanti ma'am, and she came and she taught me how to do it, catching my hands. I'll never forget those moments. So the standardization is very important before we interpret. Don't mistake this. I'm not out. In cricketing sense, this means out, but this is actually my first case. And this was the second opinion for abnormal umbilical venous connection to right atrium. So when I started looking at this case, I felt, okay, yes, there is abnormal venous connections, umbilical vein directly draining into right atrium. But later on, I even did a kind of 3D, 4D stick, and I was very convinced. But as I was scanning, I realized that no, this ductus venosus, if you see with normal color mode, it is just in the grayscale and color you watch, it is just interrupting. Abruptly it is ending there, it is not going anywhere further. And the vessel which appears to be connecting is nothing but the left hepatic vein. So it is very important to understand those basic concepts. Then I decided that let me clarify this topic one and for all. So this is the basic diagram. I want all of you to understand how the different connections of precordial venous system happens. So we understand this, how aorta rises, the course of IVC draining into right atrium, and then the umbilical vein continuing as the left portal vein and then giving branch, and then continuing as a ductus venosus, and finally with other hepatic vessels draining into right atrium. So once we understand this basic pictorial diagram, we will be in a better shape to appreciate when any abnormality pops in. Like if there is interruption of left portal vein and you cannot demonstrate any connection in different views, then you are almost sure that this could be DV agenesis. Of course, you have to do other views. And then if you see umbilical vein extrahepatic course draining into right atrium, then again you know there is an abnormal umbilicovenous systemic connections, and then accordingly you have to tailor their follow-up and you have to counsel the patient for volume overload conditions. Then there might be, there is ductus venosus is not there and is directly draining into IVC, then again you will have hemodynamic overload situations, or you may see umbilical vein draining into iliac vein and from there into IVC and into the atrium. So these are the basic pictorial diagram which I would like all of you to remember, and that's why I put in my slides to share my experience with you all. Now again I called back this patient after 2 weeks, at 20 weeks 2 days, and then I was very sure that this umbilical vein going as left portal vein, and then it is not going any further and just it is interrupting, and color Doppler further gives value to whatever I have seen on the grayscale. Now, apart from sagittal, we can go into the axial imaging, and axial imaging we know we have efferent system in the form of portal vein and umbilical vein, and efferent system in the form of hepatic and IVC, and there is a connection of ductus venosus between them. So if you compare with the control image, in this part you will not see any connection of ductus venosus. So this was DV agenesis. Now case 2, this patient came as a second opinion for echogenic intracardiac focus, and I am sure all of you know how to proceed with this. And we did the same, we switched on color Doppler, and then we saw there was a aberrant right subclavian artery. And what does this mean apart from counseling, standard counseling? That when you put all this in the chart, we know this is the standard format, you can download this, and LR of combination is 1. If it is only echogenic intracardiac focus, it does not change the LR. But if you add on apart from echogenic intracardiac focus, aberrant right subclavian artery, your LR of combination goes to 28 times. And what does that mean? The final risk was initially 1 in 5,000, which shifted after recognition of aberrant right subclavian artery to 1 in 174, and then you have to counsel the patient accordingly for direct procedures or for NIPT, whatever they wish to go for. Or it may be just a normal variant which happens in about 1.5% normal population. Then in case 3, this was the case where when I tried to see for the V sign, I instead saw a U sign, and then there was trachea in between, and there is also, if you closely see, there is ALSA, aberrant left subclavian artery originating. Why I am showing you this slide is because whenever you see such kind of situation, don't be satisfied, take an oblique section, go a little bit cranial, and try to see if that aorta is even bifurcating anterior to trachea. Because if it is bifurcating anterior to trachea, this is not a double aortic, this is not a right aortic arch, it's a double aortic arch, and the counseling and the management changes. This was a study which showed, apart from these 3, I just want you to focus on this section where intervention is required in around 40% of the cases of double aortic arch, because whenever we see double aortic arch, we always tell them to follow up postnatally, not by fetal echo, but by CT or MR angio, because they may result in irreversible tracheobronchomalacia, which is an irreversible situation. So we have to caution the patient not to take it lightly, even before the symptoms develop in the fetus, in the newborn, just get an assessment done and meet a pediatric cardiologist and do according to the situation. Now, case 4, this was the case when I started scanning. I saw echogenic intracardiac focus. Rest of the cardiac views were normal, except I was finding little bit uncomfortable when I am seeing the LVOT, because the aorta distal to the valve is little bit, it appears little bit more prominent. So I put on color Doppler, and then you can see aliasing happening just distal to the aortic valve. And for you to compare, this is the control image where you see a normal laminar flow in the LVOT. Then we switched on pulse wave Doppler, and we see the velocities were 128. Again, we called back, we counseled the patient for aortic valvular stenosis, post-stenotic dilatations, evolving coarctations, and all those stuffs. And again, we called back the patient at 27 weeks, 5 days, and now you can see the things have progressed little more. You can see post-stenotic dilatation little more prominent, color aliasing, which shows high velocity flow, which is quite expected in this kind of situations. Now, I did a stick, and in the stick you can see how the aortic valve behaves in the short axis view, the doming of the aortic valve, and this is the picture taken from Rabicio's book, and then most likely we felt it can be evolving bicuspid aortic valve, which may eventually develop into coarctation, and we need to follow it up postnatally very carefully, because those conditions may require balloon valvular dilatations and other prosthetic surgeries depending on what kind of situation it is in and the choice of pediatric cardiologist. Now, this is my last and 5th case, and we understand the most important aspect of Doppler is in assessing uteroplacental circulation, and whenever we discuss FGR, this is our most cardinal slide. We always show early, late, and what are the criteria, the Delphi consensus. I'll not go into this. I will not either go into the stages of FGR because you all are aware of it. What I want you to just understand this slide. Like whenever we see FGR, which ventricle if fails has had a bad prognosis. And to answer them, you first need to know the ABC of the circulation, and I am sure you all know that. How does the circulation happens? Around 30% in a normal situation is shunted across the ductus venosus. We have 3 shunts, and in cases of FGR, there is more blood which is shunted towards the ductus venosus, and also there is more blood which is shunted towards the vital organs, and there's a cascade of events which arises from placental dysfunction to high impedance flow in the umbilical artery, leading to redistribution, centralization. Remember, redistribution is reversal in the aortic isthmus, and centralization is what we say about the brain sparing effect. So these two are different terms. Then eventually hypertensive right ventricle, and that will eventually cause increased pressure in the right atrium, which will be transmitted to ductus venosus, which may lead to A-wave abnormality in the ductus venosus. Now, after this, there is a phase of cardiac remodeling, and once this starts happening, there will be a point when cerebral circulation also starts dampening and left ventricle starts failing. So this is the end stage, left ventricle failure. There are safety concerns when we use too much of Doppler, and also we understand that attenuation equal to absorption plus scatter. What we see on the screen is the scatter, and what we don't see, the heat which is created, is the absorption. So we have to be careful with that. And then there are guidelines at what TI we should be scanning for what period of time. You can download them, but the point of care is like, don't do unnecessary Doppler for unnecessary period of time. Do them when it is needed and when you have questions in your mind. So everything should be made as simple as possible, but not simpler. Thank you so much for your patient hearing.
Thank you so much, sir, for your lovely presentation. I would like to call Professor John Hyatt on the stage for discussing fetal growth restriction with normal Dopplers.
Okay, thank you. Okay, so this is a trick question, fetal growth restriction. I thought, oh, that would be good. I can talk about progression and abnormal Dopplers with normal Doppler. So, fetal growth restriction as a surrogate for trying to identify stillbirth. So these are causes of stillbirth in Sydney, Australia. One of my colleagues did her PhD on this, classified all the stillbirths that we had in New South Wales over about a 5-year period, and approximately 13% of them could have been identified as being associated with fetal growth restriction. And if you then just look at potentially modifiable outcomes or preventable stillbirths, then this accounted for about 17% of preventable stillbirth. Another interesting fact about stillbirth, we see it relatively early in pregnancy, between 20 and 24 weeks, and that's because in Australia our classification includes termination of pregnancy for congenital abnormality. And then you can see that we see relatively few stillbirths between about 26, 28 weeks up to about 35 weeks. And then we have an increasing incidence towards term. So if I'm thinking about when I might want to time surveillance interventions, generally speaking, having your surveillance near to the point where you might have a problem is going to give you a most efficient screening test. So that might mean that we should be focusing our attention around the 20-week scan, probably in the context of congenital abnormalities, and then some point around 35, 36 weeks gestation at the back end of pregnancy. Next problem. These are my male fetuses published on a variety of different growth charts. So these are a series of about 5,000 women who had a routine scan at 36 weeks. It's the same data set on each chart, but the charts are different. You can see, for example, that if you use, say, the intergrowth chart, which is the bottom right-hand corner, that we have very few babies that are growth restricted. Whereas if I'd used the Hadlock chart as an example, I'd have had many more babies that were growth restricted. So this is a very useful tool for being able to change the rate of fetal growth restriction in my population. If we look at how the charts perform, then here we've got the proportion either less than or above a certain centile, and we've got the 4 charts that we compared in this population. And you can see, for example, intergrowth 21 down the bottom, 24% of our babies at 36 weeks were macrosomic. Now, if I was very aggressive about that, that might lead me to have a 24% induction rate at 38 weeks of gestation to prevent poor outcomes related to macrosomia. But if I change the chart and use the Australian chart, the ASSAM chart, it would only be 8% of babies that were above that centile. So I think one of the issues when we're talking about data related to growth is what charts were people using? And one of your issues in everyday practice are which charts actually fit your data best. Another problem with charts, and particularly actually for birth weight charts, is that they typically report the whole population. But if you were delivered preterm, it's actually quite likely that you were also small for gestational age. So the effect of including all babies is you end up with the dotted line as a chart. If you take the same data set and exclude babies that were delivered iatrogenically at least for some reason in the preterm period, that excludes a lot of the small babies, and then you end up with the solid line. The difference in those two lines is quite significant when I'm setting centiles to define the population below a certain level. If I use the first approach to looking at the data, I'll end up with fewer babies less than the third centile than if I use the second approach. And you can also see that this is more of an issue in preterm gestations. So if you don't account for the fact that you've got this iatrogenic cohort that were delivered because they were, or one reason for they were small, you can see that you get this accelerated growth velocity through the second and third trimester. So that also means if we then had a baby that actually has a flatter growth velocity, we might start to interpret that as being abnormal as well. So I'm just trying to raise some issues with you about the validity of what charts you use, the validity of the way that they were constructed, and whether they truly fit your population. This was a study done in Italy, I think, looking at a randomized controlled trial of the value of a third trimester scan. And it showed that a third trimester scan would identify 38% of growth-restricted fetuses for a false positive rate of 6.4%. And 1 in 2 of those that you identified as being high risk actually growth-restricted. The positive predictive value, the positive likelihood ratio is not bad, it's 6. The negative likelihood ratio, 0.6, not particularly good. If you're trying to develop a screening test, ideally you don't want those numbers to be 10 and 0.1. So we don't quite meet the criteria for a good screening test. On the right-hand side, you can see another problem that we face. If we start screening the whole population at 36 weeks, we will identify a cohort of babies that are apparently small. Is that going to trigger an obstetrician to immediately deliver that pregnancy? If it does, you can see that for every week that you're delivered before 40, 41 weeks gestation, you have an increased special educational needs in school. And that potentially is a fairly significant burden if we start instituting a screening policy at a slightly preterm gestation. So remember, if you have a small baby, there could be something else wrong apart from growth. This is a study that identified a variety of different fetal abnormalities at the time of a 36-week scan. So just because we picked up 2/3 of anomalies in the first or second trimester doesn't mean we won't necessarily see some anomalies later. Remember, infection is often associated with fetal growth restriction. You can look for the markers of infection: hyperechogenic bowel, ventricular megaly, intracranial cysts, and here we have intrahepatic cysts, and you can see some hydrops as well. So it's important when we have that small baby that we do a proper anatomical survey to make sure we've not missed a structural abnormality, we can't see any other markers of infection. And indeed, we would typically also do a torch screen for all of this population. This is a very nice painting of chromosome 17 that's in the medical genetics department in Vancouver. And the slide just illustrates the fact that the tools that we have available to us for genomic analysis have changed significantly in the last 50 years. So 20 years ago, if you'd asked me, should the small third trimester fetus be karyotyped, I would say, well, there's probably not a lot of value, because the conditions that we traditionally thought about that were associated with a small baby, trisomies 18 and 13, usually they'd have lots of structural abnormalities as well. It wouldn't be fetal growth restriction in isolation. But we now know that in terms of if you did an array in this population, about 5 to 10% of these babies will have a microdeletion or microduplication that you would not otherwise have detected. And at the moment, certainly in Australia, there is some debate about whether we should stop at the array level or whether there's value in other targeted panels for conditions that we know are often associated with growth restriction, but we have a lot of difficulty identifying prenatally. One example might be Cornelia de Lange syndrome. Or should we do something that's less specific and do exome or whole genome sequencing? So we're having that debate at the moment. It's not part of our clinical practice. So let's think about the fetus now that we've got in front of us. A small fetus, and we've been told it has normal Dopplers. Well, that doesn't necessarily mean the fetus does not have or is not in a pregnancy that's got placental insufficiency, because you can see that the reduction in growth velocity and then no growth is on the left-hand side of this chart. So this might be a precursor to what we're going to see in the context of these compensatory and then decompensatory changes as the pregnancy progresses. So perhaps the first issue is we have a small fetus, we need to recognize there is a risk, and this pregnancy will need ongoing surveillance. So what's the risk? I'll show you two data sets, both Australian, that identify levels of risk in small babies. So this goes across gestations from 24 to 42 weeks, so it's both preterm and term, divides the population into appropriately grown and small for gestational age babies. The small for gestational age babies are the slightly light grey curves, and you can basically see that rates of perinatal death, stillbirth, neonatal death are higher at all gestational ages. Another way to look at this study basically divided the population into deciles, and so you can then see that in reference to a 40th to 60th centile population, actually you have an increased level of risk, both if you have a small baby and in fact if you have a large baby, but the risks are much more significant if you're small. And you can see, for example, if you're less than the first centile in terms of your estimated fetal weight, you have about a 10-fold increased level of risk of stillbirth compared to someone who's on the 50th centile. So what are the tests that we can do to look at this population? Well, obviously the first go-to test is an umbilical artery Doppler. This is showing a normal waveform with positive end diastolic flow. This is showing you either absent or at times reversed end diastolic flow. So we have that, if you like, categorical ability to examine this. Also, we can do this by measuring the pulsatility index. In the context of having a baby that has been identified as being small, where you're then doing the umbilical artery Doppler for well-being, we've got these multiple studies done in the late 1990s that essentially show if you have absent or reversed end diastolic flow, that you have a 30-fold increased risk of perinatal mortality. But let me put that in some context. There are also 4 randomized controlled trials that did an umbilical artery Doppler in a completely normally grown baby, and it is not of any value in that population. So this is a specific test for a small baby population. We talked before about compensation and then decompensation. Here you can see the responses that you get with the different tests using, say, the MCA, the ductus, looking at CTG heart rate changes. The problem is, as we go to more advanced gestations, umbilical artery Dopplers are less likely to be abnormal in a growth-restricted fetus. So we need another test. Now, in the UK, what we do is we say, okay, well, let's take a history from our population, and by taking a history, we can put them into different groups, and that means we can just do biometry on people that we perceive are at increased risk. Another way of doing this is to use a slightly more complex algorithm to identify a high-risk group, but it has better specificity. But beware, because about 2/3 of babies that have stillbirth at term are actually normally grown. So just looking at the biometry is not necessarily going to be useful if we want to predict these babies. I think there are two other tests that we could potentially do, specifically in the late preterm or term cohort. The first is to use the marker PLGF, and this is just a demonstration of how PLGF is reduced in the red line and the black line in pregnancies affected by preeclampsia. Preeclampsia is often also associated with fetal growth restriction. This is data summarizing a systematic review of use of PLGF to predict stillbirth in the third trimester. It's the green curve is the PLGF data, so it seems to be the best biomarker that we have for prediction of stillbirth. This is data looking at using PLGF in a population of babies already identified as being small. It triages them into 3 groups, those with a PLGF less than 12 or less than 100 or more than 100, and essentially shows that if you have a very low PLGF, you have increased rates of perinatal mortality, increased rates of smallness at delivery, and increased rates of abnormal neonatal outcome. The second tool that I think we should be considering using at the end of the third trimester is the MCA Doppler. We need to be careful to make sure that we identify it properly within the circle of Willis and sample it at the appropriate point. We know what the normal range looks by, but we can actually put it into an algorithm with the umbilical artery Doppler called the cerebral placental ratio, and essentially if your value is less than 1, that is abnormal. People have looked at whether we can use this as an effective way of screening for a variety of different adverse outcomes. You can see them listed on the 4 charts. And essentially, although this is associated with these abnormalities, you can see that the detection rates down the bottom are actually relatively poor. CPR has been useful in identifying a population that are more likely to have problems during the course of labour, therefore may end up with caesarean section. So finally, the 2 tests I've shown you that I think are likely to be useful, I would say are still in a research phase at the moment, both PLGF and CPR ratio. So the next question as an obstetrician is, if we identify a small baby with normal Dopplers at term, should we continue with surveillance, or should we just deliver the baby? And this is data from the ARRIVE trial that showed almost significant reduction in their primary outcome measures, which were related to bad neonatal outcomes. So there is a suggestion that inducing women at 38 weeks of gestation may actually be one way of, if you like, preventing an event that we're poor at predicting over the remaining few weeks of pregnancy. So I think I've presented you with more questions than answers. I did that on purpose. I look forward to the next CUSP meeting and being able to come and learn from you which of these tests and which of these approaches we should be using. Thank you.
Thank you, sir, for a wonderful talk. Now I would like to call upon Dr. Uma Ram. She is a director and consultant of OB/GYN in Sitapati Clinic. She is a chairperson of RCOG AICC South Zone. She is an MRCOG examinee and she is a compassionate clinician with high ethical values and a great motivator for younger generation into research. She has lent her lot of obstetric support to Mediscan and is a main person putting together the scientific program community for CUSP. She will be taking us through the topic of optimal timing of delivery after fetal therapy.
Thank you very much, Jyoti. Well begun is half done is a very often quoted statement which people debate the meaning of. Of course, part of it means that we need to make a beginning and do it well. But equally, having started a process, you need to persist with it and continue to do good work to ensure that the outcomes are good. And I think it is with that thought in mind that I've been asked to speak about optimal timing of delivery after fetal therapy. Probably also because in the milieu that we practice in, often care is a little bit fragmented with some centers of excellence offering fetal therapy, and often the final delivery and the obstetric outcome happens in a remote location, and the settings across India where delivery and neonatal care is provided can be very varied. So what you may get in a cohesive tertiary center where you have a comprehensive maternal fetal team may be quite different from what you may get if the couple are going back to access care in a setup which is not tuned to taking care of such problems. So we'll go through a few case scenarios to illustrate the points that may be there that one has to keep in mind, because the body of evidence to actually guide when we deliver which baby is not that strong. So the first scenario I'd like to present to you is a 37-year-old, gravida 3 para 2, 1 live birth for a cesarean section, after which no anti-D was given. She was Rh negative. The second cesarean section was done at 36 weeks, unsure what the reason for that indication was. This baby was born 2.5 kilos, was discharged home, brought back with severe jaundice and neonatal anemia, and died in the 10th day of life. Now, unfortunately, this is a scenario that happened in a metropolitan city in India. The couple were told that she had atypical Rh antibodies and therefore the baby had that outcome. She booked with us at 10 weeks and an ICT done was positive. The mother was completely evaluated and an RBC antibody extended screening was done. She was Rh negative. There was no evidence of KEL or any other antibodies. The couple were counseled and the follow-up protocol was put in place. Her first trimester screening, she screened positive with a risk of 1 in 111. NIPT was done and it showed a low risk. At 18 weeks, an anatomy was normal and there was no evidence of fetal anemia. However, she was on the routine follow-up of a Rh-isoimmunized pregnancy, and at 26 weeks, the MCA-PSV went up and she had her first intrauterine transfusion. After the transfusion, the follow-up continued, the baby was doing well, and at 32 weeks, when the estimated fetal weight was about 1.67, the MCA-PSV started to go up again. And at this point, the couple were counseled about the need for a second transfusion. However, they had a friendly relative neonatologist who told them this baby is 32 weeks, the weight is 1.6 kilos, we have a fantastic NICU now in the city, you can deliver and we'll transfuse the baby and we'll take care of it. However, the couple came back because they were conflicted with the advice that they had got unsolicited, and after counseling, they decided to go ahead with the second transfusion, which was done at 32 weeks. and 3 days, and subsequently the baby continued to follow up and do well. And at 35 weeks and 4 days, the estimated fetal weight of 2.1 kilos and MCA-PSV was 1.07. This baby was then electively delivered at 37 weeks because we were confident that the transfusion was given and we could hold on for up to 3 weeks because the previous transfusion she had pulled on for 5 weeks, and she delivered a 2.3 kilo baby by repeat section because she had already had 2 previous sections. The cord hemoglobin was 15.2. Bilirubin was 4.4, DCT was positive. The baby received intensive phototherapy and IVIG in the NICU, didn't need any transfusions, is 1 year and 3 months old now and doing well. So in RH isoimmunized pregnancies that require transfusion, timing of delivery is dependent upon the timing between transfusions, and from which we can predict whether this baby is going to be anemic or not, and the gestational age, and roughly we aim to deliver time the last transfusion in such a way that we could deliver about 3 weeks from the last transfusion, and if it is possible, take to 37 weeks at least, so that the baby does not have an additional burden of prematurity. And if the baby is not anemic, one could induce unless the section is obstetrically indicated. If you have an alloimmunized pregnancy in which there is no intrauterine transfusion done and the MCA-PSV remains less than 1.5, you could deliver at 37 to 38 weeks. But if the MCA-PSV starts going up after 35 weeks, you would deliver and then treat, because that may be easier to do in the neonatal unit. So timing of delivery after any fetal therapy really has to be well orchestrated. And it's important that all the team players work together to ensure that they give their best input to the couple. And by that I mean the fetal medicine specialist, the obstetrician, and the neonatal unit. However, because sometimes, as I said, in our context in India, you do have couples going back into public hospitals or sometimes smaller towns where there isn't that much of familiarity with complicated fetal procedures. You have to work together, maybe get on the phone, do a call, so that there is some direction that is happening. Equally, the only point I want to make is the obstetricians taking care of such women, need to know what is going on, because otherwise there is a tendency for us to just become technicians who do a cesarean section or a delivery when the neonatologist tells us it's fine for you to take out the baby, and that's something that we must guard against. The next scenarios is a 22-year-old Gravida 2 who was referred with an MCDA with polyhydramnios at 30 weeks. And this MCDA twin was scanned and there was diagnosis of TTTS stage 1 with severe polyhydramnios, discordant for LICA bladder and growth, with a twin A having an SVP of 25 and twin B having anhydramnios and a 23% weight discordance. They were concordant for Doppler. Because of the gestational age, amnioreduction was done under steroid cover because of the chance that she may actually go into preterm labor, and these babies were at a salvageable gestational age. Post-amnioreduction, both fetuses were evaluated. The anatomy was normal. They were followed up, and at 31 weeks and 4 days, this was what the charts were looking like, and when should we deliver. We have to keep in mind that we have not corrected the problem here. It was just an amnioreduction for acute TTTS that presented late, and there is a significant chance of intrauterine demise of these babies, and therefore this couple was actually advised and recommended delivery around 32 weeks, but the obstetric unit advised to continue the pregnancy, and they came back at 33 weeks and 4 days, at which point this was the finding with the Doppler of the first baby showing high resistance umbilical and high resistant ductus venosus, fetus B showing severe oligohydramnios, suggesting that the TTTS was re-established with absent and reversal of the umbilical artery. A report was given suggesting immediate delivery. However, The delivery was only scheduled 2 days later, and at delivery there was an intrauterine fetal demise. And this is a very unfortunate set of circumstances because these babies were potentially could have been salvaged and have been given a good outcome. And again, this is a case being presented to make a point that coordination and communication and a joint decision is extremely important. If communication gets fragmented, then the people who lose the most are the couple under our care. The third scenario is an MCDA twin referred at 24 weeks, discordant for growth, Leica and Doppler, concordant for bladder. The weight discrepancy was 67% with features suggestive of stage 1 TTTS and type 2 IUGR and a CHOP score of 3. The couple were counseled for a procedure because of the risk of intrauterine demise of the second smaller twin. Both laser and RFA were discussed with pros and cons, and radiofrequency ablation was done. Now, post radiofrequency ablation, you can see the follow-up. This baby is growing quite well. And at 35 weeks and 3 days, this was the weight, 2.2 kilos with normal Dopplers. And she was counseled, and delivery was planned at 36 weeks, and we had a good outcome with the baby doing well. The slides are not moving. Can you move it? Okay, so in contrast is another case situation where there was an MCDA referred at 19 weeks with one fetus having hydrops and cardiac anomaly. After ensuring chromosomal normalcy, the RFA of the hydropic fetus was done at 19 weeks. And again, you can see that post-RFA, this baby was growing extremely well. The Dopplers were normal, and we reached 36 weeks, and the couple was recommended and advised, and delivery was planned, and this is how the baby was looking at 36 weeks. However, as sometimes happens in our country, the couple insisted on an auspicious date, which was 4 days later, and unfortunately on admission it was an intrauterine fetal demise. So despite counseling, I think sometimes these very strong beliefs result in a very unfortunate outcome, and everybody was feeling terrible at the end of it, but the damage was done. So when we talk about timing of delivery in complicated twins, we know that in uncomplicated twins, the weight of evidence is around 36 weeks. In twin-to-twin transfusion, the evidence is limited, but the consensus is generally steroid and deliver at 34 weeks. If the condition resolves, then you can possibly consider going up to 37 weeks. In SIUGR, the aim is to prolong pregnancy until viability is achieved, but at the same time, you have to watch like a hawk, basically because you want to avoid a single IUD, and it's 32 to 34 weeks roughly, and earlier if there is evidence of risk of fetal demise. Once you have done a fetal reduction procedure, then you tend to take the babies up to 36 or 37 weeks. In the last two scenarios, this one is a 29-year-old lady, gestational hypertension on labetalol, who was on labetalol, was referred at 23 weeks. There was a common placenta that was seen anteriorly with a subchorionic hematoma that was more to the right, and this is how the babies looked. The second baby was smaller than the first one, and you can see that there was the absent end diastolic flow with a high resistance of the DV. And this couple was counseled, and selective reduction was discussed, and the RFA procedure was explained. She was actually brought back in 24 hours, and at that time the smaller twin had A-wave reversal, and subsequently a RFA procedure was done. At 32 weeks on follow-up of this baby, there was a growth drop from the 40th to the 24th centile, and the baby showed a high resistance umbilical type flow with the other Dopplers being normal. So the question was, should we follow up or should we just deliver this baby, because clearly this baby is also starting to get into trouble. But I just want to highlight the fact that we shouldn't forget about the mothers in these procedures. We need to look at the mom. This mother had a UTI treated a week ago. Her labetalol dose over the course of that few weeks had increased from 100 TDS. When she came back the following day after the scan, her blood pressure was 170 over 110 with 2+ of protein, so there was no question of any conversation. We had to admit her and a cesarean section was done and the baby was 1.53 kilos. So we have to look at the mother and other complications which may help us make a decision for earlier delivery because these mothers are at risk for higher complications. The last scenario that I want to project is a lady in whom a fetoscopic laser was done for TTTS. And, she presented with dysuria, treated for UTI, and presented with PPROM at 29 weeks and 5 days. Now, should we just go ahead and deliver her, or can we conservatively manage this woman? We actually did manage her conservatively, gave her steroids and antibiotics, monitored the mother and the baby. We managed to gain about 10 days, delivered her at 31 weeks and 3 days, and both babies are doing well, and it's been a few years now. So in conclusion, the reason I think we have spent some time in this meeting to talk about timing of delivery is because in our country, NICUs are able to, there are many NICUs which are able to handle a lower gestational age and get good outcomes. However, the ability of the NICUs and their outcomes vary. Also, these babies, even if you have a NICU that is doing well, you don't want to add the burden of extreme prematurity simply because you want to get this baby out and hand over a live baby, because we know that there is an increased burden of disability, and especially in complicated twins, their burden of neurological disability is slightly higher than other fetuses. So we have to take a cohesive decision keeping maternal factors in mind. And again, unfortunately, in our context, we have to bring cost into the equation as well and have a discussion so that couples are prepared for the cost of neonatal care after delivery. It is not uncommon for families to throw up their hands after a week or 10 days because the cost of NICU care is something that they can't meet. So while it is distressing, that is something that we have to also discuss. So it is a cohesive and coordinated effort. Otherwise, like this discoordinated skull team, will be hitting in each other's rows. But if we work as a team together, then we can do a wonderful job with good outcomes. Thank you so much for your patience.
Thank you so much, ma'am. There's an announcement for everybody. The TNMC credit points will be given only to those who will sign the paper physically. You can go to the TNMC counter at the entry and then you can sign the paper. Otherwise, one paper will be circulated in the hall, and that paper you should write your name in capital letters and your TNMC number. Moving on to the next talk, I would like to call upon Dr. Lata S. and Lata Paramereshwaran for discussing about the placental morphology. Lata ma'am she's a senior consultant sonologist at Mediscan. She's passionate about teaching and training of fellowship students in ultrasound, and she is an accomplished Carnatic music singer. And Dr. Lata Murlidhar, she's a senior and renowned pathologist from Mediscan. She's the HOD of Perinatal Pathology Department. She has established the Department of Perinatal Pathology 2 decades ago. She has thrown light to several families by offering meticulous pathology diagnosis. She is a daughter of a very fine-hand surgeon and has inherited all the skills which she exhibits in her autopsy dissections.
Either?
I think it's afternoon already. Good afternoon, everyone. I think after Uma spoke about it, we are going to speak about the placenta, which is going to be delivered, and we have a pathologist who is going to say, okay, are we right? The ultrasound appearance of placenta always changes over the period of time. Like you can see that by 12 weeks, it's more echogenic. And by about the mid-trimester, like when we are doing a target scan, you see you have a well-defined placental localization. You are able to see the rule of 3 is maintained again here. You see the chorionic plate well, the placental substance is well seen, and you see the retroplacental space too. In the era of standardization, I think we should stick on to the ISHWAG guidelines, which also has the rule of 3 in it. So you have to localize the placenta and relate the lower edge of the placenta with that of the internal os, and the placental substance has to be seen. When you look at the placenta, there's gradual change in the echo texture of the placenta right from your first trimester. You move on to your term placenta, there is a lot of heterogeneity. So this is what she's going to explain about how this change in echo texture is.
So when you look at the placenta grossly, there is a change, distinct change from the first trimester to the third trimester. Initially, the placenta, size-wise also, although it increases in size, relative to the fetus, it reduces in size. Like 12 to 13 weeks, you can see that the placenta is not very cohesive. You cannot make out the cotyledons very clearly. And microscopically, you see that the villi are large, the stroma is abundant, the capillaries are fewer in number and present towards the center, and the trophoblastic layers are double, the cyto and the syncytial trophoblast. At mid-trimester, the cotyledons are a little better defined, the placenta is more cohesive, and the villi are smaller, more in number, the blood vessels are better defined, they start moving towards the periphery, and the cytotrophoblast starts to disappear. Whereas if you look at the full-term placenta, you can see that the cotyledons are quite compact, and the villi are small, the stroma is less, the blood vessels are more obvious, and they are present towards the periphery, and the intervillar space is also more, and this ensures efficient transfer of nutrients and oxygen across the villi, and the cytotrophoblast is completely disappeared, and you have only a single layer of trophoblast. But initially, the fetus and the placenta, the feto-placental ratio is about 0.6, but towards the term, it becomes 7. So the fetus is about 7 times the size of the placenta later, although the placenta is much more efficient organ now.
So okay, I'm sorry. So we are going to touch on the implantation of the placenta. A normal successful normal implantation of the placenta is widespread over the entire, you can see it here. It's almost all over the myometrium. So that is a good placenta because we need a normal implantation for a successful pregnancy. Why is that important? Because a small area of implantation is definitely the clinical implication behind a small area of implantation. There is restriction of growth because less vascularity, there might be uteroplacental insufficiency, and incidentally this came as a differential diagnosis for chorioangioma. You can see the drop in the parameters and also changes in the Doppler. So that, how does it appear?
The small area of implantation is not a pathology diagnosis, but this fetus was, and the placenta was sent to us after being diagnosed as having had small area of implantation on ultrasound. The fetus had severe IUGR. The gestational age was corresponding to only 20-21 weeks on biometry when it was actually around 25-26 weeks by LMP. And the placenta was also small. It weighed only 70 grams, which is small even for 20-21 weeks. On sectioning, the villi were congested. And on microscopy, you can see that the villi resemble the third trimester placenta. The villi were small with dilated blood vessels, dilated and congested blood vessels, and very little stroma and increased intervillar space. So this villi, which appears older than it is a sign of chronic hypoxia, while dilated congested blood vessels is that of acute hypoxia. So the diagnosis we gave was acute on chronic hypoxia in a placenta with small area of implantation.
So I think then that explains the uteroplacental insufficiency too, right? So we move on to the circumvallate placenta. This we commonly report in our examination of the placenta, and we see there are rolled out margins. And it's mainly because of the fold of the chorion and the amnion. If you see, this is a normal insertion of the membrane on the edges of the placenta. But in circumvallate, you can see it's almost at the center. So this gives an appearance of the chorionic plate being smaller than that of the basal plate. And this is an extrachorial placenta. So we need more information on that. So how does that affect?
That is a normal placenta with, where the membranes are inserted normally. Here you see it is inserted around the edge, and on the cut section also you can see this is the basal plate, this is the chorionic plate, and the membrane insertion is at the edge. Whereas in extrachorial placenta, of which circumvallate is one, the membranes are inserted towards the center and away from the edge of the placenta, leaving a rim of exposed placenta, bare placenta.
So that's the extrachorial one.
And if you look, this is another circumvallate placenta where the membranes are attached over here, and this whole thing, although is the fetal surface, you can see that the blood vessels end abruptly at the margin where the membrane is inserted. And also if you look at the point of insertion of the membranes here and over here, you can see that the edges rolled out and thickened, and that is depicted over here. This is because the chorion and the amnion fold over here. And the other type of extrachorial insertion is the circummarginate placenta, which is similar to circumvallate, but there is no fold over here. But circummarginate has no pathological significance and cannot be picked up on ultrasound. So we will not talk about that anymore. Next.
So why are we concerned about the circumvallate insertion? Because when we saw this study, it said preterm delivery, vaginal bleed, subchorionic hematoma, premature rupture of the membranes, and placental abruption were definitely on the higher end. And emergency sections were also higher with patients having circumvallate placenta. So hence, documentation of the circumvallate placenta is important, and we can mention it in our report. We move on to lobes of, how the lobes appear in the different types of bilobed and succinsurate placenta. When you look at this, this is an accessory placental lobe. When you look at the size of the placental accessory lobe, it is little smaller compared to that of the main placenta. And you have a membranes running in between the placental lobes. And this membrane will carry vessels in it. So the risk of PPH and infection, if it is not delivered with the main placenta, is critical. Hence, a check ultrasound post-delivery will definitely help. So this is one kind of accessory lobe placenta, and this is the bilobe placenta. The difference between this is the accessory lobe is smaller, and here the other lobe is equivalent to the main placenta. And the cord insertion in bilobe is the center, and the cord insertion in the succinsurate lobe is into the main placenta. So this also has a significance because it might overlie at the internal os and be a precursor for placental previa and vasa previa.
Here you can see a bilobed placenta. You can see that the lobes are almost equal in size, and the umbilical cord is attached at the center. And this is the maternal surface of the same placenta, and you do not appreciate the bilobed feature over here. Whereas this is a placenta with a succinsurate lobe. This is the main placenta. This is the umbilical cord which is attached to the main placenta. This is the accessory or the succinsurate lobe, which is separated from the main placenta by this stretch of membrane. And you can see the blood vessels running from the main placenta into the succinsurate lobe through the membranes. This is the maternal surface of the same, and this is the smaller lobe, this is the main placenta, and these are the membranes.
Cord insertion documentation is also important. We do the fetal side as well as the placental side. A normal cord insertion is central, but I think we have variety of cord insertions.
These are normal cord insertions, that one is central and the other, which is more common, is eccentric, where it is slightly away from the center. But the abnormal cord insertions are one marginal, which you can see resembles this bat over here of the shuttlecock, which is called battledore. So this kind of insertion, the placenta is called the battledore placenta. This is the velamentous cord insertion, where the cord is inserted into the membranes. And here is the furcate insertion, which is quite rare, where the vessels in the cord split and they insert directly into the placental substance without the covering Wharton's jelly, and they do not insert into the membrane. So these are bare vessels which insert directly into the placental substance. So this battledore placenta with the marginal insertion, the velamentous insertion and the furcate insertion are prone for injury during delivery, and therefore have to be taken care of.
So we do see it in ultrasound too. Marginal cord insertion and velamentous cord insertion. You can see here it is inserted less than 2 centimeters from the placental edge, and in this velamentous cord insertion is into the membranes, and it's quite commonly seen in multiple gestation. So why the perinatal outcomes with velamentous cord insertion? If you see the intrauterine fetal death and small for gestational age, preterm delivery and manual placental removal is all higher in the velamentous cord insertion patients. So if you notice, this is a twin gestation, the velamentous cord insertion that we see. One of the twin had a central cord insertion, the other twin was a velamentous insertion. And about 12% of the monochorionic twin pregnancies will have velamentous insertion. And it leads to placental discordance, like placental territory discordance. Naturally, it will lead to discordant growth too. And if you look at the Mediscan statistics that we see, with the central cord insertion, with a marginal and velamentous cord insertion, the chances of selective intrauterine growth restriction is definitely higher. This was the statistics between 2018 January to 2018 June. And the risk of vasa previa is also higher with velamentous cord insertion because it's unprotected fetal vessels, so naturally it's prone for injury. So the article that I read about it, that was very nice, so I wanted to quote about it. The two-stage approach by Professor Nikolaidis and Dr. Ranjit Akulekar. It says identify the velamentous cord insertion and a low-lying placenta. Velamentous cord insertion in the first trimester and low-lying placenta in the second trimester, and use the second approach, second stage will be the color Doppler by transvaginal scan and identify the vasa previa. So this has definitely reduced the chances of stillbirth by at least 10%. So the take home will be evaluate the cord insertion on the fetal and the placental site and look for always additional lobes, because succinsurate lobe or bilobe placenta, the chances of vasa previa is higher, and reassess the lower uterine segment once you have said that the low-lying placenta. We move on to sonolucencies. We often come across in the placenta some cystic areas. Do we document it? Do we have to give importance to it? How do we approach it? So they all have maternal origin. That was, it could be an intervillous thrombus, it could be hematomas, it could be placental lakes, subchorionic fibrin, perivillous fibrin, it could be infarctions too. How do they appear? So when we looked at few of the we went retrospective. From the pathology, we went back and looked at all our placenta. How does it appear? So this is the most common sonolucencies that we came across. There is the placental lakes, and some of the placenta, can you see the swirling motion here? This is amazing. So it was, but unfortunately, this baby went in for an IUGR and did not make it and went for autopsy. And if there is a thrombus in the placental lake, then it becomes an intervillous thrombus. So this was the appearance we had in ultrasound. What did it show in pathology?
Placental lakes have no significance in pathology because we do not see them in the placenta after delivery. And it is thought to be due to distortion of placental anatomy at delivery, and therefore I cannot say anything about it.
Okay. So another important place that we always report is subchorionic fibrin deposits. Baby has an intrauterine growth restriction. We go back and look at the placenta. There is uteroplacental insufficiency. You again go back and look at the placenta. It is so non-homogeneous. There's a lot of subchorionic fibrin, and that's how we report. So baby, this was a fetus with IUGR, and there was a lot of inhomogeneity in the placenta, and we reported almost all of them as subchorionic fibrin deposits. But when it went for pathology,
I'm very sorry to say that all the placentas that were reported as having had subchorionic fibrin on ultrasound when it arrived at our table showed subchorionic hemorrhage instead. This is one example of severe subchorionic hemorrhage. This is the chorionic plate and this is the basal plate. You can see the compressed placental villi under the hemorrhage, area of hemorrhage. And so none of those which were reported as fibrin actually showed fibrin on pathological examination.
But fibrin is the it's the remnant of the hemorrhage anyway, so didn't. So
yeah, but this is how fibrin looks like on pathology. You can see the bright white fibers. This is what we call fibrin. And if you look at the histology of this placenta, we found an organized thrombus, but you can see the threads of fibrin running across. And this is probably what you reported as fibrin on ultrasound, whereas fibrin on histology looks like this or like this.
So HP is gold standard, so whatever you say is right.
Thank you.
So when we look back at the fibrin deposits that was reported in ultrasound, we looked at this was an IUFT, and you can see the echogenicity was definitely higher compared to that of the previous subchorionic fibrin deposits that we commented upon. So we move on to the hematomas. We have various locations. We have intraplacental, we have marginal, we have subchorionic hematomas, we have retroplacental space. So these were the specimens you can throw more light on.
Here you see intervillous or intraplacental hematoma. This looks very much like the picture you see over there. This is the hematoma, and you see normal placenta on either side. Here it is a bit congested. This is the subchorionic hematoma which you saw in the previous slide. And here, this is the maternal surface of the placenta, and all these black areas are actually blood clot, which was present on the maternal surface. And on cut section, you see the empty space over here that was occupied by the blood clot. And this is the compressed villus of the placenta, which is present behind the area of hematoma. So this is retroplacental hematoma.
So infarcts, I realized we reported this infarct, and it was almost similar to the picture that you have shown here in the pathology specimen. So I think that is a very important message too.
Yeah, here is there are two foci of infarcts over here. Here the infarct has the central area of necrosis, which is probably what you see as empty space over there, and surrounded by an area of infarction, and this is the histology of the same.
Tumors, of course, it's a well-circumscribed one, and the normal placenta will also be seen, and there'll be a lot of vascularity. So if she has a wonderful picture of it.
Chorioangioma on pathology can have many different appearances. You can have them as a single tumor or multiple. They can be small, large, microscopic. Here, this is occupying the subchorionic area, and this is the cut section. You see a fleshy lobulated tumor, which on histology can have any of these three appearances. They can be degenerative, cellular, or angiomatous.
Placental calcification has always been addressed, and it's just a physiological aging process, and we don't need to really grade them. Thickened placenta, placentomegaly with multiple cystic areas. So usually we give a differential diagnosis of placental mesenchymal dysplasia or a coexistent mole, a partial mole. So how does that appear to you?
So here, this placenta was large, and it had a few vesicles scattered over the surface, and on histology showed a varied appearance: small villi with fibrotic centers, large villi with edematous and cellular stroma, and also large villi with cisterns in the center, and presence of these thickened blood vessels in the periphery. So, next.
So I think
this is a classic case of placental mesenchymal dysplasia, whereas another placenta showed vesicles but clustered in groups like grapes, and which also showed these large edematous villi and villi with central cisterns. But as you can see, there were no vessels in both these types. So these were avascular edematous villi and avascular villus cisterns, which was seen classically in partial molar pregnancy. So this is how we differentiate between mesenchymal dysplasia and molar pregnancy, even though the appearance may be similar.
So again, we need the HPE confirmation, right? Placentomegaly in hydrops. Can you tell us the difference between a non-immune hydrops and immune hydrops if I just give you the placenta?
No, the placenta looks very much the same in hydrops of any kind. It does not make a difference. And only microscopy will show you what the etiology is. Sometimes it may not. Here in this the baby had hydrops and the placenta was large. And on histology showed these large villi with these very foamy cells in the stroma and in the trophoblastic layer also. So this is a diagnostic of an inborn error of metabolism, although we do not know what type of metabolism it is, and that requires a genetic testing. Whereas this other placenta, which was also large and the baby was hydropic, had these large villi with very cellular stroma, with chronic inflammatory infiltrate, and sometimes necrosis in the stroma also, and foci of calcification. And in the organs, the fetus showed presence of these large cells with Owlai nucleus, which is diagnostic of CMV infection.
So that shows we have to definitely look at the entire fetus, the placenta, and then come to a conclusion, and we give, so the clinical scenario, everything has to be correlated well, finally, when we give our opinion. Normal obtained placenta does not include a placental pathology, and the final say always comes from the HPE. Not all sonographically detected lesions are going to have a bad outcome. So that will be our conclusion and take home. Thank you very much for a very patient listening, and thank you so much to all my seniors and Dr. Suresh and Indrani Suresh for giving me this opportunity.
Thank you.
There are some questions from the audience for Dr. Khurshid. So what are the indices to take to evaluate for cardiac remodeling?
Yeah, as far as cardiac remodeling is concerned, there are insults which may lead to cardiac remodeling, like pressure overload, volume overload, or direct damage to the myocardium. Now, there are various indices based on whether systolic function, diastolic functions, but what is important to understand is there is a continuum of cardiac failure which starts from chronic adaptation, goes to subclinical failure, and finally lands up in clinical failure. So the chronic adaptation period is depicted by stress and the strain, which can be done by speckle tracking or tissue Doppler imaging. And subclinical cardiac failure, there are markers like tricuspid annular peak systolic exertion, mitral annular peak systolic excursions, myocardial performance index, so on and so forth. But the idea is to identify in the chronic adaptation or in the subclinical failure stage, because there will be a time where modifications may help. But once it goes into clinical cardiac failure, which will be depicted by ejection fraction or cardiac output, it will be too late to manage those conditions. So it's a very long concept, but the basic gist is that we have to try to use those tools which are easily available on the machine and which is reproducible. Like we can use TAPSE, MAPSE, because those are the ones which would be affected before other parameters. Because of the longitudinal muscle fibers, they are affected before the transverse fibers and so on. So the idea is like only 15 to 16% of contractions gives a 60% cardiac output, and that is only possible by composite motions of radial, transverse, and longitudinal. So everything causes twist to the muscle fibers, and once there is twist to the muscle fibers, the efficiency increases in the form of cardiac output. So all those parameters we have to take into account, and plus we have to judge them on case-to-case basis, and we should have experience how to interpret them before we give it in our impression. Thank you.
Thank you so much, sir, for the well explanation. We request all the delegates to visit stalls. Philips is having a machine launch during the lunchtime. Kindly attend the machine launch. And there's a stall number 46, which is about computed brain imaging by IIT Madras. Kindly visit the stall. The Grand Sono Quiz, whosoever wants to participate, the entries will close by lunchtime. So kindly, if you want to participate in the Grand Sono Quiz, you go to the Media Logic stall 10, 11 and 12 and enter your name, CUSP ID and phone number, and you will be contacted shortly. Quiz will be conducted by Professor Suresh. Grand quiz in evening. We are very much looking forward.
So if you're a young and upcoming sonologist, fetal medicine specialist, within 3 years of completion of training, you can drop in your name, phone number and your CUSP ID into the box in the next 10 minutes, and you'll be picked to be a part of the quiz, which is something that Dr. Suresh does at every cusp with a lot of flair. And I think all of us are looking forward to the quiz. If I can also request the faculty to ensure that you have signed against the TNMCA form at the registration counter. That's something we need to do in order to get the points from the Tamil Nadu Medical Council. We have a series of excellent speakers who are, I'm sure, going to ensure that we don't fall into postprandial need to shut eye as we sit in the slightly darkened conference room. So looking forward to an exciting post-lunch session. I have the pleasure and privilege of inviting Dr. Shanti Sairam, who's a consultant fetal medicine consultant at Dubai. Shanti is a dear friend, and we've both been accused of being night owls when she was here in Mediscan. She has put in a lot of effort into streamlining the teaching and examining protocols for fellowship students while she was in Mediscan. She's very interested in teaching and research, and likes to ask pertinent questions and weed through data to give us the answers as well. So over to you, Shanti, to answer the question, the third trimester scan, is there a standard protocol?
Thank you, Uma, for the kind introduction. I'm sorry we are starting a few minutes earlier than planned. That's simply so that we can accommodate the information that I think I want to share with you. And Uma, likewise, Uma is a dear friend, so she said all these good things about me. She says good things about everybody anyway, so don't take notice of it. Let's start, okay? Now, I think we've come a long way with ultrasound. In the 1980s, we tried to create a protocol for the second trimester scan, which has happened. In the 1990s, after Kipros brought in the nuchal translucency, we eventually managed to get guidelines for the first trimester scan. Here we are, 32 years later, and we are still arguing, debating, and have no consensus about the third trimester scan. It's a sad state of affairs, but nevertheless, like Uma said, I have to stick to that personality of mine. I like asking questions. Let me ask you, do you think we need a third trimester scan? Can you put your hand up if you think you need? Okay, excellent. That was actually a trick question. The question is, do you need a routine third trimester scan? How many of you think you need? See, the numbers have gone down. The reason is because we really don't know what the role of the third trimester scan is going to be in a routine manner. Broadly speaking, I think what we do in the third trimester scan is firstly look at the growth. I don't like to split that into 1, 2, 3 as in growth separately, Doppler separately, Leica separately. They're all one package deal. So if you do the growth, you do all those things. And of course, you can look at some anatomy. And more recently, with the advent of the 3D ultrasound, we have what's called as 3D, 4D bonding. How many of you women or even the men asked for a 3D scan when you're pregnant with your child? None? Wow, I'm impressed. In real terms, the growth scan, oh dear. Asking for that extra minutes, I think I'm paying penalty now. So in real terms, what we are actually looking for when you do a growth scan is whether the baby is SGA or LGA, small or large for gestational age. Are we going to pick up any incidental or specific anomalies? And of course, 3D bonding, which I don't think is relevant at all for today's talk. Just to remind you that SGA is not equal to IUGR. For the purposes of today's talk, we are going to talk only about SGA, which means a birth weight less than the 10th centile. It could also include the estimated fetal weight below the 10th centile. Why is it relevant? Because we all are living in middle-income, low-income groups and countries, and we find that there is quite a significant presence of SGA. And if you can see India has got the largest there, where you can see the darkest color possible, and that corresponds to nearly 40 to 50% of deliveries having SGA. Is that all? Actually, that's not all. The majority of the SGAs that you see are term SGA, but the screening modalities that we are currently using does not address this at all. Needless to say, we are all well aware that stillbirths are still common. A third of these stillbirths are due to placental causes, and we assume that a significant proportion of that will be because of the growth abnormalities. And on the right side, you have a neonatal mortality, and you can see that the neonatal mortality relative risk also increases as your centiles fall. Not surprising, and we also, all of us are well aware of the Barker hypothesis, where if you're born as a low birth weight baby, you're going to end up with a higher chance of having cardiovascular mortality. And not only that, I'm not sure if you can read the letters there, it's telling us that there's actually long-term disability and also learning problems. And these are all not just IUGR babies. This pyramid here is actually including term, preterm SGAs, and also some preterm appropriately grown babies. What are we doing? We are trying to use SGA as a proxy for IUGR. But in reality, we have two kinds of IUGR. Not two kinds of SGA, two kinds of IUGR. The early onset IUGR, fetal growth restricted, early onset below 32 weeks, and the one that present after 32 weeks. With the early onset one, we seem to be getting better and better because you scan them routinely at 20 weeks, and that's when you want to pick up the early onset, or maybe a few weeks later. Whereas with the late onset fetal growth restriction, the problem we have is the detection is the major issue, and that is where your third trimester scan is going to come into place. Have we not got anything else? I mean, we've been practicing obstetrics for so many years. We have had simple tools like the symphysiofundal height. The graph is telling you that there's a linear association between symphysiofundal height and the gestational age. Why not use it? Far simpler. You don't have to pay that much for an ultrasound machine. But then it's not recommended because there's not enough evidence. Either we're not doing it properly, or it's not enough to tell you that this baby is actually SGA. What do we do? Several people have had the same questions as you and me, and there are several studies which have looked at using ultrasound in the third trimester to predict the SGA. This is a very good study from the Dutch population. It was called the IRIS study, intrauterine growth risk study. What they did is they looked at a large cohort of people, and they used a new controlled trial called as a wedge cluster randomized trial to avoid confounders. And they looked at the babies who had ACE less than the 10th centile, or they also looked at babies who showed slow growth, which meant a drop in about 20 centiles in the growth scan. They looked at a huge cohort of 13,000 women, and they said, yes, if you do a scan in these women at 28 and 34 weeks, and you try to use the abdominal circumference and combine it with slow growth, your detection rate of SGA is quite good. When they say quite good, it's actually 32%, which is not, in my terms, very good. But what is worse is the positive predictive value, as in, if you say that a baby is SGA on scan, your positive predictive value is very low. So as low as if you say 100 babies have got screen positive, perhaps 1 in 5 to 1 in 4, 3 of them might actually really be SGA. More importantly, it seemed to increase the induction rate, and also it had no significant influence in the adverse outcome. Not surprisingly, the Cochrane therefore said, it is not changing anything in the perinatal mortality, there's no benefit, we are not going to do it. Again, NICE guidelines more recently, 2019, said exactly the same thing. To add a bit more flavor into it, it added groups with or without Doppler and still said there's no statistical significance in perinatal mortality, we are going to veto it. Are there any studies in India? Yes, I just picked up one study from India which actually said the same thing. Yes, we are able to pick up more small for gestational age babies if we did a scan in the third trimester. But then, no difference in perinatal mortality. Of course, the study was very, very small. It had hardly 175 patients in it. So, worldwide, if you look at the European countries, given all these guidelines and given the negative connotation in the third trimester scan, 1 in 3, only 1 in 3 European countries have actually got a routine third trimester scan in their protocol. What about the common colleges that we attend to, the policies that we look up to? None of them recommend SGA. So, we are in a situation where routine third trimester scan for small for gestational fetuses has been summarily rejected. Why? Because they are thinking that if you pick up estimated fetal weight less than 10th centile on scan, the detection rate is very moderate, positive predictive value is not so good, and it has no impact on adverse outcome, and potentially it increases the maternal impact. Just be careful when you read this slide. The only thing I've changed there is this. The previous one was SGA and this SLGA, and this has also been summarily rejected, saying that it makes no difference to the outcome in the pregnancies. Well, I'm not going to keep quiet. I like to ask questions. So, we are trying to pick up these babies whom we think are potentially at risk by doing a single scan. And yet we are saying that the detection rate is poor. Really, why are we thinking about this detection rate? We are actually only doing a screening scan. It's possible that we take the cohort that we think are potentially at high risk and do more things. And we are not thinking about the gestational age. All the studies that I have told you have looked at babies at anywhere. The Cochrane study looked at babies anywhere from 24 weeks. The IRIS study looked at 28 and 34 weeks. So perhaps we are not looking at the right gestation. Your baby is going to be born much after 37 weeks. So if you do a scan at 28 weeks, how can you even imagine that you're going to actually pick up a small for gestation that's going to come 10 weeks later? So we have to rethink, we have to reorganize our brain. Adverse perinatal outcome, no impact. Again, we have done one scan that could have been anywhere from 24 to 28 weeks. And the baby is born at 40 weeks, and you're trying to correlate that bit of information to the second bit of information, which happens 10 weeks later. Are we really looking at the right group? More importantly, are we looking at the right outcome? And of course, maternal impact, we are complaining that it increases the intervention, but in reality, if we had the right management strategy, then, only then, we can ask the question, is it really worth it? Is it really worth it, taking the risk of increasing the interventions in the mother? Let's look at them at least some of these points in one by one. Firstly, we are thinking about whether we are using the right gestational age. We have enough papers which are telling us that they have tried to scan babies at 32 weeks versus 36 weeks. And they've actually said that you're much better at identifying small for gestation fetuses which are less than 10 centile, but do it at 36 weeks, not at 28 or 31 weeks. The only problem is, if even this scan is only good if the baby delivers less than 2 weeks of your scan, which is all, I think we all have looked at this. You don't scan a baby at 36 weeks and say, this baby is 2.4 kilos, and the baby is born 3 weeks later, and with the baby is 2.7, you're not going to beat yourself up about it. But we beat ourselves about this, because we still want to scan at 36 weeks and pick up everybody. What about the adverse outcome? We keep saying there's no impact, there's no impact. Are we actually looking at the right group? Let's look at this. On the left side, you have a graph. I'm sure every one of you would have seen a graph like this. It's just a standard graph which has got the centiles going down, as in it's decreasing in this way. You've got perinatal mortality and morbidity. And rightly so, as your centiles go down, particularly after the 5th or 3rd centile, your morbidity and mortality goes up. Now, look at that corner of that graph, which I have enlarged over here. You've got the 10th centile, and you've got more than 10 centile. Blue is for mortality, B is for morbidity. Is the mortality and morbidity actually 0 if it is more than 10 centile, if the baby is more than 10 centile? No. There is significant morbidity and mortality even in the group that we think is actually more than 10 centile. Keep that in your mind. This looks intense, the graph, but what it's actually telling you is what proportion of babies who were considered as a perinatal mortality group have actually got only a 10th centile detection. Now, let's take 35 weeks or 38 weeks. The white is the proportion of babies whose birth weight was less than 10th centile. The light brown is 10 to 50, darker brown is 50 to 90, and the darkest is more than 90. And if you look across the gestation, this pattern is not any different. What is it trying to tell you? It's trying to tell you that perinatal mortality is not unique to 10th centile babies. So if you keep on looking at the 10th centile or less, you're not going to pick up all of them. There is a significant contribution from babies whom we think are more than 10th and less than 90th. We are not focusing on them. More than 10th centile, chalega, this baby is going to be fine. No, that baby is not going to be fine. Perhaps we need to focus on that. And what is interesting is, this kind of pattern is similar across the gestation. What about neonatal morbidity? On the left end of the graph, you have a centile less than the 3rd, and of course, neonatal morbidity is going to be very high. On the right end, you have more than the 97th centile, and of course, neonatal morbidity is high. But it is not 0 in between. That is where your bigger chunk of babies with mortality and morbidity are going to be. So, let's go back and see if somebody has done this even more recently and more objectively. A paper that I showed you before, which looked at the 32-week and 36-week scan, Ranjit, who used to come here for CUSP meetings, he has looked at it and he has seen that if you look at the less than 10th centile babies, only 16% of the adverse perinatal outcome, not just mortality, is in the birth weight less than the 10th centile. So what am I trying to tell you? We are focusing on a group that's not going to yield enough. And you focus on this group and then you keep complaining that it's not yielding. Of course it won't yield. Now, if you go back to the paper again, what they did was, okay, 10th centile is not yielding us a good number. Why don't we shift the threshold? Why don't we include babies who are maybe less than 40th centile? And that seemed to work in them, in their group. What they then said was, if you were to include more than 40th centile, there is a chance you will pick up more than 85% of them, whereas the sensitivity before was like 30 or 40%. So what did Ranjit propose? He proposed that if you wanted to improve the detection, do it in a stage. Don't assume you're going to pick up everything in one go. First identify the ones with less than 40th centile, add Dopplers on them, then convert them into risk groups. And what do those risk groups tell you? It tells you when to bring them back. Not do a scan at 36 weeks, 10th centile, or not, go away. No. Take the 40th centile, bring them back, and then you titrate and tell them when they need to come back. And he believes, at least in that model, that there was a better detection rate, nearly 85% of all the 10th centile babies, which is what we want to do. But perhaps it will also give us an idea to look at the other babies and include adverse outcomes that we have not looked at before. And it worked. It worked in that paper. It was a model prediction. It was not a real life scenario. But I strongly believe that perhaps that's the right way to go. As in, move your threshold, include a larger group, but plan further scans, not just assume that one scan is going to bring you everything. What about anatomy? We have heard talks, and in fact, I had one presentation in the e-posters as well, and in the morning about anomalies that can be picked up in the third trimester. A scan is going to pick up anything that is deviating from the normal. Not surprising at all. This paper, the Ficara et al., looked at babies who were examined between 35 to 37 weeks in the same cohort where they predicted about SGA, and they said, actually, if you look at the third trimester scan, 25% of all the anomalies are actually picked up in that. And the incidence of anomalies in that population was just 0.5%. However, what about the systematic reviews? They also agree, but they just say it's not that common, perhaps 1 in 300 women. But we need to bear in mind that we're not sure what these numbers are telling us. There is going to be incidental findings, something that you could have picked up before, but you didn't. And there will be late manifestations, and those are the ones you should be targeting. But do we have guidelines? Do we have protocols? Again, no. That's a variety of countries there. If you have the time to read across, you can pick up and say, actually, not majority of them give you a routine third trimester scan. Not all of them are actually including anatomy. So therefore, we don't have a worldwide protocol. We don't have a guideline for third trimester growth centile cutoff. Then comes the question, is routine third trimester scan cost effective? One more minute. Is it cost effective? I'm going to ask you that question. How many of you think it will be cost effective? Quite a significant number, thank you. But I don't think I know yet. I don't think we have the evidence yet. That's the problem. If you want to practice evidence-based medicine, we are all aware that there is an SGA, LGA, we know about perinatal mortality, we know about anomalies, we know we can do a 34 to 36 week scan from what we have heard. We need to understand it's a screening scan, perhaps stage it and perhaps focus on feasible anomalies. We do not have universal screening policies yet. Perhaps in the future, we will get management algorithms and perhaps we will incorporate them and get larger studies. And I will be standing in front of you, giving you that magic drug which has made the difference. What do I do, having spoken so much? For me, I think I want to make a difference to that one particular woman and baby I'm scanning. It's not just a growth scan. Don't book a just growth scan. It's more than that. Try to have a local guideline to protect yourself. And of course, there is a routine statement that many of us have included. I've done in the past as well, but that's an obstetrician's distress. If you send a paper saying, recommend routine follow-up growth scan or interval growth scan at 28 weeks. Do not do that. They can either decide when they want to have the scan or try to push your routine scan a bit later because you're perhaps not going to pick up that many. Again, consider growth scans at 35 to 36 weeks, if possible, in your entire cohort. I'm fully aware I'm not paying for this, but if you're going to do it a bit later. Act on falling centiles. Don't just think that it is 20th centile, it's going to be okay. Perhaps it was 40th and it came down to 20th. Then you need to follow that baby up. And of course, if at all possible, check fetal heart, kidneys, brain, as many anatomical landmarks as you can look at. Remember, you need to include your limitations. If you're going to include a protocol which says anatomy is to be seen, make sure you have a default statement in your report to protect yourself. And finally, do not say everything is okay to the baby or to the mother, because even when you think everything is normal in a growth scan, it may not be. Try to be specific. Just say the growth is within normal limits. Whatever I have seen looks normal, because every mother wants to know if you counted the toes and digits in the third trimester, which is not possible. Thank you very much for kind listening, and congratulations to the CUSP team. A wonderful, wonderful conference.
Thank you very much, Shanti. A lot of food for thought there.
Thank you.
I'm sure there'll be questions, and I invite the audience to post the questions into the app, or if you're writing it down, just raise your hand and somebody will pick it up for discussion time. It's now my pleasure to invite Dr. Preeti Parekh Tomar, who is the consultant at Arohan Fetal Medicine Center at Indore. 4 C's come to mind when I think of Preeti: calm, cheerful, competent, and composed. And in that fashion, I think she's going to address the question which will follow Shanti's talk very well, identifying fetal hypoxia at term. How good are we? Over to you, Preeti.
Thank you so much, ma'am, for those very, very kind words. And I have to say, I reciprocate the feelings for you. We have a mutual admiration society. So, yes. I would like to sincerely thank Professor Suresh, the entire Mediscan family for this fantastic opportunity, for giving us yet another CUSP, and it's a privilege to be standing here in front of all of you. I think the previous 2 speakers, Professor Hyatt and Dr. Shanti Sairam, have made my job so much more simpler, and probably I will be a little repetitive, but we all know for a fact that fetal hypoxia is something about which we all are very, very worried. Not only has it has implications in the form of mortality in the perinatal period, but also implications in the form of disability, both in the short and the long term. And if you look at the risk factors that cause stillbirths, we have seen and we have heard in the previous talks as well that fetal growth restriction tops all of that. But more important to remember is that more than fetal growth restriction, it is this undetected cohort of fetal growth restriction which is much, much more serious and which can cause stillbirths. So it is an undetected group where we are going to end up with stillbirths. And we say that impaired placentation is the main cause of a fetal growth restriction, and all these babies translate as babies which are small for gestational age, which means for the longest time we have been using smallness as a surrogate for growth restriction. So does that mean if we pick up babies who are small, are we potentially identifying all those babies who are at risk for adverse perinatal outcome, or do we need something else? Well, this was a graph that Professor Hyatt also showed. And if you look at this graph, this was a study conducted at King's College and Medway Hospital. On the x-axis here, we have the gestational age, and on the y-axis, we have the birth weight. And if you cut a line across 34 weeks of gestation, we can see that prior to 34 weeks of gestation here, majority, these are the 10th, the 50th, and the 90th centile for the birth weight. And if you see each dot which represents a stillbirth, most of the babies prior to 34 weeks of gestation, in fact 70% of them were babies whose birth weight was below the 10th centile or below the so-called traditional definition of growth restriction. So all these babies were actually small babies who ended up as stillbirths. And so when we talk about this subset or this cohort of babies, you know, we do have mechanisms in place. We know that these babies will have low expected fetal weight, they will have high uterine artery PI, they will have high mean arterial pressures in the mums, they will have low PLGF and high S-FLIS, and these babies will have a low cerebroplacental ratio. So we have all those mechanisms and predictors in place to be able to detect or predict babies who are going to have hypoxia. And then we have the 11 to 13 week scan where we have the uterine artery Dopplers, we have the biochemistry, we have the maternal characteristics, the mean arterial pressure, where we can actually predict all those babies who are going to be small with or without preeclampsia. And then if we start aspirin at this point in pregnancy, we are able to modify the course of the disease. However, the story after 34 weeks of gestation is completely different. Now in this graph, if you see, most of the dots are in where the birth weight is above the 10th centile. So only 30% of babies who end up as stillbirths after 34 weeks of gestation are actually the small babies. That means 70% of babies who are ending up as stillbirth after 34 weeks of gestation are the so-called appropriate for gestational age babies. And so then how do we detect? You know, for the longest time, we have been using umbilical artery Dopplers as a surrogate for placental disease. And we know for a fact that, you know, when we are interrogating the umbilical artery, we are essentially looking at the placental health. So if we have a decreased end diastolic flow, we know that 30% of the placenta is affected. And then it shows a series of progression from the decrease to the absent end diastolic flow and the reversal of flow, where we know that about 70% of the placenta is now diseased. Well, yes, umbilical artery Dopplers are very good, but we have to remember that these work well in babies who show severe placental compromise or who are the so-called early onset growth restriction babies. And this was again a graph which was shown by Professor Hyatt, which says that if after 34 weeks of gestation you look at babies who did have adverse perinatal outcomes, but if you look at their umbilical artery Dopplers, these dark blue boxes over here, most of these babies, because they have very mild placental disease, these babies actually have normal umbilical artery Dopplers. So the umbilical artery Doppler, which was helping us prior to 34 weeks of gestation, in all probability is going to be normal in the late onset growth restriction babies. And so if we cannot use umbilical arteries after 34 weeks of gestation, or if it is not going to give us that information, then we need to interrogate other vascular beds, and then comes the middle cerebral artery into the picture. And we all know for a fact that the babies, whenever they are exposed to hypoxia, will start showing redistribution in the form of shunting more and more oxygen to the brain. And this in turn is reflected in the form of high flow to the brain or a low PI in the fetal middle cerebral artery. And so the PI of the middle cerebral artery starts falling. And this is seen in the near-term fetuses who are hypoxic. And so a ratio was created, which was the cerebroplacental ratio, which is nothing but a ratio between the PI of the middle cerebral artery and the umbilical artery. And needless to say, the umbilical artery PI is either going to rise or it may remain the same, but the middle cerebral artery PI falls. And so any ratio below 1 or below the 5th centile is definitely an abnormal CPR. So we have studies right from 2003 which tells us that any CPR which is below the 5th centile is an indicator that this baby is undergoing a process of hypoxia, and in fact it is a good test, it is a more objective test of the partial pressure of oxygen in the pH of the baby in growth restricted babies. We have had another study by the Gratakos group which also says that the CPR shows a much more change than either the umbilical or the middle cerebral artery, but this was in severe and mild, both in severe and mild forms of growth restriction. Now this whole belief in cerebroplacental ratio has been challenged by this one study. You know, if you look, if you plot the birth weight Z-scores on the x-axis and the CPR moms on the y-axis, so anything which is below the 10th centile is a low CPR. And similarly for the birth weight, if you plot, if this is the 10th centile, anything to the left in the graph here is a low birth weight. And then if you plot all babies who underwent, all these red dots here are babies who had to undergo a cesarean section for fetal distress. And if you look at this chart or graph over here, you will see that most of these red dots are in the area where the CPR was above the 10th centile and the birth weight was also above the 10th centile. So the majority of the cluster is in babies who were appropriate for gestational age and who did not show any changes in the CPR. There was a recent meta-analysis which also went on to say that CPR added no predictive value to adverse perinatal outcome beyond umbilical artery PI at any weeks of gestation. And they said that they were almost comparable to the umbilical artery or the MCA PI as such. And when we translate this into our practice, we see all of us here are imaging people. We are routinely doing middle cerebral artery Dopplers in our growth scans. And because CPR is so dependent on the middle cerebral artery, this was the middle cerebral artery PI for a patient whom we took at 11:44 a.m. And within a span of 4 minutes for the same patient, I could get MCA PIs of 1.66, 0.9, 1.4, and 1.27. This is when I was scanning the patient for a continuous of 4 minutes. So, MCA is something that you can tailor according to your needs. If you want, what do you want the obstetrician, do you want to deliver? I will give you a low CPR. So, the point that I want to make is that it is very important to, see that how the middle cerebral artery Dopplers were taken, whether excessive pressure was applied, whether the fetus was breathing, whether the head was deep in the pelvis, because all of these are going to have an impact on the PI of the middle cerebral artery, and that in turn is going to affect your cerebroplacental ratio. So therefore, any CPR which is a low CPR or any MCA, it should always be cross-checked and counter-checked, and multiple MCA PI should be taken to make sure that you are measuring the MCA correctly. What about CTG? We've been told that CTG is very good in detecting fetal hypoxia. Well, we have to understand that in most cases in our country, most places, we have the conventional CTG. And conventional CTG has a high false positive rate of about 50%, and it is very, very subjective in its interpretation. Also, CTG is good as in acute distress, in seeing acute distress rather than long-term distress. So we always see for the long-term well-being of the baby, it is the Dopplers rather than the CTG. But for acute well-being of the baby, maybe yes, the CTG can help. And it is more of the computerized CTG that helps, which shows a loss in the beat short-term variability. But again, it has been said in studies that if you see a loss of short-term variability, you don't act on it because probably this baby is compensating and right now is not in the decompensatory stage. So if you section this baby at the compensatory stage, probably you are increasing the number of operative deliveries for a baby who might have done all right without the iatrogenic delivery. So then what should be our strategy if we have such conflicting views on CTG, on Doppler monitoring, on fetal growth, so on and so forth? Well, the algorithm that we think can be followed is that all babies need to be triaged at the 11 to 13 week scan. It is very, very important that we take a detailed maternal history. You look at all the maternal characteristics. You look at whether she had preeclampsia, what is her BMI, what is her parity status, so on and so forth. And after the uterine artery Dopplers and if needed the biochemical screening, you triage the pregnancy at 11 to 13 weeks because then this is the time you can start these patients on aspirin. After 11 to 13 weeks, we scan the uterine artery Dopplers again at 20 weeks of gestation to see that which of these patients have actually responded and which of these patients do require intensive monitoring, and those who are identified to require a closer monitoring are then subsequently called at 28, 32, and 36 weeks of gestation. The low-risk group can be called straight at 36 weeks of gestation unless the obstetrician feels that there is a problem with the growth on the clinical examination. Now, as the previous speaker, Dr. Shanti said, we have to have a standardized protocol in our country because the person doing the scan and the person delivering the baby, the place where the scan has been done and the place where the baby is being delivered are completely different. There is no continuum of care sometimes in this. So a standardized protocol of when a third trimester scan should be done is very, very important. And we say that, again, it's the same study which this group of Dr. Ranjita Kolekar have proposed a two-stage approach, where they say that all patients have to undergo a standardized screening scan at 36 weeks of gestation, where we can classify all those babies whose expected birth weight is above the 40th centile, can be discharged as very low-risk babies. They need not come for further scans, and they can go into spontaneous labor unless there are some other factors. For babies whose birth weight is below the 10th centile are in the high-risk group. So at 36 weeks of gestation, if you're clearly below the 10th centile, then these are the patients who need to be delivered. If the birth weight is between the 10th to the 40th centile, then and if these babies have very abnormal Dopplers, either the uterine artery PI is very high, the umbilical artery PI is about the 95th centile, the CPR is very low. These are the babies, again, even if the birth weight is about the 10th centile, they need to be delivered because they are in the high-risk group. If the birth weight is between the 10th and the 40th centile and the Dopplers are moderately abnormal, say a little high resistance in the uterine artery, mild cerebral redistribution, these are the babies who are in the intermediate risk group. They need to be monitored closely but not immediately delivered, and they can be asked to keep a strict check on their movement count. They can be asked to follow back again in 10 days or 2 weeks' time for repeat scan, and any time there is a deterioration in the Doppler indices, then they will need to be delivered. And then there is a third group which has the birth weight between the 10th and the 40th centile who have shown normal Doppler. So these are probably the true babies, the true small babies who don't have a placental insufficiency as yet. And these can be called as the low-risk babies who just need to be monitored clinically, probably need a repeat scan in 4 weeks' time if they don't deliver. And this is the protocol that we could possibly follow to look after babies and detect hypoxia. So in conclusion, we have to triage all babies at the 11 to 13 week scan and at the 20 week scan. For small babies, yes, cerebroplacental ratio is a very sensitive marker of fetal hypoxia and a good predictor of fetal outcome. But in the non-SGA babies, it can predict poorer outcome, but we cannot use it as an endpoint for delivery. The best timing for a routine third trimester scan is about 36 weeks of gestation, and we really need to think about using an expected birth weight of 40th centile as the cutoff to identify a subgroup of patients who need to be monitored more frequently. Thank you so much for your patience.
Thank you very much, Preeti. I'm sure we'll have questions at the end of the session. It is now my pleasure to invite to the stage to deliver his talk on triaging twins in the first trimester, the organizing secretary of CUSP 2022, consultant fetal medicine specialist at Mediscan, Dr. Sudarshan. For those of us who have seen him grow from being a postgraduate in obstetrics and gynecology to a consultant to whom the fellows and trainees look up to as a mentor and patients look up to with trust, we are arguably proud about how he has blossomed into a dependable and dedicated clinician. Over to you, Sudarshan.
Thank you so much. Okay. So, over the next 15 minutes, I shall be taking you from the third trimester, which you have been hearing over the last half an hour, to the other end of the pregnancy spectrum, which is the first trimester. And in the first trimester scan, we are used to assessing the singleton pregnancy. We have a process, there are rules. But once we come to a twin pregnancy, is it 1 + 1 = 2? Or is it actually 3 or more? So, which means, is there some other stepwise protocol of imaging twins? Or is there a different process of the way we look at twins? The imaging is the same, but the way we triage them and interpret them is the same. So for the purposes of triaging twins, when a twin pregnancy walks into the unit at 12 weeks, we triage them using the 6-step process. 1, we assess the history. 2, the chorionicity. 3, the crown to rump length. 4, the nuchal translucency. 5, structural anatomy. And 6, aneuploidy. These are all things that you must have heard of. But how do we use them to split them and triage them and counsel the patients is what we are trying to look at over the next 15 minutes. So let's take the triage one, which is the history. When I look at the history, I divide them into 2 subgroups. The top one, which I have put here, is the maternal medical history, history of any significant medical conditions. And these put the pregnancy overall, in addition to the fact that it's twins, for a higher risk of preeclampsia or growth restriction disorders. The second half of the history which we focus on is someone with a prior bad obstetric history, say someone with a cervical incompetence, multiple miscarriages, and uterine malformations, because the impact this has on an ongoing twin pregnancy is much more than that in a singleton pregnancy. It increases the higher risk for a mid-trimester loss. So using this first triage at the history, what do we do? Someone walks in and you take the background history and you take the history of the uterine malformations or prior loss. This subgroup needs to go through a subspecialist care to optimize the glycemia. For people who have heard Dr. John deliver a session on glycemia and the impact in the workshop, you must be understanding the significance of what this undergoes. On the second side, when you have someone with multiple prior losses, say someone with a unicornate uterus, and they come with a twin pregnancy, we need to ponder whether possibility of an elective reduction to a singleton may at least improve the overall pregnancy outcome. That is something up for debate. There are not big studies on that. The second triage that we go is a chorionicity. This is a trend of twin pregnancies that we see at our unit over the period of years. What we have seen is one thing is consistent. Dichorionic twins remain at around 85% of the numbers, while the monochorionics constitute around 12 to 15%, while the momo twins are around 2%. Which means the moment we see a monochorionic twin, we all panic, but when we see a dichorionic twin, we sit back, but the majority of the twins that we see is a dichorionic, and hence by default the complications are supposed to be more only in that group. So when we assess the triage by chorionicity, we have to make sure we identify it and document it at the first trimester. And that is done by means of the signs. We see separate placenta, or we see the lambda sign, or in case of an MCDA twin, we see the T sign. But what about the momo twin? We have some difficulties in that. So this is a pregnancy with on a transabdominal scan. Initially, we did think that there was a monoamniotic twin, no membrane seen. But on the transvaginal scan, a thin membrane was seen. This happens more often than not. So the moment you consider having a monochorionic, monoamniotic twin on a transabdominal scan, increase the 2D gain, switch on the color Doppler, and do a transvaginal scan, this would make you make this diagnosis with greater certainty, because as we will be seeing in these slides, what happens to the perinatal outcomes? Ultimately, what is seen is that when you have DCDA twins, in all these graphs, the first bar is the DCDA, second is the MCDA, and the third is a monoamniotic twin. All these bars which represent pregnancy loss prior to 24 weeks or about 24 weeks, or preterm birth before 37 weeks and 32 weeks, one thing is consistent. All these graphs are going up from the DCDA to the momo. So if you take a loss at less than 24 weeks, in DCDA it's 2% and increases to 21% in your momo twin. Similarly, in a preterm birth less than 32 weeks, it increases threefold from 7% to 26%. So assessment of the chorionicity gives you this much amount of clarity to triage your pregnancy as to the fact that they could be undergoing these complications. The third triage is your crown to rump length. When you see a pregnancy at 12 weeks, some form of discordancy is common. You would have measured one baby is 6 centimeters, other baby is 5.5 centimeters. And how do we put that into clinical evidence or practice? And how do we interpret them for counseling patients? Let's look at this paper, which this meta-analysis in 2014, that looked at CRL discordancy and adverse perinatal outcomes. They took a discordancy of around 10% for these twins. And when you looked at the data, what was seen was the sensitivity to pick up fetal loss or preterm birth or birth weight discordance was not too great, was only around 20%, and they used a cutoff of around 10%. But again, what this more recent data gives us is that in DCDA twin, when you use a CRL discordancy cutoff of 15%, then it gives you a much better predictive ability to both counsel patients and put them on a closer monitoring pathway. So when you see the discordancy of over 15%, the fetal loss rate less than 24 weeks and birth weight discordance all increase from the baseline 2% to close to 5 to 10%. So if you see a discordant CRL in first trimester in DCDA twin, if it is more than 15%, then report it and consider counseling the patient on the need for a closer monitoring. The same thing when we look at the monochorionic twin, the data are much more stark, and in this, the numbers are even more stark even if you take a discordancy of 10%. So if you look at the loss rate less than 20 and 24 weeks, the blue bars are more than 10% discordancy, this is 15% discordancy, and this is 20% discordancy. So as the discordancy in the CRL increases in a monochorionic twin, the loss rate also exponentially increases from 20% to 60%. So when you see an MCDA twin and you have a discordant CRL which is above 15%, like in a DCDA twin, the risk of early fetal loss rate, the relative risk is 3.7 more, and these pregnancies also are at a higher risk of needing fetoscopic surgery. So this is again a paper which looked into the predictive ability of the nuchal discordance for adverse outcomes, especially the vascular complications. The predictive ability was not too great, it gave only a detection rate of 20%. But when you looked at the individual markers, if you used an NT discordance of 20% and a DV reversal, when a combination of both are present at the time of the first trimester scan, this gives a significantly high prediction for these pregnancies. So what are we going to do after we predict them? The primary concern that we have when someone comes for a 12-week scan is these pregnancies need to be followed up more frequently, and the compliance is extremely poor. If you take a DCDA twin discordant for an NT, it doesn't change the number of perinatal loss, but a significant number of these patients opt for selective feticide at that point of time or investigations, which we have seen from our cohort, which will be presented later in the day. If with respect to MCDA twin, what we essentially do is we tell them that there is a threefold increased risk of the twin-related complications. The follow-up protocol though remains the same, but this helps us reiterate and enables compliance from the patient. With respect to structural malformations and invasive testing, the assessment is exactly the same as in a singleton pregnancy. So the triage number 5 which we see is the anatomical checklist which we do at our unit by the rule of 2 protocol. But the rule of 2 protocol is not the same in twins as in singleton because it is challenging because the anatomical planes are difficult to image and the fetal positions are difficult to image. So the utility of transvaginal scan extensively, having a proper checklist and most importantly patients and a proper audit process helps you raise the bar significantly in triaging these twins at the first trimester. And if any of the other things we do not do, this anatomical assessment at this time is a focus that we need to have. So how do we triage them again? We triage the anomaly. This is exactly what we do. Once we see an anomaly, we need to put them into 2 groups. Is it a lethal or a non-lethal anomaly? These are some examples of what I put up. If it's a non-lethal anomaly, if it's correctable or one with a high morbidity. This classification right at the end of the scan helps give you clarity towards what to do. So if it is a lethal anomaly, then you have an option of a selective feticide to provide them. If it's a non-lethal anomaly with a poor prognosis, again you have an option of selective feticide well early in the pregnancy. If it's something amenable to correction, you can opt for routine care. All this again subject to patient's choice because not all patients want to go through that process, but you'd be able to make a triage right at that juncture and not get into a difficult situation with the patient requesting for a selective feticide in the mid-trimester scan. So triaging the monochorionic twins, is it the same? It's not the same. We don't look at it as a lethal or a non-lethal. Rather, we triage them as to is the abnormality putting the pregnancy at a higher risk of in utero demise, and that is what is a concern because that's got a potential to impact the co-twin. And in that case, we've got to put them on a closer monitoring path because that patient may require a selective feticide by a cord coagulation or an RFA at around 18 weeks. If there is no increased risk of in utero demise, say there is a pregnancy with a baby, one baby having a renal agenesis in a monochorionic twin, or there is a one baby having an acrania in a monochorionic twin, then potentially a conservative follow-up could be done 2 weekly from 16 weeks onwards for twin-related complications, and we can handle them as things go forward. The other thing with respect to twin pregnancy, when you see, is a trap sequence, and if we need to triage trap sequence at the early pregnancy, what are the things that we need to have in mind? If we see in the early pregnancy a singleton, and at 12 weeks, then you see a twin pregnancy, then it's definitely either a monochorionic twin or a monochorionic twin with a trap sequence. So if in the early pregnancy scan or in the first trimester scan, you see a MCDA twin with one non-viable pole, then switch on the color Doppler to look at the vascularity and review them closely to see if this could evolve into a trap fetus. The triage 6 is aneuploidy screening. And when you look at aneuploidy screening, the combined screening test for aneuploidy, which uses the nasal bone, the NT and the biochemistry, has got around an 80 to 85% sensitivity in twins. The key challenges are the need for early diagnosis of aneuploidy, considering the multiplication of invasive risks in pregnancy. So if you look at NIPT in twins, again the detection rate is almost equal to singleton for trisomy 21, but much poorer for the other trisomies, but with an increased failure rate. So with this in background, when you do aneuploidy screening in twins, you either follow an ultrasound-based screening or a combined screening test or a NIPT screening. What we follow at our unit is a second pathway, which is a combined screening pathway. NIPT is not done as a first-line screening in twins. And how do you triage them based on this? Once you have a screen positive pregnancy, in a DCDA or a MCDA, we split them because in monochorionics, we avoid a chorionic sampling. We prefer to follow them up to 16 weeks to consider an amniocentesis. While a DCDA twin, an early assessment for aneuploidy is much beneficial because early detection of an aneuploidy provides you options of further pregnancy care. And the last triage is looking at the placenta, and when you look at the placenta, you can see subchorionic hemorrhages, more common in twins, especially assisted conceptions, and again the risks are the same as in singleton. When you have a large hematoma over 5 centimeter, slightly higher risk. And when you look at the other complication, which is a coexistent molar gestation. So in an early pregnancy scan, when you see a twin gestation, and at the first trimester scan, you see a singleton with one portion of the placenta showing multiple cystic zones and the other normal. Then this gives you a differential of these two problems. It's very difficult to triage because one has got a very poor outcome, one has got a slightly better outcome. In this particular case, the beta HCG was 15 mom, TSH was extremely low, so it has made a diagnosis of a partial mole. Pregnancy was terminated at the time, but not always possible. So to summarize whatever I have said into a flow, if you do twins at the first trimester, we just split them into CRL, NT anatomy and aneuploidy and see if they are concordant or discordant for either. The care pathways beyond the first trimester are very simple. If they are concordant, it is 4 weekly pathway for a DCDA and a 2 weekly pathway for a monochorionic twin. But if it's discordant, we split them. If it's a discordancy for the anomaly, we have an option of an early FR, this is a cardiac anomaly. If it's discordant for an NT, then you have an option for an evaluation. Again, as we have seen in our cohort, very large percentage of pregnancies opt for a selective reduction. If it's a discordant for CRL, we realize that if we use a 15% cutoff, then there is a 4-fold increased risk of adverse outcome in mid-gestation. Slightly different triage in a monochorionic twin. If you see an anomaly, then we start contemplating and triaging the anomaly, as I said before, based on the risk of in utero demise. If there is a discordancy in the NT, then we consider genetic evaluation and follow-up for twin-related complications from 16 weeks, and a 15 to 20% discordance in the CRL, higher risk. So to take home, if you want to triage twins in first trimester, these are the ones which require the red flag, a monochorionic twin discordant for an NT, or a trap sequence in a monochorionic monoamniotic twin, or a DCDA twin with a discordancy, major discordance in the NT or an anomaly. These are the things which need the yellow flag, MCDA discordant for a CRL or an anomaly at this point of time, or the mere presence of a monoamniotic twin. And these are the things are the low risk routine care pregnancy, which is a concordant MCDA or DCDA twin. Thank you so much for a patient listening.
Thank you very much, Sudarshan, for succinctly putting together that quite a challenging topic within 15 minutes. May I now request this delegates, if you have any written questions, just raise your hand. Somebody will come and pick it up. Otherwise, you can put the questions into the app. There are a couple of questions. I think there are one or two. I don't know if John is here from the previous session. Yes. Okay, so there's one. Because there are a couple of questions, I think, from relating to the past session. One is, at what gestation do we need to intervene in SGA with normal Dopplers? I don't know if he wants to take it or, oh, he's here. Yeah, sorry, I didn't.
Good afternoon. Just tell me the question again.
At what gestation should we intervene in SGA with normal Dopplers? I'm assuming to deliver.
So I'm not sure I have a straight answer to the question. I think it's a balance of risks. And you've got to identify what level of risk you think the pregnancy is facing in the context of, let's say we were talking about stillbirth. And that will vary depending on a number of factors, including previous obstetric history. Maternal ethnicity actually makes a difference to that. Maternal age, BMI, might make a difference to that. You've then got the issue of the pregnancy that you scanned and you're thinking the baby's small. So you've got to take all of that into account and come to some decision about what you think the level of risk is. And then you've got to make a decision about whether the risks of induction or of delivery are higher or lower than that. Now, just to give you some scale of what is considered to be acceptable, traditionally in obstetric management, we induce women when they're about 10 days overdue. And typically, we are doing about 150 inductions to prevent one stillbirth. So an obstetrician's view seems to be that doing 150 inductions to prevent one stillbirth is worthwhile. And you could make the argument that if you got to the threshold of something similar, let's say more than a 1% risk of stillbirth, then you might choose to induce at that point.
Okay, thank you. I think there's a question also on standard deviation versus percentile. Can you please clarify what you meant?
So some people report growth in terms of the number of standard deviations from the mean that you are, or a Z-score, or sometimes they might call it a delta value. If you have a normal distribution, then 1.97 standard deviations is approximately the 5th or the 95th centile. So roughly 2 standard deviations equates to the 5th centile. And 1.64 standard deviations equates to the 10th centile.
Okay, thank you, thank you. Preeti, there's a question for you. How do you differentiate an SGA baby from an IUGR with normal Doppler? I think we're just getting into semantics here, but...
Well, to be very honest, you know, the differentiation is difficult. I think the differentiation is difficult. The first thing that you look at is the weight. And if you see a birth weight or an expected weight which is below the 10th centile, then you automatically categorize this as a small baby. And then the question is?
How do you differentiate if it's SGA versus an IUGR with normal Doppler?
Well, traditionally, we have been using the uterine artery Dopplers, the umbilical artery Dopplers, and we have said that the definition is that if you have a baby which is small below the 10th centile, but if your umbilical artery Doppler is normal, you would technically call it as a small baby or a constitutionally small baby, and the moment you start seeing umbilical artery Dopplers as abnormal, you would probably start calling it as a growth-restricted baby. The problem with this is that a lot of times, as I've said in my talk, a lot of these babies who do show mild placental disease will not show the umbilical artery Doppler's abnormality. And that is precisely where there is a cohort or there is a subset of babies who are in the appropriate for gestational age group, but they do not show any Doppler abnormalities, but they are still hypoxic. So yes, it is difficult, but technically if you see an abnormality in the umbilical artery, probably that helps in categorizing it into a small, normal small versus a growth-restricted small fetus.
You want to say something?
Yeah, I just wanted to say, I think the question to some extent misses the point. The point is not whether you're growth restricted or you're not growth restricted below a certain centile. The point is, this is the centile cutoff that you have now chosen to call an alert point where you're going to have some either further surveillance or further intervention. And so really everybody below that centile has reached the alert point. Whether they truly have IUGR
a problem or not
is sort of irrelevant. They all need to be managed in that way. Yeah.
Yeah. And I think that's also a point which Shanti made in her talk with the thing. So Preeti, you had shown over 4 minutes that you could generate whatever MCA that you wanted. And so if you got such 4 MCAs, which one would you report? And how do you decide which one you're going to report?
So that's a difficult one, isn't it? So yes, this I purposely did it for that patient because I applied more probe pressure. I asked the patient to hyperventilate,
You did it for the talk.
I did it for the talk, but this is a real life situation and it can happen. So the moment the patient comes in and lies down on the couch, most often if the baby is in the cephalic position, the first thing that you do is the BPD and the MCA, and oftentimes, you can see that the MCA is abnormal. So I think repeated measurements when the patient is a little more calmer, maybe time the MCA multiple number of times throughout the period of scan when the patient is a little more quiet, a little more calmer, the baby is a little more quiet, see that you're not applying unnecessary probe pressure, and then over a period. So it's not just one MCA or 2 MCA measurements, but you have to take multiple measurements to be able to then decide which measurement you have to take into context.
Okay, thank you. Sudarshan, there are a couple of questions on discordant NT. One was, I think, when do you report it as discordant NT? And then there is this one with concordant CRL, discordant NT with reversal of A wave in the ductus Doppler. How frequently should we follow up? I mean, would you do anything first of all, and then how frequently would you follow up?
So we don't report an NT discordancy per se. We report a discordant NT if one NT is high. We define how we see how an increased nuchal in the first talk. So if we see a monochorionic or a dichorionic twin, we use the same cutoffs as in a singleton to define an increased NT in one of the fetuses. And if one of the fetuses has an increased NT and the other is normal, then this is a twin which is a discordant for a nuchal translucency. We don't have number or percentages, we don't separate the NT values and then make a number there. So for the second question, we don't do anything at that point of time. I think I put that in my talk, the fact that if we see these concerns at the first trimester, we know that this puts the pregnancy at a significantly higher risk of complications. So we get them back still at the early assessment at around 16 weeks and then follow up the pregnancy based on what we see at that point of time. It's not about how frequently follow up, it's about what we see at that point of time, which will determine the way we follow up the pregnancy.
Okay, thank you. Shanti, there's a question for you, and I think that may be all that we have time for. Should we mention about anatomy during the 3rd trimester scan? You said we don't say fingers and toes, we can't count. So should you say all that, I think is the question.
No, you don't have to individually list out what you have not seen. I think First of all, if you have a protocol that says I'm going to look at anatomy, you need to define in your protocol what you're going to see. And that certainly should not include fingers and toes. But I think what I tend to have in my report is a gentle statement that this is especially if they're asking for anatomy in the third trimester, is that I say you cannot assess all the anatomy. But as a routine, I look at kidneys, minimum 4 chamber, and then you just have to have one pulmonary stenosis, and then you'll start doing velocities on all the hearts that you see. So the list is endless. But I think you need to have a caveat which says, I've not looked at all of it because I cannot look at it. I think that is good enough.
It's also something that patients ask us very often.
Absolutely.
Because sometimes on reports they say limb survey has not been done in this scan. One such line comes, they actually get worried and they say, is there something wrong with the limbs? They have not seen it. So I think from an obstetrician's perspective, now I have started to tell them this scan is to see how the baby is growing. You've already had a 5th month scan where they've looked at the anatomy. Yeah. So unless something is really off, our focus is this. So because now women, couples are getting very anxious with every scan.
Absolutely. That's why I said it's not good enough to say everything is all right. It's not. It may not be. So why don't say things that you don't need to. You're looking at the growth, tell the growth. I think what I tend to do is as I'm scanning, I'll say, okay, I've looked at the kidneys, it looks fine. I've looked at the 4 chambers, it looks fine. I can see the bladder, that looks fine. Stop with that. Don't go beyond what you are, whatever field you're looking at for measurement, that's a good field to look for anatomy as well.
Okay, I think we are running out of time, and there are more questions as there will always be with growth restriction and small babies, but we'll have to discuss that later, maybe in person. So thank you very much for that lovely session, and we now move on to the next So for the next session, I'd like to invite Dr. Divya Singh, who's a consultant radiologist at Prime Imaging and Prenatal Diagnosis, Chandigarh, very active member of the Issuog teaching and online education programs. And she is a Mediscan alumni as well. And she's going to talk to us on fetal CMV diagnosis and implication.
Thank you, Uma ma'am, for the kind introduction. And good afternoon, everyone. At the outset, I would like to thank Dr. Suresh sir, Indrani ma'am, and the entire organizing team of CUSP 2022 for the kind invitation to be a part of this academic extravaganza. I have been assigned the task of speaking on fetal cytomegalovirus infection, its diagnosis and implications. And I shall be making an unconventional start to the presentation by giving you the take-home messages first. Please remember that maternal CMV infection, when it occurs before 14 weeks of gestation, is responsible for the severe debilitating neurological sequelae of CMV. And this is more true for primary, that is, when a pregnant woman is exposed to CMV for the first time in her life as compared to non-primary infection. That being said, it is actually the non-primary maternal infection which is the main cause of congenital CMV in our country. Remember, this non-primary maternal infection cannot be excluded by maternal serology alone, and you need to do PCR analysis of the amniotic fluid for CMV DNA to confirm fetal infection. Also, please remember that mere presence of CMV-specific IgM antibodies in the maternal serum does not equate to recent primary infection. It has to be corroborated with IgG positivity and a low IgG avidity index. All fetuses who have CMV in the amniotic fluid are neither symptomatic nor do they end up having the severe form of infection. A normal scan done at 18 to 22 weeks and an anomaly scan which is normal does not guarantee freedom from the appearance of the severe manifestations of CMV later on in pregnancy. If the ultrasound and MRI done in the 3rd trimester are normal, it is reassuring in terms of neurological outcome, but it does not eliminate the risk of occurrence of sensorineural hearing loss postnatally due to CMV. And all congenital infection by CMV must be confirmed within first 3 weeks of life by testing the baby's urine or salivary swab samples. Now I come to the main lecture, and I'll qualify all the statements which I made earlier. Please remember that CMV is important because it's the most common viral cause of congenital infection. Fetal CMV, rather congenital CMV, is the leading non-genetic cause of sensorineural hearing loss and neurological disability. And there are two forms in which pregnant women can be exposed to CMV. First is the primary, in which case a woman who's never been exposed to CMV gets the infection during pregnancy and has a 30 to 40% risk of having a fetus with CMV. The other infection is non-primary. Please remember, CMV is a herpes virus. And so, once it inflicts a person, it remains dormant in certain tissues, and there can be reactivation of this prior infection or reinfection by a new strain of CMV, resulting in non-primary maternal infection. And this has a relatively lower risk of causing congenital infection. Only 10% of women who have primary CMV in the first trimester end up having babies with severe neurological sequelae of CMV. One look at this graph map would help you understand that we in India are living in an area of high seroprevalence of CMV. What this means is that majority of pregnant women in our country have already had an exposure to CMV earlier on in their lives, and hence what the CMV infection that we see during pregnancy in the fetus is actually due to non-primary cause, that is reinfection or reactivation of prior infection. This is in contrast to the Western European countries like France, where there is low seroprevalence and hence congenital CMV occurs mainly due to primary maternal infection. Okay, when it comes to diagnosing maternal primary infection, problem is that majority of women remain asymptomatic. And why do we test women for CMV? The most common indication is when we see fetal ultrasound abnormalities suggestive of infection, or there is a non-specific viral illness which cannot be attributed to usual culprits. A lady has hepatitis, she tests negative for the usual culprits, and then you think about testing for CMV. Now, it's important to understand how the immune system reacts in order to understand maternal serology. And you'll have to have a careful look at this graph. Now, this is what happens when there is primary infection, that is when an individual is exposed to CMV for the first time. As expected, the solid line indicates the IgM antibody levels, which gradually increase, they reach a peak, and then they decline. But please remember that CMV-specific IgM can persist for more than 6 months after recent infection, and so you cannot rely only on IgM positivity. Simultaneously, there is an increase in the IgG antibody levels, as you see by this dotted line. So if you were to test a lady at this point of time, that is during a recent primary infection, you would have IgM positivity, IgG positivity, but as you see, the concentration of IgG antibodies is low, so you would have a low IgG avidity index. Gradually, the IgM would decrease, reach a nil level, and IgG would plateau and persist for the lifetime at a high level. What would happen in non-primary infection? When there is reactivation or reinfection, again IgM would rise. But what about IgG? It would still be high because she had IgG antibodies from prior infection. And here, when you would do IgG avidity, the IgG avidity would continue to be high, though the lady was having a recent non-primary infection. And that is why maternal serology doesn't hold good when it comes to diagnosing non-primary infection. Let's try to decipher maternal serology. Suppose a lady had a non-specific viral illness in the first trimester. You did her serology and IgG was negative. You looked at IgM, that was negative too. This implies that this lady hasn't been exposed to CMV, she is not immune to CMV, and you need to educate her about primary preventive measures. On the other hand, if IgM antibodies were present, what do? Do you jump to the conclusion that she has CMV? No. Please remember that CMV IgM antibodies can be false positive due to cross-reactivation by other viral illnesses. For instance, she has Epstein-Barr virus, but you can have a false positive for CMV IgM. And so, you repeat the sample after 10 days. And if this repeat sample shows no IgG antibodies still, it means it is a false positive, because if she was truly exposed to CMV, she would have had IgG antibodies by now, and an IgG avidity would be done, and if it is low, it would confirm recent primary infection. What do you do if IgG is positive? You again look at IgM. If IgM is negative, it means that this infection is because of some past infection. You have IgG, you don't have IgM. On the other hand, if you see IgM, do you jump to a conclusion that it's recent infection? No. You do an avidity. If the avidity is high, what does it mean? It can mean that the primary infection occurred more than 3 months ago, but in our setting, we cannot rule out that this is not a case of non-primary infection by avidity alone. If avidity is low, that helps because it helps in diagnosing recent primary infection in the last 3 months. So, this is what happens typically in our setting. We do a 18 to 20 week scan, see a baby with features of fetal infection, order maternal serology. How do we interpret it? If IgG for CMV is negative, at this time you can safely exclude that the findings are not because of CMV. However, if IgG antibodies are positive, irrespective of IgM levels, please remember that CMV can be a cause of these findings, and you need to rule out CMV by doing PCR analysis of the amniotic fluid for CMV DNA. What are the red flags which alert you to the possibility of fetal infection? Now we come to the domain of ultrasound. There are certain cranial manifestations, some extracranial manifestations like a small grown fetus, fetus with hyperechogenic bowel or kidneys, enlargement of the liver and spleen, because besides the brain, CMV has affinity for the reticuloendothelial system, or there can be fluid in the pleural, peritoneal or pericardial cavity. Remember, before going to the fetus, the CMV goes to the placenta and causes placentitis. So there can be placentomegaly, changes in the placenta, which can lead to uteroplacental insufficiency and consequent growth restriction and amniotic fluid abnormalities. Coming to the intracranial manifestations of CMV. This is one such finding, the typical intraventricular synecdoche, these linear echogenic strands that you see in the occipital horn of the lateral ventricles, which are quite suggestive of CMV. This is the parasage image of the brain of a baby at 30 weeks. One glance shows you that the brain is atrophic. There's more fluid than expected in the lateral ventricles, and you can appreciate this echogenic halo in the periventricular zone. Also, for 30 weeks, the brain is relatively smooth. There are hardly any sulci, and this is a fetus with severe manifestation of CMV in the form of lissencephaly. There can also be presence of these anechoic cysts in the caudothalamic groove region or in the temporal horn. When they are quite specific, they are known as periventricular pseudocysts of CMV. Then we come to another severe case with CMV where you see marked brain atrophy, dilatation of lateral ventricles, and this periventricular calcification. A rare manifestation in the form of marked destruction of the brain parenchyma and communication between the lateral ventricle and the extraaxial CSF, resulting in schizencephaly. And finally, there can be involvement of the posterior fossa. So the cerebellum can be small, it can show foci of calcification as well as hemorrhage. Coming to the extracranial findings, you may see ascites, echogenic small bowel, then there can be opacification of the lens resulting in cataract, enlargement of the spleen, and as I said, pericardial effusion, pleural or ascites. Placental manifestations can be in the form of an enlarged placenta with punctate foci of calcification due to the placentitis and accompanying abnormalities in the amniotic fluid. Coming to diagnosis of fetal infection, there are certain things that you need to remember. First, there is a time lag between occurrence of infection in the mother and occurrence or rather excretion of the virus in the fetal urine and detection in the amniotic fluid. That is why there has to be a time delay. It's ideally recommended that you give a lag of at least 8 weeks after the estimated time of infection and definitely after 17 weeks of pregnancy, because that is when fetal urination is well established, so as to ensure that you don't get a false negative result for CMV on the amniotic fluid analysis. Or if you don't know the time of maternal infection, it's best to do it around or after 20 weeks. to avoid false negative results. Also, there is a time lag between infection in the fetus and manifestations of the abnormalities on imaging. And that is why if you have an amniotic fluid which is positive for CMV but no significant findings on ultrasound, you need to still closely monitor this pregnancy because the manifestations may appear later on in pregnancy. Coming to the prenatal prognostic factors. Now, what factors determine prognosis of a baby? First, as I said earlier, the likelihood of vertical transmission, that is transmission from the mom to the baby, as you can see from these figures, increases as you move in gestation. However, the likelihood of occurrence of severe manifestations at birth actually decrease with advancing gestation. So it is the infection in the first 14 weeks of pregnancy which has the maximum implications as far as neurological outcome is concerned. So if a lady has an infection in the 3rd trimester, though she has a risk of transmitting it to the baby, but the baby would not have those severe debilitating manifestations of congenital CMV. Also, presence of fetal abnormalities, that is the abnormalities that you pick up on imaging, especially the cerebral abnormalities, are important prognostic indicators. And the role of ultrasound and MRI is complementary. This is because ultrasound is good at picking up some things like intraventricular calcification better, whereas MRI is better at picking up other things like malformations of cortical development. Also, a normal ultrasound in MRI after 30 weeks, that is in the 3rd trimester of pregnancy, has a high negative predictive value. So you are reassured that the baby is not going to have an adverse neurological outcome. But it does not guarantee freedom from sensorineural hearing loss. There are certain isolated findings like these which tend to have a fair neurodevelopmental outcome. And studies have been done to look for CMV viral load in things like amniotic fluid in blood and fetal blood sampling for platelet count, but they don't seem to be that significant as well as prognostication is concerned. Now here is a flow chart for management of a fetus suspected to have infection. So when you see ultrasound features suggestive of severe infection, you would counsel the couple appropriately so that they make an informed decision, and they may opt to terminate the pregnancy, following which the fetus and placenta have to be examined. However, if there are non-severe findings like mild ventriculomegaly, some calcification, ventricular synecdoche, then all that you do is maternal serology, and if it is positive for IgG, remember you cannot rule out non-primary maternal infection here. And that is why you offer amniotic fluid CMV analysis. If that is negative, you reassure the family. However, if it is positive, it is their choice. They may opt for termination, or there is something new on the block, and that is valacyclovir, which is given in a high dose of 8 grams per day divided in 4 doses for treatment of fetal CMV. And there are recent studies which show that administration of valacyclovir, even in those fetuses who had normal ultrasound and MRI, results in a significant reduction in the sensorineural hearing loss postnatally. It is 12% and unilateral in the untreated group, vis-a-vis 50% and bilateral in the untreated group. So it's lower in the treated group. Also, with those minor imaging findings, if you give valacyclovir, those fetuses which are asymptomatic at 1 year are 65%, vis-a-vis just 30% in the untreated group. And the risk of neurological delay is 2% in the treated and 8% in the untreated group. So food for thought as far as treatment of fetal CMV is concerned. Thank you.
Thank you very much, Divya, for that clear presentation. Adding to the list of power-packed speakers of today, it's my pleasure and privilege to invite Mala Sibal onto the dais. And today Mala will be talking on ultrasound and adenomyosis, measure or look. Mala, as we all know, has like an encyclopedia of gynae ultrasound with her. Her book, I'm sure, is there in all of your clinics and offices, and she is an Issuerg International faculty member, an IOTA ambassador, and a regular at CUSP. Over to you, Mala.
Hello, everybody. Very good afternoon. At the outset, I'd like to thank Dr. Suresh for not just inviting me, for so much more that I cannot, I don't have time to go into details here. But thank you very much, Dr. Suresh. I'm really indebted to you for all the support. And I thank the Mediscan family for this actual academic feast that we have every now and then at CUSP. So the topic assigned to me was diagnosing adenomyosis, whether we need to look at features or measure certain structures, and let's see as we proceed which would be more appropriate. We all know adenomyosis is a pretty common gynecological disorder with presence of endometrial glands and stroma within the myometrium, which this most often results in hypertrophy of the adjoining myometrium. There's no known cause really, but in most cases, why this extension of endometrium happens onto the myometrium, but in some cases it may be associated with pelvic endometriosis when you see the progress from the external surface, serosal surface of the uterus, or when there's obstruction to antegrade menstrual flow. The gold standard for diagnosis is histopathological examination through hysterectomy specimens, and obviously, therefore, true prevalence is difficult to establish. Most patients are symptomatic with abnormal uterine bleeding or pain, and recently with advancing understanding of the features of adenomyosis and its recognition on MRI and ultrasound, they've realized it is responsible for subfertility. In a set of IVF patients, they've noticed that the pregnancy rates are about 28% lower, and there's about a 2 times higher rate of abortion. The diagnostic modality of choice are, both modalities that can diagnose adenomyosis are ultrasound and MRI, and obviously ultrasound is the diagnostic modality of choice. So let's see, how do we see adenomyosis on ultrasound? We all know that when adenomyosis begins, it is endometrial tissue moving into the junctional zone. This is the junctional zone, and therefore the endometrial tissue is obviously first seen in the junctional zone. And this endometrial tissue may be seen in the form of endometrial lines, as you can see over here. This is endometrium entering the myometrium, and slowly this endometrium proliferates, and you get endometrial buds, as you see here and you see here. With further proliferation, very often this endometrial tissue breaks away from the endometrium from which it arose, and you see endometrial islands, as you can see over here. Every month when the lady bleeds or menstruates, there's no way for the blood that is produced in this endometrial tissue or island to move out, and therefore it begins to collect in the center, as you see in these cystic spaces. Here you see it only in initial stages, and then you see this is how you see the cystic spaces with fluid in the center and a good amount of endometrial tissue lining it. But over a period of time, because of inflammation and fibrosis, what happens is the endometrial tissue itself may become less evident, and it sort of gets compressed and gets diminished, and you get these turbid, thick fluid within. So in all this, what we are seeing is really presence of endometrial tissue within the myometrium. Now, junctional zone, as a result of all these changes, very often appears prominent, hypoechoic, and for a long, long period, what we did was we measured the thickness of the junctional zone to make a diagnosis of adenomyosis. It was therefore then, it used to be then diagnosed objectively by measuring the junctional zone, and there were numerous studies. It all started off with measurement of the junction zone in MRI, where they used a cutoff of 12 millimeters. Then they saw what we could see instead on ultrasound, and they realized that there were numerous studies with cutoffs varying from 15.5 to 8 to 5.7 millimeters. But finally, what they realized is there was very poor correlation of the thickness of the junctional zone in the absence of other features. The junctional zone was very often difficult to measure because it was so ill-defined, and with newer machines, we've begun to see the morphology very, very well. So today, to come back to the original question, Do we measure or do we look for features? It's quite clear we should not measure the junction zone, but we should look at morphology. So let's look at this one video clip of a patient. Here you see the endometrium, the myometrium looks quite okay, except for this little cyst and a little bit of endometrial, a small endometrial line over here. But as you see, as we progress, you will see when you observe the junction zone carefully, you see cystic spaces, you see hyperechoic lines, you see we've moved to sepia mode to see we can visualize better. There is an endometrial island over here. There are cystic spaces. So you can see very well that the junctional zone is now got a lot of endometrial tissue going in from the endometrium into the myometrium, and you can also see that in a coronal rendered plane where you get the endometrial lines, irregular endomyometrial junction, and cystic spaces. This is another patient looking very different from this. Both these are cases of adenomyosis with irregular, interrupted, or ill-defined junction zone. And this can be seen not only on 3D, it can also be seen very well on 2D. You see the irregular, interrupted, and ill-defined endomyometrial junction. So this endometrial tissue then moves on further into the myometrium, causing more of hypertrophy. So the uterus the myometrium looks thick, coarse, with tiny myometrial cysts, hyperechoic endometrial islands, and fan-shaped acoustic shadowing. And this fan-shaped acoustic shadowing is because the cystic areas cause acoustic enhancement, whereas the edges of the cyst cause acoustic shadowing. So you have alternate shadowing, enhancement, shadowing. In addition, around this endometrial tissue, if there's any myometrial hypertrophy, that hypertrophied myometrium also causes edge shadows, and that ends up with this type of fan-shaped shadowing. This is often referred to as rain in the forest. As a result of the myometrial changes, what we may see is asymmetrical thickening of the myometrium. As you see here, this is the endometrium. Here the posterior wall is coarse and thick, here the anterior wall. And sometimes you see a nice uniformly thickened globular uterus because of uniform thickening of the myometrium, so the uterine body becomes globular. Now on Doppler, what we see in adenomyosis is intralesional flow, and this is really not very useful, I found, in diagnosing adenomyosis, but it is very useful when you want to distinguish it from fibroid uterus. So I know that this is not a fibroid. In a fibroid, flow is peripheral and circumferential. Similarly, if you need to differentiate between fibroid and adenomyosis, another important feature is that in adenomyosis, you do see intralesional acoustic shadowing. In fibroids, you see intralesional and edge shadows because of the well-delineated margins. Now, there's something called focal adenomyosis. That is, adenomyosis is considered focal if more than 25% of the circumference of this adenomyotic tissue is surrounded by normal myometrium. Let's look at this one case. There was a fibroid here in the anterior wall, more to the right. But as I moved to the left, most of the myometrium looked normal. But as I moved to the left, in the posterior wall, you could see this heterogeneous area with cystic spaces lined by endometrial tissue. Just this area, very difficult to delineate. But if you look here, this was an area where the myometrium did not look too good, and that was focal adenomyosis. Remember, focal adenomyosis is rare, and if you have a doubt whether it is focal or it is diffuse, call it diffuse adenomyosis. Now, sometimes this focal adenomyosis, because of hypertrophy of the surrounding myometrium, becomes more evident, and then it's called as adenomyoma, or it's more well-defined. Here again, you see long section, the myometrium looks okay, but as we move to the left, you begin to see these features of adenomyosis. You can see cystic areas lined with endometrial tissue on the left, compressing the endometrium on the left. And here you can see how this adenomyoma is actually bulging into the endometrium, and you can sort of measure it here because it is slightly better defined. So since an adenomyoma has basically got the same features of adenomyosis, on ultrasound you will see fan-shaped acoustic shadowing. You do not see edge shadows because it is not well defined like a fibroid. It has heterogeneous echos with cystic spaces, hyperechoic endometrial islands, and Typically, these are seen in the submucosa. That's because we know that endometrium moves from the tissue moves across the junctional zone into the myometrium. So obviously it is very often submucosal and it may even protrude into the endometrium. On Doppler, of course, flow is intralesional. So to summarize the features that we see, in some cases you can actually see endometrial tissue within the myometrium, like you can see here, endometrial lines, endometrial buds, endometrial islands, and cystic spaces which may be lined with endometrial tissue, and these are all called direct signs. But even if the cystic space is lined by endometrial tissue, but even if the cystic space doesn't show you very obvious endometrial tissue, this is all considered to be direct evidence of endometrium within the myometrium. This is diagnostic but has a low sensitivity, because if you don't observe the junctional zone well, or if the uterus is mid-positioned and you're only doing a transvaginal scan, you may not see these features properly. So we have indirect signs which are more obvious but less specific, and that is an ill-defined endomyometrial junction, a globularly enlarged uterine body, asymmetrical thickening of the myometrium, and acoustic shadowing. Now, these features are indicative that endometrial tissue is perhaps present in the myometrium, and therefore we are seeing these myometrial changes, and therefore they are less specific, because especially asymmetrical thickening, because one must remember that you can get asymmetrical thickening of the myometrium in a normal uterus because of uterine contractions. There are multiple, there's even a very interesting article where in the White Journal, where they've shown that within few minutes and hours you can see that the myometrium looks normal and the asymmetry is gone. So these indirect signs are today considered important, mainly because they help us pick up and they can tell us, please look carefully because you may find direct signs of adenomyosis. So it is suggested this should be used as prompters to look for direct features, or at least we should have 2 of the indirect signs to make a diagnosis of adenomyosis. Another important thing that I want to say is that sometimes these features are subtle. So look carefully at the junctional zone to pick up subtle adenomyosis. But remember, if a patient is asymptomatic, do not treat her for adenomyosis. We need to treat the patient, not the ultrasound findings. The other thing is, because this is a progressive pathology, you will see, when you call the patient back the next time, the myometrium and the uterus may look very different. Initially it may be like this, but later on when she comes, it may be like this, or it may be like this. Secondly, in the same patient, there may be some areas that show some features and some areas that show more advanced features depending upon the progress of adenomyosis in that area. I think it's the first time I've concluded well in time. So to conclude, it is not possible to go through this article, but this is a very nice article that has come out in the White Journal in 2019, which explains a little bit more about the difference between focal adenomyosis, adenomyoma, how do you assess how severe it is or how advanced it is, and how do you report adenomyosis. Thank you very much for a patient hearing.
Thank you very much, Mala, for actually putting it all together within 15 minutes and giving us a beautiful overview of images. I request the audience to put in your questions for the discussion. And it is my pleasure to now invite Dr. Labdans Kaur onto the dais to give us her insights into the accessory and cavitated uterine masses, or ACUM, diagnosis and clinical implications. Dr. Kaur is a consultant radiologist at Prime Diagnostic Center and has many talks and deliberations in international meetings, very keen on teaching and clinical presentations. Over to you, Dr. Kaur.
Thank you so much, Dr. Uma, for a very, very kind introduction. At the outset, I'd like to thank Professor Suresh, Dr. Indrani, and the entire CUSP team for having me over here. I wish to confess that Dr. Suresh has produced such intellect in the society that is unremarkable, and the way they perform today with such responsible citizens of India and even overseas. Hats off to Dr. Suresh. So with that, I would like to begin my talk on accessory cavitated uterine malformations, diagnosis and clinical implications. Before I actually talk about this particular entity, which I would be calling it as ACUM, I would like you to go through with me a case. This lady is a 32 years old lady who was suffering from pain in the lower abdomen, which persisted for months together, despite having so much of non-steroidal anti-inflammatory drugs, which were refractory. She had some relief with that, but again the pain used to appear. All prior ultrasounds which she was going forth had given the report as intramural and subserosal fibroids. This lady comes to me, again with the diagnosis. I do see a subserous pedunculated fibroid, as you can also see it here, arising from the left lateral wall. That's the pedicle which is supplying the subserous fibroid. But in addition to that, I do see another lesion, which is seen in the fundus, close to the left lateral wall, and that shows an altered echotexture. It's a hypoechoic lesion, right? And I had reported it as a pedunculated subserous fibroid with ACUM. I will be delineating all the features later on. This lady goes to an institute, and in the institute she undergoes a laparoscopy, where they do a myomectomy for the subserous fibroid, and considering the presence of the intramural fibroid, they reported as intramural fibroid with degeneration, nothing was done to that particular intramural mass, and they just operated upon the subserous fibroid. Considering the fact, this lady comes to me back after 8 months of myomectomy with the repeated pain and no relief after myomectomy. You see the plight of the woman post-myomectomy, that's the lesion. That was the ACUM, and this is the pre-myomectomy picture. The ACUM not only had increased to two times more than the previous scan, but also showed us another lesion. This has been done just a few days back, right? And now you see she's in for another laparoscopy. We don't even take blood samples twice. We avoid. We always ask we are concerned about the patient. This lady is undergoing a laparoscopy, second laparoscopy. So with that, I would like you to take a little glance to this unfamiliar entity called as ACUM, which is unrecognized, under-recognized gynecological condition. The knowledge of it is very, very crucial because diagnosis is challenging. We need early and correct diagnosis, which is pertinent for this particular entity. I coin it as diagnosis is therapy. If you are able to diagnose this entity correctly, you will provide a therapy. Otherwise, these women keep on coming with repeated pain, and they are reported very frequently as fibroids with degeneration. So with that, I come to this entity called as ACUM. It is a neomullerian anomaly. It has many theories of occurrence, but the most commonest is caused by duplication or persistence of the ductal malarial tissue due to dysfunction of the gubernaculum, and is located in the lateral aspect of the myometrium and inferior to the attachment of the round ligament. Until 2012, this entity was also called as juvenile cystic adenomyoma, cavitated adenomyoma, or a non-communicating accessory cavitated mass. It was in the first time, in the 2012, this entity was coined as ACUM. The various clinical presentations with patients come to us are presents at younger age, the median age being 29 years old, and associated with severe dysmenorrhea and recurrent pelvic pain, as happened in our case. The pain is often ipsilateral to the side of the lesion. It may radiate to the back or the leg, and is not associated with heavy bleeding or subfertility. The various imaging modalities, needless to say, ultrasound of course, and to head the list is the transvaginal ultrasound, 2D, 3D, color Doppler, power Doppler, and of course, transrectal ultrasound, especially the ones which are unmarried. MRI, we do have case reports of characterizing these lesions by MRI, but despite these reports on MRI, we must trust our own transvaginal ultrasound. In the ultrasound findings, first I'll tell you about the location of the lesion. As I told you, it's an isolated unilocular, it's a spherical lesion and is defined to the myometrium and is located either to the right or the left anterolateral wall, and we do not see any adenomyotic changes in the rest of the uterus, but yes, we can see adenomyotic features around the wall of the ACUM, and that happens because of the intracystic pressure of the blood products which are contained within the cavity of the ACUM. Now, as I told you that this lesion is confined to the myometrium, so as I gently push upon the cervix, this lesion would move with the movement of the uterus. So that indicates that it is confined to the myometrium. Second point to categorize this lesion is that ACUM is seen inferior to the interstitial segment of the fallopian tubes. Now, before I tell you how does ACUM present as, I would like you to take you through this transverse section, the video in the transverse section of the uterus, showing you how do we see the interstitial segment of the fallopian tube. Now, once you go from fundus to the cervix or cervix to the fundus, as you approach the endometrium, you see this black line and this another black line. These are the two interstitial segments of the fallopian tube. Remember, when you see the interstitial segment of the fallopian tubes, you will not see the endometrium under view. So that's another hint. And you can also see the same on the longitudinal section. And this is to show you an example of the ACUM. As you see this particular lesion on a longitudinal view, it is seen below the level of the interstitial segment of the fallopian tube. If I just happen to stop here and show you, that is the interstitial segment of the fallopian tube in the longitudinal way, and that is better appreciated on a volume of the 3D which I have walking through. And as I walk through this lesion, I see the interstitial segment of the fallopian tube in a much clearer and a better way, and that shows you the ACUM, or that shows the lesion which is seen inferior to the interstitial segment of the fallopian tube. Also, this can be appreciated and on the 3D. The 3D shows you that since I told you that it's seen inferior to the interstitial segment of the fallopian tube, it will be seen not in the line of the corner of the uterine cavity. That is the rendering box of the 3D. That's the green line, all called the rendering line. It's not touching the endometrium. So as you see here, since it's not touching the endometrium, I am seeing the lesion and not the cavity. And the same is depicted on the HD live images. You are seeing the endometrial cavity, you don't see the lesion, and here you see the lesion because it is not in line with the cornua of the endometrial cavity, and it is seen in a different plane than the endometrial cavity. So that's how you can categorize the presence of the lesion in the myometrium. Now talking about the lesion per se. The characteristics of the lesion are, it's a cavitated lesion and is surrounded by a thick, relatively isoechoic myometrial mantle. It is seen in the confinements of the uterus and can produce a bulge depending upon the size of the lesion. It also shows you the fluid-filled cavity. The fluid can have varying echogenicities depending upon the stages of bleeding in different phases. So that is how you could see a hypoechoic or a ground glass appearance. You could see an echogenic appearance. You could see the fluid content. It could also produce you a fluid level. So all this varying picture can be seen as far as the cavity is concerned. One more thing I would like you to draw your attention to, and that is the lining of the cavity, which is slightly hyperechoic. That is the functional endometrium which lines the cavity of the content. So that's important to understand, that this tells you that you are looking at another picture, what is called as uterus in uterus. So this acum is a kind of uterus in itself. It has a wall, it has a smooth muscle, it has a lining which is like endometrium. It's functional endometrium. The endometrium, there are receptors, CD10 receptors are seen on microscopy, which tells you that it is functional endometrial lining of the cavity. Then it's a good idea to have a look at the gross specimen. Once you look at the gross specimen, you understand the sonological appearances much better. That was the case. We cut open the acum and you see the circumferential arrangement of the muscle, right? The smooth muscle fibers in a concentric orientation, and that is the chocolate colored fluid which is seen in the cavity, which is similar to what you see on a 2D and a 3D ultrasound. That is the concentric appearance of the smooth muscle visualized on 2D and 3D, and the content which has been brought out nicely. Even the color and the power Doppler helps you to assess the vascular pattern, which shows you a separate vascularity of both the acum as well as the uterus, thereby telling you you are looking at a uterus in uterus appearance. That supports the theory of malformation rather just an adenomyotic cyst. Also, you can see these vessels, the arcuate vessels, which are seen medial to the acum, thereby telling you you are having a proper uterus with proper vascularity, and this is another lesion which is seen within the confinements of the uterus and is seen beyond the arcuate vessels or seen lateral to the arcuate vessels, thereby again telling you a uterus in uterus appearance, which can be also appreciated, the vessels can be also appreciated on a 3D, where you thereby see these arcuate vessels and you do not see the cornua or the endometrial cavity. That means acum is seen not in line with the cornua. So remember clinical history, remember the characteristic location as I explained to you, remember the grayscale and the color Doppler findings, which help you to actually make a diagnosis of this particular entity and help you differentiating from others. We'll talk about the differential diagnosis, taking you through a case. A 25 years of medical student presents with history of painful episodes in the left iliac fossa, which increased during menstruation. She was refractory to analgesics, and the provisional diagnosis was a fibroid with degeneration. And there was another, that was the acum which was seen here, producing a slight bulge. We went in and did a transrectal ultrasound, showed us all the characteristic features of an acum, and which also elicited pain on probe pressure. Patient underwent an MRI, which showed all the features of increased signal of TT on T1 and T2, telling us that we were looking at the blood products or the hematometra, which was seen in the cavity of the ecum. And here also you see uterus in uterus appearance. So two uterus having their own independent endometrial cavity, but the mass is inside the uterus. But most important thing I would like to, you see the quality of the MR here, and you see the quality of the ultrasound images which I have provided. So that was the patient's laparoscopic surgery which was performed, and the mass was dissected from the uterine myometrium interface, and the chocolate colored fluid is seen spill into from the ecum. Another case, similar picture, ultrasound done and underwent histopathology, turned out to be ecum. All I need to tell you that this is an endometrial tissue which is lining, shows you classical staining, positive for CD10, estrogen receptors and progesterone receptors, telling us that this is the normal endometrium which lines the cavity of the ecum. And then coming to the differential diagnosis, I'll just take a minute or two. It's very important to differentiate this condition from conditions which happen to have the same location in the uterus, and that is, one is cystic adenomyoma. We've heard about adenomyosis, when it happens to occur in the place where you see the ecum, but here you see it is seen superior to the interstitial segment of the fallopian tube. Here you see that it lacks the endometrial lining and the capsule and the typical myometrial mantle, and all you see are adenomyotic changes which are seen around the cystic area. So that differentiates it from ecum, and also a lesion of cystic adenomyoma will abut the endometrial lining and can show you a fluid level. Contrary to the fact this lady was diagnosed as ecum, comes to me, and this was not ecum. You see, there is cutoff of the endometrial cavity. There are changes of what you called as echogenic islands seen across the endometrium in one of the sections here on sagittal as well as on the transverse imaging, and also you see that there are features of adenomyosis, as I just told you, and the cystic lesion is seen above the interstitial segment. If you look at the fibroid in the cornua, as I told you the location, the fibroid is producing a typical edge and internal shadowing, whereas ecum, cystic cavity, will produce a posterior acoustic enhancement. And if you have a lesion with cystic areas, then color Doppler or power Doppler comes to rescue, where in fibroid you will have vessels approaching from the arcuate arteries, whereas in ecum it will have its own vascular supply. So that is a differential from the obstructed part of the in the unicornate uterus. And I come to the end by talking about the management. We have several treatment options for ecum, ranging from simple analgesia to complete excision, which range from medical management with GnRH agonists or oral contraceptives. We have few case reports with ultrasound-guided alcohol therapy. Then, of course, cryotherapy is under trial. And, of course, I would like to say complete surgical excision is curative. And the take-home is that we must suggest a higher awareness for ecum among the expert sonographers or whosoever is doing a gynae ultrasound in young girls, apart from looking at the pelvic pain, as you must have a probability of ecum in mind, and accurate diagnosis and surgical management gives us complete cure and can change the quality of life forever. So I would like to iterate and say diagnosis is therapy. Thank you so much for a very, very patient hearing.
Thank you very much, Dr. Labdin Scott. As the last talk for this session, I invite Dr. Sridevi, who is a consultant at Pinnacle Hospitals and Pinnacle Imaging Center at Visakhapatnam. Sridevi is very quietly efficient, a very committed clinician who has a deep interest in teaching and training. And today she will be talking to us upon an evidence-based approach, the use of ultrasound to optimize fertility treatment. Over to you, Sridevi.
Thank you, Dr. Uma. And I would like to thank the organizers, especially Suresh, for making me part of the CUSP. I think it is more than a decade I'm part of the CUSP from the time I'm his student. You all would have seen me as a fetal medicine consultant, but hope I do a good job in the use of ultrasound in infertility. How do we optimize in the fertility treatments? So I have gone through many papers during the preparation of this lecture, and the main thing where I saw the ultrasound fits for the infertility is to see whether the anatomy is normal and the physiology is normal or not. So to look at the anatomy, normal or not, is where the ultrasound fits. So for the physiology, we always need some of the blood tests, but yes, the use of ultrasound sometimes indirectly tells about the physiological aspects, especially when coming to the infertility. So how the ultrasound helps? It helps to diagnose the possible cause of infertility. So the first scan when we do, it helps us to see whether the anatomical structures are normal or not. And then it is very important in infertility treatments to see whether the patient's response to the exogenous gonadotrophin, so whatever treatment modalities they started on these patients, the response is there or not. And it is I can say this is the only way most of the infertility specialists use the ultrasound to see how the treatment is going on. So to know how the response and to see how the structures are, we always need a systemic approach. So most of us do the scan from the uterus, but let us see the scan starts from the vagina, not from the uterus. So these are some of the examples where we can see this is a vagina. And as we come inside, we can see the bladder on the one side. This is the rectum, and you can see that we are imaging from the anterior fornix, the cervix, and the uterus. So this is the next case where you can see the probe is inserted, but still a white line is seen just below your probe. This gave the suspicion that it is not only the vagina, but there is something we see in the white line. So the gel vaginal sonography was done in this patient, and this is a septate uterus. These septums are usually missed because this patient had 2 IUI cycles, but because they use a speculum and the septum is actually not seen. And this is another case where they had postcoital bleeding, and you can see the polyp, and when we have done the scan, it is not one polyp, there is another polyp down here. And again, this is also a case for infertility. When they came, we can see this polyp nicely protruding, which probably might be the cause of the infertility. There's also a case of gel vaginal sonogram. And this is a very interesting case. The patient came. You can see that I just hardly kept the probe inside. The vagina is so shallow and the cystic structure in the vagina, and this is the endometrial cavity which is actually communicating here. This is when we started asking the history. She told she had primary amenorrhea and had a surgery, after which she had periods, but it was scanty, and a resurgery was done, and none of the husband's family side knows about it. When we evaluated and got the MRI done, she had absent vagina and absent cervix also. So once we start know the diagnosis, I think the clinician knows what to offer them. So the scan is not a single scan in infertility, because one single scan helps us to know if the anatomy is normal or not, but to know the response to the endogenous hormones, that means in a normal cycle, you have to see them in all the phases of the menstrual cycle, because every phase is important for these women to conceive. So the baseline scan, yes, because the hormones are baseline, we can see the endometrium and all thin, but many of us even count the antral follicles at this point of time. I think we can do it even in the premenstrual time, the antral follicular count, reason being they are recruited in the previous cycle. So once you get a patient, don't think this is not the time. Yes, that is a first opportunity for you to rule out this anatomy is normal or not. And in the next cycle, you can, depending upon the problem you are looking at, you can ask the patient to come at that point. For example, for polyps, yes, this is the best time. For the Mullerian anomalies, yes, you need secretory phase. So you can time your scans, but don't think this is not the time. When the patient comes for the first time for the consultation, you can use that as an opportunity to rule out the anatomy of the anatomy is normal or not. So the position of the uterus, orientation, everything is very important because here also there are some procedures they do in infertility where you have to see whether the uterus is anteverted, retroverted, anteflex, retroflex, because this is the information we give them when they do sometimes the catheter insertion in IUI or embryo transfer is difficult. Now most of them move to ultrasound guided embryo transfers. So that when you give the length of the uterus from the external os to the serosal surface is the length, anatomical length, and this is the functional length of the uterus. When we give this information, they know how to calculate to put the guide length measurements. And this is the third measurement when you take, and always in my lectures, I think most of you would have seen this picture. Can you see the endometrium is playing on either side? This should be your anatomical landmark for the third measurement because this gives us a lot of information. Let's see how. So if eyeballing says this uterus is normal and this uteruses are small, but volumes tells us they're really small or not. When the uterus size is small, we always open the uterus and see whether this is a unicornate or this is just a small uterus but the cavity shape is normal. So when the uterus is asymmetrically enlarged like this, I think Dr. Mala now, we had a lecture how to diagnose adenomyosis. This is fan shape, this is the shadows we can see typically in adenomyosis, and these are the shadows, edge shadowing, which we see in the fibroids. So this is the third measurement which I was talking about, the axial measurement. This is how the endometrium goes to on either side. So here it's beaking to one side and we see two islands of endometrium with a intervening myometrium in between. So this is where 3D helps us to say, you can see this is a unicornate and this is a septate uterus, but itself is a lecture to how to diagnose the Mullerian anomalies, but screening 2D helps us to suspect and know which patients we have to go for 3D. So unless you suspect in 2D, you cannot go for 3D because if you're good in 2D, I think you will be good in, if you're good in 2D, you will be good in 3D also. So moving from the myometrium to the endomyometrial junction, as Dr. Mala also previously told that adenomyosis, the chances of infertility is more, so it starts from the endomyometrial junction. And before moving to the next structures, I just would like to speak a little about the Dopplers because the angiogenesis plays a crucial role in the various female reproductive processes like follicular genesis, corpus luteal formation, growth of the endometrium, and implantation. So where do we see the Dopplers? In the uterus, it's the uterine artery, endometrium, it's the spiral arteries, ovaries, the stromal and the perifollicular floors. So uterine artery Dopplers, the normal it is 2.2 to 3.16. It is not like the pregnancy scans. So moving to the ovary, ovarian reserve, it reflects the number of oocytes that are available for procreation. So whenever we see the ovary, we have to see the preantral or the antral follicles and rule out there is any pathology or not. So this is how we see the ovary, and this is how we count the antral follicles. And this is how we have to see whether the follicle is the ovarian origin or non-ovarian origin. You can see the ovarian tissue here. You can see the ovary and the cyst are moving apart. So this cyst is not ovarian origin, but this cyst is ovarian origin. And we can see this is more commonly seen. This is the hemorrhagic cyst, where we can see the cyst within the ovary, but you can see they're moving along with that. So every gynec scan, you have to talk to the patient, because most of the time the patients take you to the diagnosis. So whenever you see the ovary, you have to see the volume, antral follicular count, Dopplers, and 3D. This is how we take the antral follicular count. The 3D is, in some centers we do routinely 3D. But what are these antral follicular counts? These are pool of follicles recruited from in the follicular phase, which are 2 to 10 millimeters. But the ones which are above 4 millimeters have the receptors for the gonadotrophins. So the ones which have receptors for the gonadotrophins are the ones which are going to get stimulated with the exogenous, that means the injections or the medications they're going to give. So we can expect whether these women are poor responders or hyper responders, and they can actually use these information to give the medication dosage. So 3D, yes, it is more accurate when the sono-AVC, the smaller follicles also can be seen, especially when the number is more, we will be able to get them more accurately. And many times we will be thinking, why stromal flows, why stromal flows? Yes, the stromal flows are the ones which deliver the gonadotrophins to the follicles. So if there are good flows, the response will be good. So with these information, we can actually classify the ovaries into normal, polycystic, or low reserve. And this information also tells whether these are how these are going to respond or not. So in the pre-ovulatory scan, we are going to see the dominant follicle, Doppler, and the endometrium. Just measuring the follicle, we know the size, but when we add the color flows and the Dopplers, we know how the mature this follicle, and the timing of HCG gives us very good results in these cases. So moving to the endometrium, you can see here this little amount of the fluid. So this is the basal, this is the functional, and this is the cavity. Approximation of both the sides gives this triple line appearance. And we all know that endometrium changes with the phase of the cycle. Please remember, there are two things in the endometrium, because endometrium is the end organ. So if the endometrium is not in sync with the cycle, that means this follicle is not a very good follicle which is giving either the hormones, or this endometrium is a defective that it is not responding. So you have to just see two things. That means there is no proper follicle, or this endometrium is defective. So we all know this, how the endometrium looks in different phases, how it is classified, and this is how we see the zone of the vascularity. As the good vascularity, the outcomes are good. Sometimes the endometrial thickness might be small, but the volumes will be good, and that also gives, especially in frozen embryo transfers, when they want to plan the cycle. And these are the common endometrial pathologies we come across: synecdoche, polyps, and endometrial cysts. The correction of these improve the fertility. So moving to the secretory phase, we can see just not by seeing the corpus luteal cyst, but you have to see the Dopplers. Good vascularity, that means the good secretion of the hormones, and the appearance of the endometrium gives us the information about the quality at this phase. So when I was actually going through, preparing for this lecture, I just came across this very interesting thing by Dr. Scott. The 6 most dangerous words in evidence-based medicine is, there is no evidence to suggest that. It doesn't cause any adverse events, but it doesn't directly cause the medical errors or administration in the quality of care. However, they may directly cause the adverse consequences by leading to false inferences in decision making. So because whenever we read a paper, the end of the most of the papers have this this one line in this. So whenever we are doing anything, whether it is in obstetrics, gynecology, or infertility, most of our evidence comes from either expert opinions or case series, case controls, or current. So we need to know, depending on what we are taking, how relevant the examples we are taking to give our clinical decisions. So this is very important. So in infertility, ultrasound, I think, the role is to know whether the anatomy is normal or not. Here, it's not one scan. We have to do 3 scans in all the 3 phases of the menstrual cycle. And the assessment of blood flows by Doppler adds a physiological dimension to the anatomical ultrasound parameters. And thank you very much. I think I should thank Dr. Sonal and Dr. Mala, from whom I have learned the gynec and infertility ultrasound. I really thank them both so much, and this is the first time I'm having Mala along with me, so thank you so much, Mala.
Thank you very much, Sridevi, for walking us through that in a beautiful fashion, and you must all agree that that was a wonderful session. And I would now request Dr. Sudarshan to come forward and handle the Q&A. While that is happening, and to give you a couple of minutes to post a few more questions, I'm also going to say that immediately after this discussion, we are going to draw the lots to pick up the candidates who are going to be part, in the quiz. And Chitra is going to do the honors and pull out the 12 names from the box.
Okay.
The question, yeah. Just a couple of questions, I think we have time for. Everything is on ACOM, I think.
Yeah, everything is on ACOM. So, how does ACOM differ from juvenile cystic adenomyoma?
Initially, before 2012, juvenile cystic adenomyoma, as I told you, they were reported as, the ACOM was coined after 2012. So initially you had many names for it. It was after 2012 when ACOM was coined. So merely all these lesions, they are same and they are part of ACOM. They represent ACOM today. The only thing which I think what you want to understand is that you need to know how do we differentiate a cystic adenomyoma, right? So juvenile cystic adenomyoma is the same as what we call as ACOM, but cystic adenomyoma with cystic, when you have adenomyotic changes, is what is called as cystoid adenomyoma. Like you see, and when you see the changes, right starting from the endometrium to the myometrium, which produces adenomyosis, and then you have associated cystic changes in the myometrium. So that is different, right? The location will be different. The presentation will be different. You will have adenomyotic changes in the uterus other than seeing a cystic lesion. I think the second is also mine. So how do we differentiate ACOM from a rudimentary horn? Yes, that is a good question. I had put up a slide in the differential diagnosis. So once you have a rudimentary horn, you have a 2D ultrasound, you can resort to a 3D ultrasound. That helps you to differentiate the Mullerian abnormalities and helps you to differentiate rudimentary horns which are obstructed and present with hematometra and can be differentiated from ACOM. Reproductive outcome of ACOM is they do not have any problem of reproduction. These women, even in Paris women, we have seen cases. Even in pregnancy, I had actually put up a slide where the lady is about 8 to 9 weeks of pregnancy and was harboring ACOM. So you can see ACOM with pregnancy, and people deliver after, even with ACOM, right? So the ladies have come to us even after pregnancy saying the pain is there. They keep on persisting with the pain and they reproduce well. It does not cause any aberrant effect on your fertility status. I think it's all done.
Okay, now
I've answered
reproductive outcome.
Yeah.
There is an announcement that booklets are available at the Education Department for sale. To get hands-on experience on simulator at the venue, please register yourself at the education department. There are various simulators with various volumes and images and videos to work on. If you want to get hands-on training on that, you can go and visit educational department, and if you want to buy booklets, you can visit education department. Thank you.
Thank you. Handling one anomaly is a challenge. And if the same person comes back with the anomaly the second time, it's a nightmare. And to handle this session, we have none other than Professor Suresh, who will be handling the session on recurrent fetal anomaly towards ensuring a normal child. So I call upon Dr. Suresh to take the stage and call the panelists. We have our panelists, Dr. Janak Desai, Dr. Jayareka and Dr. Chinmayi, and Dr. Suresh will introduce them and then take you through the panel.
The delegates who are selected for the grand quiz, I'll just read out the names. Dr. Anjali Malhotra, cusp number 93. Dr. Deepika, the mobile number is given. I will SMS you separately. Dr. Sangeeta Srivastava, Dr. Aishwarya from Coimbatore, Dr. Kumar Guruprasad, Dr. Varun Thakur, Dr. Vanita A, Dr. Tazeen Khan, Dr. Jita, Dr. Rajesh Senthu, Dr. Arpita Reddy. So individually I will send SMS so that it will be here beforehand. Thank you.
Okay, are we ready to start?
Yes.
Okay, good afternoon and welcome to this panel. First thing, you have attended a lot of panels, but you realize this panel is very, very small, just 3 people. And the reason is, it's a power-packed panel, so that whatever questions are put, the responsibility becomes higher. You can't share it and say, pass it on. Just to introduce Dr. Janak Desai, he's a fetal medicine consultant from Ahmedabad. I think he's been practicing for over 2.5 decades now and runs a good training program also. Jayareka is our geneticist working at Mediscan, and many times we've had arguments. Some of the cases which we have said, there are many times I argue with her, why are you not doing this test? And she said, no, I don't want to do this test, let us do some other test. So we are here to understand that when a patient comes with repeated anomalies, somebody has to give a solution to them because that family is desperate to have a normal child. So let's see how our panelists take one. Chinmayi is somebody who's already been introduced. We had that fantastic debate today. So the parent's perspective for recurrent fetal anomaly is one of anxiety. Their anxiety is so high, sometimes when there's enormous anxiety, it leads to irrational thinking. And one of the things they do is they go from pillar to post in the fond hope that somebody will give a solution. And a very typical thing that happens is when they are with an obstetrician and she delivers a baby with an anomaly, second time they go to somebody else in the fond hope that changing the obstetrician will prevent the anomaly from happening. It's a common thing in practice, more like it's a psychological feeling. The next question they ask is, can this anomaly be prevented? What should I do? Did I do something wrong in my eating habits? Did I do something wrong with, maybe I traveled to some place or I slept on the right side instead of the left side? Some reason they want to say, they want to pin the responsibility on somebody or some aspect of their life to say this is what had happened, with the fond hope that if they avoid that, next time things will be better. And the question is, any testing to be done prior to pregnancy? So let's discuss some cases and let's go to the first case. She's a 25-year-old primey come for a target scan at 20 weeks. Ultrasound reveals an open neural tube defect. After understanding the anomaly, the couple's questions, we have decided to terminate the pregnancy. What is the likelihood of this anomaly repeating again? So, Janak, this is the case for you. Do you agree with the diagnosis, and you want to take us through this?
Yes, sir. This is the all images depicting the open neural tube defect, including the splaying of the posterior ossification center and Lemon sign, increased ventriculomegaly. So in these all images, the sonologist has documented there is a open spinal defect and with the cranial signs.
And you come across this very often, isn't it?
This is very common, sir.
Very common. And what is the first question the patient asks you?
Basically, first question there is whether this to be continued the pregnancy, yes or no. And if it is, as a fetal medicine concern, we need to answer that the prognosis, and usually we favor the decision that they want to continue, discontinue the pregnancy. In this type of cases, we always support that.
Okay. So, so the question now is, they have decided to terminate the pregnancy.
Yes.
And their next question will be, will it come back again? Will it repeat again?
Yes, there is a, usually the recurrence chance, this is a multifactorial anomaly.
Okay.
And so the recurrence chance is around about 3 to 5%.
Okay.
If it is isolated and not like that.
Okay, Chinmay, are there any subclass of patients where this neural tube defect has an increased recurrence? Or supposing there's somebody else in the family who's having, do you need to see what happened in the family so that it's a recurrent anomaly?
Sir, as he said, the cause is usually multifactorial, but some important things that we need to know, because one of them we think is folic acid deficiency.
Yes.
So if the mother has a definite condition which can lead to folic acid deficiency, either it's nutritional or some inherent condition where her own metabolism is affected. So that is one thing we can think of. Or if there is a pre-pregnancy teratogenic effect, like maybe diabetes or intake of some medication or something which can again be a persistent factor. So
Okay.
those are the things I would evaluate. Like
So she spoke about intake of any medication. Jaireka, are there any medications or teratogens which can cause neural tube defects?
the
Mike. Yeah, correct.
So maternal diabetes is a known cause for causing neural tube defects. Anti-epileptic drugs has also been reported to cause neural tube
Okay,
defects.
so you get all that information, and then they are still asking you as a geneticist about recurrence defects. Do you agree with her 3 to 5%?
Is multifactorial inheritance or the disorders which are thought to occur due to interplay between a genetic and environmental factors. When we look at a pedigree, it doesn't fit into a particular Mendelian inheritance form. So the recurrence risk for any multifactorial disorder is 3 to 5% in the next pregnancy. If there is another fetus that is affected with the same problem, then we say the recurrence risk increases to 8 to 10%.
Okay,
For the next.
it's repeated. So can she attempt that? Chinmay, she wants to know when to go for the next pregnancy.
First and foremost, we have to be sure that this is isolated neural tube defect, nothing else. So
yes, beautiful picture.
You have beautiful pictures, but suppose it is part of any other syndromic association, like there is a chromosomal translocation or some other problem because of which this has happened.
You opened up a Pandora's box now. Chromosomal translocation. For neural tube defects, do you do karyotype?
Generally we won't, sir, but then the whole session is about recurrence. So if she asks specifically about recurrence.
No. She's just a patient who has come to me with neural tube defect. That's all.
So sir, now that we are counseling.
Every patient is going to ask for that recurrence, isn't it?
So if she's going to ask for recurrence, this is what we'll tell, that most of the times it is multifactorial. We don't have that recurrence. But either we have a family
So you told me
history.
folic acid can be given.
Sir?
you told me folic acid can be given.
Yes, sir.
So definitely she will take folic acid, not a problem. So can she be assured of having another normal baby? Janak, folic acid she is taking 3 months. You have told her.
Sir, usually I counsel this type of patient that the recurrence, we will give you the drug, folic acid and B12 in combination, at least for 3 months, but that will only cover the factors which are due to the deficiency of these vitamins only.
Okay.
This is a multifactorial, so we don't guarantee to the patient that it will not recur by just giving the folic acid and B12.
Okay.
Because there is a multifactor. There can be only genetic component also.
Okay, so the patient is very worried. Why not we do some genetic sequencing, whatever you want to call it as, and then tell her your genes are fine, you are going to get a normal baby next time.
Sir, usually we don't do that, but genetician is there, so we can.
So this is a priming who is coming with a first pregnancy with a very clear ultrasound picture of a neural tube defect. We don't suggest any genetic investigations.
Okay, right. So that the couple decide to terminate the pregnancy, they are very upset and definitely don't come for follow-up. Like I told you, they change doctors. And then 1 year later, she comes for the next pregnancy at 12 weeks because the doctor said next time you please come early, so 12 weeks. And obviously you can see this image. Yes, sir. You don't need any other image to say that this baby has got a neural tube defect. So the couple's questions are, I've been taking folic acid for the past 3 months, why the recurrence and what about future pregnancies? In a way, you had answered the question that folic acid will address only the component of neural tube defect due to the deficiency, and when it's multifactorial, there may be other factors which may be playing a role here. But then they're asking, okay doctor, do some test. Tell me next time I will have a normal baby. What's the hope for her?
So, okay. So this is a couple who has come with a second time neural tube defect. Still, isolated neural tube defects are not known to have any associated genetic associations. So we would suggest at least to store the DNA and to send the fetus for autopsy to look for any additional signs.
So she put a new term called isolated neural tube defect, and a lot of us say while doing ultrasound, this and if it's isolated then things are better. So Janak, in your term, what is meant by isolated?
Isolated means it is practically there is no other system is involved for a fetal medicine consultant. But theoretically it should not be there is genetically also normal.
Fine. So Chinmay is a fantastic fetal medicine person. She does such superb imaging. Can you not tell it's isolated just by looking at the scan? Why do you need any more tests?
No, sir, it's a little difficult because the brain and the spine are interrelated.
Okay.
So even if it's just a neural tube defect, the pressure effects can cause, cortical thinning and things like that.
So what is your advice for this patient? What should they do now?
So now that it has recurred, we definitely are looking at some cause which is happening again. I was thinking of translocations earlier, but the translocations may not always present in the same way.
Okay.
If you were not happy with doing the chromosome analysis of the fetus, maybe we could have done the parents' chromosomes if they were carriers of translocations in the first place. But now that it is like that, I would talk to the geneticist and want a detailed genetic evaluation, like a clinical exome.
So when I went to the geneticist, she said, no, not genetic evaluation, bring the fetus for autopsy.
Yes,
but
sir,
at this
autopsy.
gestation, again, autopsy, how much will it yield at 12 weeks?
Is it good to do autopsy at 12 weeks?
Okay, she has come. Still, we could do a detailed autopsy and see whether any other system involvement is there, and we could suggest a DNA store because there is a recurrence of neural tube defect.
So
from maybe the fetus, sir.
Pardon?
By doing a fetal skin biopsy, we could store a DNA.
Okay, you are because you are a genetics unit, your material storing DNA is fine. But this autopsy thing, she says 12 weeks is not good enough.
I'm a little apprehensive, sir. We
Sir,
don't have
whatever the
pathologists.
information, autopsy experts, perinatal pathology expert, whatever the information, they may find out some additional information.
Even a small amount of
So
information.
this discussion clearly proves that I have not shared this information with any of those panelists there, right? So this is an open discussion. This is truth and honesty that's coming out. Fantastic. So we did the autopsy because the geneticist wanted. And can you read what is there? Can you
Okay.
show what is there?
Sir, okay. So the fetus, the fetogram shows abnormal ribs and vertebrae, and the external appearance of the fetus shows myelomeningocele.
Okay. So there is a
so-
neural tube defect, without a doubt. That's what the baby had. But in addition, the baby seems to have abnormal ribs, which is not normally seen with a neural tube defect. So this baby which has recurred, but first we are not aware of how the first baby's ribs were, but in this definitely there is a change in the pattern. So a fetogram has given a lot of information in this case. But with this information, the pathologist comes and tells you, look here, this is not neural tube defect alone, but this is spondylothoracic dysplasia. And so now with you, you've got a DNA stored now.
Yes, sir.
So do you want to do something with that, or you
Yes,
are happy?
sir. Spondylothoracic dysplasias or single gene disorders that usually comes in autosomal recessive inheritance. So it's better we do investigations from the stored DNA by doing a whole exome sequencing to find out the exact genetic
But
cause.
let me play the devil's advocate here, okay? Remember, this is a 12-week scan. And in 12-week scan, both Chinmay and Janak found out this baby had neural tube defect. Okay? In the next pregnancy, at 12 weeks, if this anomaly is there, I'm going to find it out. Agreed? I can't do it earlier than that. So you are going to do a genetic analysis and tell me that LR1, 25.35, there is a micro deletion here, there, all that. Is it going to help this patient? Is it going to help this patient at all?
So the information is still important because first they will know that there is a 25% chance of recurrence.
Correct.
And-
But I got it from here. I
Yes.
already got it from here.
Yes, sir. So now in this age, we have a capacity of doing even pre-implantation genetics.
Ah.
So that can change their...
So that comes the point that if we are going to find it out too early, we need to go and get this baby before it actually manifests itself, which is in a pre-implantation. So coming to that pre-implantation point now, they are doing it from one cell, I heard. From the embryo, they pull out one cell. You are going to tell me about a complex genetic mutation which is there. Do you think they can do that from that? Is it possible?
Yes, sir.
It's possible?
Yes,
Okay.
it's possible.
That's very reassuring. So what are the lessons we have learned here? One is even a simple neural tube defect, don't take it for granted. Somebody go and exactly examine the baby, and a simple thing to do with any neural tube defect, just take an X-ray. Once you take an X-ray, you rule out, yes, it is plain neural tube defect or it's something more. If it's something more, her recurrence chances are changed, her counseling changes, everything changes. Now, for a straightforward neural tube defect with no other problems, whether you need to store DNA is a question. But if you go to ask any geneticist, they will say, my only recourse to answers is DNA. So somewhere you store it, any which day, supposing 5 years from now I want some information, I can get it from there. That will be their approach. So, and a fetogram said, now let's go on to the second case. Now this is a non-consanguineous couple, a little bit different. 13 weeks shows nuchal edema, 4.6, diffuse subcutaneous edema, and it was a missed miscarriage. Second one at 10 weeks, again nuchal edema, 3.2 millimeters, subcutaneous edema, missed miscarriage. Third, missed miscarriage by 7 weeks. Before we could know whether there was any edema or not, already became. Now she has come for the fourth pregnancy. Parental karyotype done elsewhere reported normal. Now let's go get differing opinions here. Opinion number one, first let's go to the geneticist. 3 miscarriages, okay? They said parental karyotype done elsewhere reported as normal. So anything more to do other than parental karyotype?
Hello, sir. The one thing we could have done is we could have investigated from the products of infection and the products of conception from the previous pregnancies we could have tried karyotype Bob's or karyotype to know whether chromosomal abnormality was the reason for the increased nuchal edema or the miscarriage.
Okay, so Chinmay, this patient comes to you with recurrent miscarriage like this, what would be your call? Because by the time she comes to you, the heartbeat has already stopped. There's only some tissue which is there.
Sir, I would just want to first evaluate what happened in the first two cases. I mean, she had increased...
We don't know. For nuchal edema, 4.6, the baby expelled, that's all.
What is her blood group, whether she has any antibodies, and
Okay.
if no evaluation was done, this is where we kind of suffer in cases of recurrent problems.
Let us take it like this. To make matters simple, she has gone through all the common investigation that needs to be done. Diabetes has been ruled out, her blood parameters are normal, everything, the infection screen, everything has been done, all that is normal.
And sir, parental karyotype is also normal.
Yes.
But still, one thing which we have missed by not doing the product of conception is, if there was any gonadal mosaicism in the parents, it would only manifest in the product of conception.
Okay.
So if once that had been checked, that would also be ruled out.
But see, the parent is not worried about all that. Tell us what to do. Can I, G4 will be all right or no? That's all she wants to know.
We need more information, sir.
You need more
We'll,
info.
we'll see the G4 scans and then we'll...
Because the G has already happened, so to know yes or no, you're going to do a scan, isn't it? So let's go and see the scan. So this is G4. Janak?
Yes, sir. So this baby is also not normal, sir. And having the increased NT probably, and cystic hygroma developing.
Yes.
So this is the repetition of what it was.
So it's a G4. Now you have something in your hands. The
Yes,
baby's heartbeat is still there.
Yes.
So what would you do now?
Sir, this anyway has to now get terminated. So once the product of conception is out, now this is a fetus only at 10 weeks. So still if the pathologist, I will speak to the pathologist and geneticist. So we need DNA. DNA we can take out from product of conception. If
Why not
the
CVS? Why not CVS now?
CVS at...
Sir, it's already non-viable and it will come out as a chunk.
Okay.
So I can collect it from that. I mean, I would think it will be easier
So
to
then the lab says, okay, when you collected it, it was contaminated.
Okay, then I'll talk to the lab before deciding.
So antenatal sample is always
That's
better.
the problem. This is the problem. You send the product, they say, okay, specimen is not good enough, and then you're lost again. Because this is G4, and we need to pull out all the stops here.
So antenatal sample is always better, sir.
Yeah, antenatal sampling is always better. Okay, so let's move on. So obviously the options now are, you said you'll send it for analysis. Now, Jaireka, what kind of testing we need to do on this?
So if we have got a CVS sample, first we would like to still rule out a common chromosomal aneuploidy because the history here looks
Parental karyotype is normal.
But still...
But why do you want common chromosomal anomalies? Then why did you do parental karyotype? It was something translocation, but you've seen the parent by now.
So even though parental karyotype is normal, we could get sporadic chromosomal errors in the fetus.
Sporadic.
So we have to...
Now I'll argue with you. It's sporadic, it can't come 3-4 times again and again, isn't it?
Gonadal mosaicism.
If it's sporadic, it cannot come again and again, isn't it? When parental karyotype is normal, if it is sporadic, it cannot come in every pregnancy, isn't it?
Yes, sir.
Thank you for agreeing to that.
But still, this pregnancy could have got a non-distinctional chromosomal error.
Okay.
So we still
So why not tell them, look here, this is going on for too long now. Why don't you go to a donor IVF program? I mean, today, every street corner has an IVF clinic. And they'll be very happy to do a donor program because they know she can conceive. So their success rate will be very high. No problem. Right? Is that a solution?
No, sir. Most of the couple would not offer for it. And even if they're going for a donor gamete program, we need to know the exact inheritance in the fetus to suggest them whether they could go for a donor gamete or a donor embryo. So we need to know the inheritance in the fetus.
So you got your pedigree here. Pedigree says absolutely normal. and there's no family history at all. So here we did the CVS, and as you asked for, a QF-PCR and a DNA store was done. And what is this MCC they are talking about?
So this is maternal contamination studies. Since we are taking the sample from the chorionic villus, for any DNA-based studies, we have to rule out that maternal cells are not mixed up so that we get a true free fetal testing.
So this MCC will come as part of all prenatal testing for you?
Yes, yes sir, sure.
Okay, right. Now QF-PCR was done and the QF-PCR was normal. Then what do we do for this patient?
Since this is a couple who are non-consanguineous, but there is a history of a recurrent nuchal edema, and the only investigation that has been done prior was a parental karyotype that has been normal. So we would like to go for a whole exome sequencing from the DNA store to rule out the single gene etiology.
No, the problem is I don't have a geneticist within 150 kilometers of my place.
Okay.
Chinmay, all the geneticists in Hyderabad have travelled out, not available for the next 3 months.
So the DNA can be stored for a very long time.
So that means you are not going to offer, you tell the couple, wait till my geneticists come back and then I'll tell you whether you can conceive or no.
Sir, geneticists
is that a good idea?
Sir, geneticists can counsel from the online also.
Okay.
It is routine now, sir.
No, all I want to know is, if there is no geneticist on the scene, what kind of testing you will ask for?
Sir, logically speaking, QF-PCR has ruled out major aneuploidies for us.
Correct.
So if we want more in terms of the chromosomes, then a microarray.
Yes.
And more in terms of genes, then a whole exome.
Thank you very much. So she wants a microarray because that's the most common test that is done. It is like a little bit more than karyotyping, isn't it? But when I asked the geneticist, she said, I want whole exome sequencing. The difference, 15,000 rupees for a microarray and 40,000 rupees for a whole exome sequencing. Please justify. Why can't we just go for microarray?
Sir, yes, you could go for a microarray because still it's more of a structural anomaly because it's been recurring in more than 3 pregnancies, and we thought we could rule out
So the more the pregnancies things happen, I will go for bigger and bigger tests, is it?
No, sir. When there is more number of recurrences, then we think it could be a single gene etiology.
Okay, right. So this patient, the DNA was sent for whole exome sequencing, and let's see what happened. What about parental testing? At the same time, do you also want to take the parent DNA and send it along?
No, sir. We would wait for the fetal DNA testing because
fine.
we need to know.
So this is the result. Please help us to understand this, because we absolutely don't understand these numbers. For you to make it bigger, it says L is a TR1 gene mutation can cause both autosomal dominant and autosomal recessive Noonan syndrome. So
This is the fetal sample, sir?
Pardon?
Yes,
This is the fetal
sample. This is the fetal sample.
Okay. So this is a whole exome sequencing that is basically a test that sequences the exons of all the genes, and it has given us an answer, a compound heterozygous mutation, that is in the gene LZTR1 there are 2 mutations, 2 different mutations are seen. So as we all the genes are present in 2 copies, so in the one gene there is a different mistake and the other gene there is a different mistake. So it's a compound heterozygous mutation. And looking at the picture, the child has got an autosomal recessive because there is a 2 different mutations in the same gene.
Okay. So now question is, if you send the same sample to 2 different labs, will you get the same result?
Should be.
Okay. Right. So you wanted to test the parents now?
Yeah. Since this can present both as autosomal.
Now that you have a clear idea that this is in fact Noonan syndrome, diagnosed made, okay? Why do you want to test the parents now?
No, sir, because it's a compound heterozygous mutation and it can present both as an autosomal dominant and recessive. You need to check the parents whether the fetus has inherited one variant from each of the parents.
So will that
will complete the analysis.
So will it complete the analysis on an academic note?
No, it will give us.
Will it help you to counsel the patient better?
No, it will help us to counsel the patient better that it is clearly an autosomal recessive disorder.
Okay, right? So why not an array? We discussed that. So it's a non-consanguineous couple. Okay? Can this kind of recurring thing happen in a non-consanguineous couple?
Yes, sir. Still non-consanguineous couple can also have autosomal recessive disorders.
Okay?
They can also.
Because constantly the patient asks, they have no family history, why is this happening to us? So, right. So, options for the couple now. Can they attempt another pregnancy?
Since they've already gone through 4 pregnancies with increased nuchal edema.
No, I don't want you. I want because they are the one, they are going to go to them only first.
No, they can.
All 3 options.
Okay, they can.
They can attempt.
But without doing anything, okay, you say, now I've got the answer for Noonan syndrome, you please go and have another pregnancy. And what if that also turns out to be Noonan syndrome?
So, sir, every time the chance of having an abnormal fetus is 25%. It is only bad luck that they had it in...
But she got 3 or 4 together. 25% is 1 in 4. The first one is affected, second, third, fourth not affected, then fourth one is affected, 5, 6 not affected.
No, sir, the
that's the way it
definition
goes,
has
isn't it?
changed. So, the odds are 25% every time they plan a pregnancy.
Okay.
So, it was just bad luck that 3 times they had some... and the third one we don't even know, sir, because that
Now,
was a miscarriage.
See, for me, it's a very simple thing. This is happening very early, extremely early in pregnancy. So, the question is, why not simply go for assisted conception by changing at least one of the gametes?
So that is a complex counseling because that will change the genetics of their family. If they are ready to accept it, that's
Honestly, touch your heart and tell me, is that what everybody is considering now? Change genetic composition of the family? Wow. I don't know.
Sir, option to be given to the couple and looking to the obstetric history, if patient is affording, will probably go for the assisted pregnancy, and if patient is not so much affording, but in the experience, even though they may go. So options to be given for the assisted pregnancy.
No,
but,
I personally feel that after 4 pregnancies, the anxiety state is over. One more time if she has this, after going through all the testing, after knowing that there is a problem, she is never going to recover from that shock. She is going to go into depression, she is going to have problems, other problems. So please give us a solution. She needs a normal baby. Geneticist.
It's a so-called directive counseling, partial.
Yeah?
Okay, so we will discuss all the options and we tell them that if they, to ensure a normal baby, the best option is to go for pre-implantation genetic testing if they want to have their own embryo.
So that's all. You tell them there is an option of PGT, right? And there's a good chance that they'll be able to do that. So let's move on because we have only 8 more minutes. And we'll go on to the next case because this case is very important. Janak, can you tell us about this baby?
Sir, this image shows oligoamnios and hydronephrosis. Urinary bladder is dilated. There is a fluid in the urinary perinoma is also there. So it is a lower luto. This is the bladder outlet obstruction, sir.
So no disputes in the diagnosis between you two?
Sir,
lower urinary tract obstruction.
Yes. Lower urinary tract obstruction.
So this is not uncommon, isn't it, to see this?
There's a keyhole sign, sir.
Keyhole sign also.
So what do you tell the parent once you see this? This baby has got a very poor prognosis, agreed? Because Leica is also very less, the poor prognosis. What are you going to tell the parents about testing? Does she require any prenatal testing, storing DNA? The whole rigmarole should we go to for this?
Sir, usually luto we don't do. This
We don't
is
do.
oligoamnios, termination of pregnancy. Usually don't we offer any prenatal testing.
Geneticist?
No, sir. Isolated, luto is majority sporadic.
So you don't want also?
So we don't want any testing.
For once
but
they
we would
agreed-
suggest.
For once they have agreed that I don't want DNA. So that's a
But
good
we would
thing.
suggest a detailed autopsy, sir, in case if they opt for termination.
Thank you very much. So final report is oligopregnant terminations. Any parental testing to be done now?
At least one karyotype.
No, no need, sir. We could do a parental renal screening at least to look
Parental
for...
renal screening, okay? Whether father had luto or what.
No, at least to look at the parents' kidneys because it's a...
Okay, right. So the question of autopsy, okay, again we come back to the same question. Even though it's a classical luto, do you require an autopsy?
Yes, sir.
It's always better, sir. because-
Always better, because it may throw up something which you don't know, right? Now the question is, when can they come for the next pregnancy? Any medications to be taken? Will folic acid help in this, or any other put
Sir,
her on?
folic acid is a regular empirical preconceptional intervention we tell them. Whether or not it prevents recurrence of this, there is a general consensus that it prevents onset of fetal anomalies. So there's no harm in doing it. Even if it's a placebo effect, it's a reassuring placebo effect.
Placebo effect, but her classmate, Flynn told her that you go for some of these Patanjali vitamins.
No, sir. And also they all often ask, how long can we wait?
Yes.
So in these kind of cases, maybe a couple of months just to recover physically and mentally from the problem.
So for all practical purposes, we are going to reassure the couple, this is a sporadic thing. Generally, we don't see luto recurring again, but because she has come into the panel, she comes back again in the next pregnancy.
Oh.
That's why she came into the panel, isn't it? So now what? Shall we start the process of investigation, whole exome sequencing, all those things?
No,
Immediately looping into genetician.
Pardon?
Immediately loop into the genetician.
Correct, immediately. So even though it is sporadic, has been declared sporadic in the first pregnancy, because it came back again, now I want an escape route, isn't it? So I tell them, okay, go and meet the geneticist, come back, then we'll see. Now once it goes to the geneticist, there's a compulsion to do something. Are you going to do anything or no? You're going to send her back saying, no, luto, don't come to me.
Sir, still isolated lutos, posterior urethral walls, they don't have any definitive genetic etiology established so far. So even, we could ask the parents we could check whether there is any consanguinity in the couple. If there is a consanguinity and recurrence, we could discuss an option of storing a DNA and suggesting an exome sequencing. But we have to very clearly do a pre-test counseling telling that we may or may not get an answer. But in view of consanguinity and recurrence, we might plan a testing, but you have to tell them very clearly. But still, isolated posterior urethral wall, we don't have any definite genetic etiology.
So somehow you went round and came back saying, I won't do anything. We'll finally take it that nothing will be done. Okay, so isolated PV has no significant genetic association, so the parent did not opt for further genetic testing. And the current pregnancy is G3, and antenatal scan, thankfully, till 30 weeks appears normal. It's highly unlikely that luto is going to come back again. So we escaped without anything here. But then, let's go to this case 5. Okay, we've got 3 more minutes now. And she's 20 weeks, and Chinmay, you want to take this 20-week scan?
Sir, we can see a dilated bowel loop, which is kind of crossing, almost lying transversely in the abdomen, and there's also an area of hyperechogenicity.
Yes.
So, probably a bowel obstruction.
So this is at 9 to 20 weeks. So naturally you would have said, come back, we'll see at present. You want to come back, will you do something now?
Sir, at this stage, because there is echogenic bowel, I'll review her screening history, and although echogenic bowel with this kind of dilatation need not be part of the an aneuploidy scenario, I will kind of counsel them that there may be bowel obstruction and prepare them for a follow-up.
Okay, so that means you don't want to send her to the geneticist at all at this point?
At this stage, no, sir.
No. Jayadeka, you lost a patient just now, okay? Because you see that echogenic bowel with shadowing here, and in my mind, what comes to my mind is cystic fibrosis. Okay? And cystic fibrosis, she only has to deal.
Not as the first differential.
Not the first differential. Why not?
After burning fingers, we'll think of cystic fibrosis.
So you want to happen it again and again, then call it a cystic fibrosis.
Sir,
so why can't I call the first time echogenic bowel as cystic fibrosis?
Sir, any second trimester echogenic bowel, usually 3 causes we think. First is the Down syndrome, means aneuploidy. Patient may or may not have gone to the first trimester screening, good or bad. Viral infection, and third is cystic fibrosis.
Okay.
There
So
are three causes.
So let's agree with you. Let's agree with you. So this dilated bowel, you want to come back for repeat scan?
Yes, sir. I'll
Okay.
call her for
So 24 weeks, got the repeat scan here. Okay? No change in your diagnosis.
No, I'm just suspecting bowel obstruction.
Bowel obstruction. Okay, so here, obviously, you can see there's a bowel obstruction.
Definitely prominent bowel loop.
Yes. So this was the delivery details. Here the 35 weeks preterm, delivered polyhydramnios. The father said that after jejunum, when the baby was born, it's operated, no loop of small bowel and large bowel are seen. Query apple peel atresia. The option is to put the baby on TPN till bowel transplant, but no surgical notes are available. Advice bowel transplant after 12 years, the baby died on day 7. Okay? Now, some diagnosis has come now. That's apple peel atresia. Should we do any investigations now?
We have a case like that, sir. So, apple peel jejunal atresia does have a known familial recurrence.
Yes.
So, at this stage, probably, again, DNA testing.
Okay. Jareka?
So, multiple intestinal, there is one gene that has been reported for multiple intestinal atresia, but it's not that very common. And this is only...
Are you happy to do testing or no? That's all I want to know.
So, but we don't,
You don't
have
want
any
to.
DNA.
Okay, don't want to.
We don't have any...
Sir, I have a question for the geneticist.
Yes.
Now, suppose right now you don't want to do, but they have had a major condition. See, losing a pregnancy as a termination is not so much of a trauma, but losing a baby on day 7 is a trauma, and we are saying there's a possibility. What is the harm that we will do if we take DNA from this baby and either store it or do a cryoanalysis at this point?
If there is a DNA, we could try, but it is not very, we don't see that much of genetic
She's not happy.
association with intestinal obstruction.
Sir,
ma'am.
at least DNA preservation.
But if there is a DNA store, we could...
Okay, so let's come to middle ground. We are ready to store DNA, but we're not ready to do any testing now. Because it's finally the geneticist who has to take the call to do the testing or no. She doesn't want to do the testing, but since they want to store, we have stored it. So let's go to the second pregnancy, because the time, we're already time's up, so we'll try to do that. So second pregnancy was normal. Everything was fine. No recurrence, and so the couple are very happy, alive and healthy, so they went for the third pregnancy, right? And this was at 18 weeks. These are 18 weeks.
So, there is some echogenicity in the bowel,
Yes.
but no dilatation as such.
No dilatation. So what do we do?
Now we are thinking. So because apple peel does not present only as echogenicity, it will have some dilated bowel loops.
So this could still be apple peel, but not presenting in the same way. Okay? So the entire small bowel appeared echogenic, so DNA store and termination of pregnancy was done.
Autopsy, sir.
Autopsy. So here's the autopsy. So the descending colon luminal atresia was narrow, segments of small intestine with luminal stenosis, intraluminal web, long segment atresia of descending colon, and the pathologist report went into 5 pages with absent bile and all that. Finally, what does it mean to the patient? Be happy with one baby, don't keep doing, or maybe the next one will be good.
Sir, now we have this fetus, and we have DNA of this fetus, we have DNA of the past fetus. So we could go for genetic analysis, because for them the more cases and phenotype they have, they can find a cause.
Sir, I had the same type of patient, and then we have done the whole exome sequence. Norm.
Correct. No answer.
No answer.
Yes. So when you do these cases where she's saying it's very rare, and you do a very expensive test, and the report comes as normal, should the patient be happy or unhappy? I've seen patients who are very unhappy when the result comes as abnormal. Then you have not found out anything till now. Whatever test you are doing, you're saying it's normal. So there's a flip side to that. But anyhow, what happened? Of course, here no testing was done. G4 current pregnancy, 28 weeks so far, everything is normal. So just want to remind you that the Asia Pacific International Symposium, November 19th and 20th, you can use this code Asia2215 PC27 to get 15% discount from ISWAG. So it's a very beautiful meeting, so you can log on from the comfort of your home. Thank you very much, panelists, for this fantastic session. Thank you very much.
Thank you very much, sir. Thank you very much, sir, Madam Indrani and Team CUSP. Thank you very much.
Okay, now we are going to we will start the quiz.
Sir, we have
Yes.
some invited presentations.
We have a few invited presentations now. I call upon Dr. Soumya, Dr. Geya Gotipati, Vidhi Hathi, Dr. Deepika and Dr. Neha to come up. The judges for this session are Professor John Hyatt, Dr. Chandan Lulla and Dr. Mayank Chowdhury. I request the judges to go on stage, please.
Okay.
Dr. Soumya. Can we start?
Good evening. So I'd like to present my study about prenatal left-sided cardiac asymmetry and its postnatal presentation. That was the primary aim, and we also wanted to understand the proportion of cases of coarctation in this cohort. It was a retrospective observational study conducted over a time period of 11 years. Abnormal size of the cardiac ventricles and their respective outlets are early indicators of abnormal fetal cardiac development and blood flow. There have been many prenatal studies that have evaluated this association and tried to find out if there's left-sided obstructive lesions. The actual narrowing of the aortic isthmus is very difficult to demonstrate on a prenatal ultrasound. So in our study, we had 89 cases as our initial cohort, and finally the cohort with the postnatal follow-up was 50 cases. And in the postnatal parameters, we saw whether it was a live birth or a neonatal demise, and whether a detailed postnatal echocardiography was done, and whether they had any surgical intervention, and what was the 2-year follow-up outcome. Going on to the results, the cases, looking at the gestational age at the initial time of diagnosis, there were 30% of the cases diagnosed at less than 22 weeks, with equally distributed cases between a time period of 23 to 27 weeks and more than 28 weeks.
Amongst the cases with the postnatal follow-up, which was 50 cases, there were 29 cases with an abnormal postnatal echocardiography findings and 17 cases had a normal postnatal echo, and there were 4 neonatal deaths, and they were all preterm in our cohort, and the mean gestational age was 32 weeks, and the cause of death was reported as prematurity or respiratory distress syndrome, and there was one case with a cardiac problem, but there was no autopsy correlation. Looking into the abnormal echocardiography, which was 29 cases, we had 10 cases of postnatally diagnosed coarctation of aorta, and among those 10 cases, there were 6 cases were associated with a persistent left SVC. So we thought there were those 10 cases of coarctation of aorta, 7 cases of left superior vena cava, and 2 interrupted aortic arches could have explained the prenatal association of a cardiac disproportion, and there were other incidental abnormal echo findings also that were found. Since this study was based on a clinical subjective evaluation, we conducted a coefficient correlation for the cardiac disproportion among 2 groups, that is the less experienced operators and the more experienced operators, and we found that both the groups were able to pick out with equal accuracy among the cases that had an abnormal echocardiographic finding. Out of our abnormal postnatal echocardiography, there were 11 cases which required a surgical intervention, and 50% of the cases required a pulmonary artery banding. We had a mortality percentage of 14.2% in the post-operative period. And the mean time of surgery which was performed was 14 days. So we compared a study with Shalan et al. Done in a fetal cardiology unit. Most of the parameters were comparable. However, our positive predictive value was 24.2%, and the mortality percentage was a little higher, maybe because of the change in the sample size. On concluding, 1 in 5 babies with asymmetry in our cohort had coarctation of aorta, and almost 2/3 of the cases with a diagnosed coarctation of aorta had a persistent left superior vena cava, which highlights the importance of serial monitoring prenatally. 20% of the coarctation of aorta still remained undetected in the prenatal period with asymmetry, which highlights the importance of our counseling of a postnatal echocardiography that would be required after 48 hours of birth. And subjective evaluation of cardiac disproportion is still significant in picking up a cardiac abnormality. However, a prospective research could be done to derive the Z scores to suspect coarctation with a better positive predictive value. Thank you.
So should all babies that have some asymmetry in their cardiac anatomy be delivered in a center that can manage a coarctation of the aorta?
Sorry, sir, I didn't get the question.
If you see asymmetry,
yes,
should that baby be delivered in a hospital that can repair the coarctation?
Yes. So our counseling was that if we detected a cardiac asymmetry, we did advise them to get admitted in a tertiary care hospital with a pediatric cardiologist so that a postnatal echo can be done and the baby could be offered a surgery if there's some abnormalities which is picked up. So that will decrease the mortality and decrease the morbidity parameters.
Thank you.
A very common cause of asymmetry, right side chamber dilatation, is fetal growth restriction at times.
Yes.
So did you account for that?
Sir, actually, in our inclusion criteria, we only had taken cases with isolated cardiac asymmetry, and we'd excluded any case with intrinsic cardiac abnormality and multisystem abnormalities. So we had studied only the isolated cardiac asymmetry cases.
And did you also measure the aorta and the pulmonary artery? Was there any associated findings in those cases?
Sir, it was a retrospective study done over a period of 11 years, starting from 2011. So we did not have a uniform measurement for all the cases. Hence, our study right now is based only on the subjective evaluation. So I did not put the measurements of cases which were performed little later from 2016 onwards, just to get a uniformity in the study. However, we do propose, I think by the next cusp, probably we would have a study where we will have a Z scores and get a better positive predictive value.
Thank you.
Thank you.
I call upon the next speaker, Dr. Geya Gotipati, for her presentation.
Good evening all. Today I would like to present my study on cerebroplacental uterine ratio, which is a novel Doppler parameter in prediction of late onset fetal growth restriction. How do I navigate this? This is not moving. I'm so sorry. So going on, late onset fetal growth restriction, FGR, is predominantly due to uteroplacental insufficiency and associated with 50% of stillbirths. The screen is also not coming.
You want the slides to go back?
No, the screen is blocked. I'm not able to see. It's blinking and it's going off. I'm so sorry. Yeah, I'm so sorry. So coming to my study. Yeah, I'll restart it again. So as I was saying before, late onset fetal growth restriction is predominantly due to uteroplacental insufficiency, and it is associated with about 50% of stillbirths, especially after 34 weeks. So it becomes very important to distinguish between SGA and FGR fetuses, because the fetuses which are actually less than 10 centile may not be at increased risk of stillbirth, but whereas cases which are labeled as AGA, that is more than 10 centile, may be actually FGR and are at increased risk of stillbirths. So there comes the role of Doppler parameters, which we routinely measure in substantiating our prediction of FGR. And we propose a novel Doppler combination, that is CPUR, which is nothing but CPR by uterine artery PI for the prediction of late onset FGR. Coming to the aims and objectives of my study, the primary aim was to evaluate the association of CPUR, a novel Doppler parameter, in the prediction of late onset fetal growth restriction, and also to compare CPUR with other existing Doppler parameters in prediction of late onset FGR, and also to study perinatal outcomes in late onset FGR. So this was a prospective study conducted on 587 low-risk nulliparous women with singleton pregnancy after 34 weeks gestation fitting into inclusion criteria. We derived fetal biometry, PIs of uterine artery and umbilical artery, MCA, and were analyzed individually and in combination, like CPR and CPUR were also derived. Estimated fetal weight was converted into centiles, and the Doppler indices were converted into multiples of median. And we derived receiver operating curves, and we analyzed the area under the curve for each Doppler parameter in prediction of weights less than 10, 5th and 3rd centiles. When plotted on a customized GROW chart, the sensitivity, positive and negative predictive values and odds ratio were also derived, keeping specificity at 90%. Additionally, the correlations between Doppler measurements and adverse neonatal outcomes like NICU admissions, Apgar, and meconium stain Likert were also made. So inclusion criteria is only nulliparous women with singleton pregnancy after 34 weeks, and we have excluded multiparous women, PIH, early onset FGR, and fetal infections. So coming to my results, the performance of CPUR for predicting FGR was better than that for than the existing Doppler parameters, with area under the curve being 0.677 and 0.734 for birth weights less than 5th and 3rd respectively. So these are the ROC curves which show the area under the curve. And also we derived odds ratio. As we can see, especially for 3rd centile, CPR MOM of less than 1.29 had odds ratio of 4, which is quite significant, and with p-value of 0.001. And also, low CPR MOM was associated with higher rates of MSL and NICU admissions in the SGA group. So these results were comparable to my other parent article published by T.M. McDonald et al. In 2019. To conclude, CPR is a novel Doppler ratio that is strongly associated with uteroplacental insufficiency and has a higher area under the curve and odds ratio for low birth weight when compared to the existing Doppler parameters. So the clinical significance of this Doppler parameter is when combined with fetal biometry, existing Doppler parameters, and when recorded in third trimester, can predict the fetuses at risk for low birth weight, and the stillbirth could be prevented from an earlier obstetric intervention, and it can be performed with minimal training even in peripheries of India. Thank you.
So this parameter help in just counseling or management also?
Both, sir. Both in detection and also in management.
How?
See, when we can only intervene when we have the suspicion. So the first we should be able to suspect which are the fetuses at risk. Since morning we have had so many talks which say the existing Doppler parameters, the biometry, all have low sensitivity in predicting SGAs and detecting FGRs. So my study was an effort to actually derive a parameter which may be even more beneficial in adding the whole value, in improving the sensitivity and positive predictive value, so that if we identify fetuses at risk, the main priority is on fetuses which are actually labeled AGA, but maybe they are at risk of stillbirth. So if we identify these fetuses with the supplementary ratio as well, maybe we can intervene and prevent a stillbirth.
So I was interested in your methods that you chose to mom the data, which most of the presentations we heard today didn't mom the data. Could you explain why you chose to do that?
So because gestational age specific MOMs, because this data is not equally distributed, so we need to derive gestational age specific MOMs. And actually, to be honest, in my study, when I spoke to the statistician, they needed a bigger sample size to derive gestational age specific MOMs. So the MOMs I derived are from the pool data rather than gestational age specific. That is a limitation of my study. So the cutoff value is derived from a ROC. I'm yet to convert these into gestational age specific MOMs, and I need a bigger sample size for that.
And so my next question is in two parts.
Sir?
What was the time interval between the scan and the delivery?
Yeah, so that is another thing. So we have taken the last scan which was performed closest to the delivery, because some babies are known FGRs and they were under regular follow-up, serial surveillance. So we actually took the Doppler parameters which are performed after 34 weeks. When we had more than 2 scans, we took the scan values which are closest to the delivery time.
So what was the time interval? Was it 4 weeks or 1
No,
week?
no, less than 2 weeks. But this is for only the patients who had serial scans.
Yes.
But those who didn't have serial scans, it is the scan which is performed after 34 weeks. So the interval varied between 4 to 6 weeks also.
So do you think the sensitivity of the test would improve if there was a shorter time interval between the tests?
Definitely, sir. Definitely.
Okay, thank you. That's great. Thank you very much.
Thank you. Thank you so much.
I call upon the next presenter, Dr. Vidhi Hati, for her presentation.
Good evening, everyone. Today I'll be presenting our data on prenatal detection of situs abnormalities in the first trimester of pregnancy. Prenatal studies on situs abnormalities are largely focused on second trimester characterization, and very scant literature is available on first trimester diagnosis of situs abnormalities. We aim to evaluate the ultrasound characteristics, natural history, and perinatal outcomes of situs abnormalities detected in the first trimester. We included all singleton pregnancies with a situs abnormality detected in the first trimester over 11 years, and ultrasound details, associated anomalies, follow-up, and outcome data were reviewed. Our cohort had 81 cases, of which 31% were situs inversus totalis and 69% were situs ambiguous cases. Postnatal outcomes or perinatal pathology were present available for 43% of the cases. 11% of our mothers were diabetic, 17% obese, but what is more interesting is that 8.6% of the patients had a positive family history of a situs abnormality, and 5% of the cases had a recurrent situs abnormality. 32% of our cohort presented with increased nuchal translucency at presentation, out of which 88% had an associated intrinsic cardiac abnormality. Amongst the situs ambiguous cases, almost all of the fetuses with an increased NT had an intrinsic cardiac abnormality. When we see our cohort of situs inversus cases, almost half of them did not have any other major malformations. Considering the multisystem abnormalities in situs inversus, 4 out of the 7 were either Meckel-Gruber syndrome or limb and renal abnormalities. Although the numbers are small, but this is an interesting data that we found. Amongst the situs ambiguous cases, 86% had an intrinsic cardiac abnormality at detection, and the majority of which were atrioventricular septal defects. 38% of our cases had a rhythm abnormality at detection. Venous abnormalities in situs inversus were few, only 2 of 25, while 60% of the situs ambiguous cases had a venous abnormality, the majority of which again were interrupted IVC. The uptake of genetic testing was low, with only 2 cases who underwent a whole exome sequencing, one of which was postnatal, and that baby actually was diagnosed with a primary ciliary dyskinesia. 72% of our situs inversus cases terminated the pregnancy, and the major causes were either an associated cardiac abnormality or a multisystem abnormality. Of those who continued, 6 of the 7 babies are doing well. Among situs ambiguous, 91% of the patients chose termination of pregnancy, and the major reason was a major structural abnormality. Interestingly, amongst those who continued, 1 we don't have a follow-up for, and 3 babies are actually doing well. Autopsy data was available for 36% of the patients who terminated the pregnancy, and at autopsy, intestinal malrotation was seen in 24% cases, asplenia in 32%, and lung malformations in 68% cases. We did a correlation of the ultrasound to autopsy for the venous abnormalities, and we found a significant mismatch that 6 out of the 9 cases had either a false positive diagnosis on ultrasound or a venous abnormality was missed. So to conclude, situs abnormalities are detectable in the first trimester with a high degree of accuracy by transabdominal ultrasound. A detailed cardiac or structural assessment by transvaginal ultrasound is mandated, considering the high incidence of associated malformations, especially in cases with an increased nuchal translucency. A detailed family history and parental evaluation is very important in cases with a first trimester situs abnormality. Venous system malformations are difficult to diagnose in the first trimester, and asplenia and malrotations are seen in over 25% of the cases. Thank you.
Thank you. That was very comprehensive.
Thank you.
I don't think any of us have any questions, so thank you very much.
Right. Thank you, sir.
I call upon the next presenter, Dr. Deepika Chandrasekharan, for her next presentation.
A very good evening to one and all present here. So my presentation for today is on the role of the new UTD classification system in prenatal prediction of severity and correlation with postnatal outcomes. So coming to the background and methods, we all know that fetal urinary tract dilation is a very common finding in antenatal scans. In fact, it accounts for about 1 to 1.5% of all pregnancies, and it's a very important cause of postnatal morbidity. Earlier, we used to have a lot of terminologies such as pelviectasis, pilectasis, hydronephrosis, etc., which caused a lot of confusion among referring clinicians. Hence, the new UTD classification system was introduced in the year 2014. It had 2 components, A, which referred to the antenatal, and P, which is the postnatal. It had 8 components in each group, which were the anteroposterior renal pelvis dilation, central and peripheral calyceal dilation, parenchymal appearance, parenchymal thickness, appearance of the ureters, bladder, and the AFI. Based on this, the patients were characterized as either A1, 2 to 3 or P1, 2, and 3 postnatally. So our study is a prospective study for a period of 1 year from Jan to December 2021. We had a total of 66 antenatally detected UTDs which were delivered and managed in our hospital. The prenatal and the postnatal ultrasound findings were noted and the UTD A and P classification system was applied. The postnatal outcomes in all cases were evaluated in terms of either resolution or persistence of the UTD pathology and the need for immediate postnatal surgical intervention. The statistical analysis was done by PAT-T test. So before we go into the results as such, a small clinical vignette. So this is an antenatal scan, a UTD A2 to 3. This patient delivered in our hospital and the 48-hour scan showed a P3, that is an anteroposterior diameter of 33 millimeter with cortical thinning. This baby had a diuretic renogram which showed an obstructive curve with reduced renal function on the left kidney. The split renal function was just 19%. So this baby had to have a pyeloplasty at 8 weeks of age. So coming to the results, among the 66 antenatally detected UTD cases, 77% were UTD A1 and 33% were UTD A2 to 3. So the first outcome which was studied was the persistence or resolution of the symptoms. Here we can see that in UTD A1, about 80% had resolved and only 20% persisted, whereas in UTD A2 to 3, only 20% resolved and 80% persisted. So this was actually statistically significant with the p-value of 0.001. The second outcome which was studied was the UTD grade and the need for surgery. Again you can see that in UTD A1, only 2%, that is 1, needed surgical intervention. That was a case of vesicoureteral reflex. And UTD A2 to 3, 33% needed surgical intervention. 1 case of uretropelvic junction obstruction, 1 megalourethra, and 3 posterior urethral valves. Again, this difference was statistically significant with the p-value of 0.001. So coming to the conclusion, this new UTD classification system is very useful in antenatal prediction and for the prognostication of severity. An adequate postnatal follow-up is the cornerstone of effective management. UTD-P as a follow-up in a similar format helps in adequate continuity in understanding the evolution. So this is a pediatric ultrasound. Even though all the components have been included, they have not incorporated it into the UTD-P classification system, which makes follow-up and research slightly difficult. Hence, I emphasize again on the universal application of this UTD classification system, not only in the antenatal scans, but also in the postnatal scans, which ensures good communication and clinical outcome. Thank you. At this junction, I would like to thank my guide and mentor, Dr. Chitra Andrew, and our pediatric urologist, Dr. Ramesh Babu, sir. Thank you, ma'am.
Excellent study, and your UTD A23 was very well correlated with surgical outcomes. I'm more interested in the UTD A1 80%. How many percent had VU reflux? Or did you evaluate them or you did not evaluate?
All of the babies were followed up, sir.
All of the babies were?
All the babies were followed up postnatally. All had scans 48 hours, 1 month, 3 months, and 6 months, up to 2 years also all the babies were followed up. Only one baby had significant VUR and that baby needed surgical management. All the others are on either they have resolved or on follow-up. They did not need surgical treatment.
So the message is that if it is UTD A1, the incidence of reflux is very low.
Yes, sir.
And this corroborated with the world literature, or do you have?
Yes, sir. Yes, sir. It's very well correlating, sir.
Okay.
So can I take that a step further? Could you change the management for that group? Would you be happy to reduce the level of surveillance that they have in the postnatal period? Or do you think they still need the same level of surveillance?
I don't think we need to reduce the size, sir, because then we might miss a significant number of cases which may be like, they may worsen postnatally. like this one case, even though it is this 2%, for that maybe it is significant because it even needed surgical management. So I think the size should be the same, and effective postnatal management is going to be the cornerstone of our the entire process.
Thank you.
Thank you, sir.
I call upon the next presenter, Dr. Neha Mohindro, for her presentation.
Good evening, everyone. I'll be presenting the data on antenatal course and perinatal outcomes of dichorionic twins discordant for nuchal translucency. Increased nuchal translucency is associated with structural malformations, chromosomal or genetic defects. Protocol for assessment of increased NT in singleton is standardized. However, in twin gestation, decision-making in one with increased NT may have the impact on the outcome of an apparently normal twin. There is a scant literature evidence on the outcomes of discordant twins with NT, and this prompted us to undergo this study. The aims was to evaluate the antenatal course and perinatal outcomes of DCDA twins discordant for nuchal translucency and to understand the patient's choice in undergoing decision-making on pregnancy care. It was a retrospective study over 10 years, and we had a total of 4,746 cases of DCDA twins, out of which 1.5% had NT of more than equal to 3 mm. Out of this subgroup, the screen went off. Okay. Out of this subgroup, 19 had NT between 3 to 3.4. The screen is going off. Okay. The end.
Start your results again.
Yes, sir.
Start your results again.
Okay.
Can you see now?
Yeah. So there were total of 4,747 cases, out of which 1.5 had NT of more than equal to 3 mm. This subgroup was divided into two, between 3 to 3.4, that was 19 in case number, and the second subgroup was more than equal to 3.5 mm, that was 1.1%. The outcomes that were studied were fetuses associated with structural anomaly, adverse outcome in the form of IUFD, miscarriage or termination of pregnancy, those who opted for fetal reduction with or without genetic testing, and single or double survivor. The results in the first subgroup was in the NT of more than equal to 3.5 mm in one twin, total number of cases of 54, out of which 72 had abnormal scan finding. Out of the total, 41 had structural malformations, mostly formed by the cardiovascular group or the skeletal group. Now coming to the abnormal scan findings subgroup, 85% opted for selective fetal reduction, while 15% opted for routine care. Out of the routine care group, we can see that 50% had at least a single survivor at birth, while 50% had an adverse pregnancy outcome. However, we see a stark difference in the selective reduction group, in which 88% had the survival of the normal twin, and most of these had a near-term or a term delivery. Coming to the NT between more than 3.5 and isolated group, 50% almost opted for selective fetal reduction, while 50% opted for follow-up. And here we see that almost 100% had single survivor, at least a single survivor at birth. We see a similar outcome in the selective fetal reduction group, that 100% had a single survivor at birth. This is the second subgroup, discordant NT between 3 to 3.4 mm. In this, the total number of cases were 19, out of which 53% had additional scan findings. Total number of structural anomalies were seen in 32%, out of which cardiovascular and the CNS system formed the major group. The outcomes in this subgroup in the isolated increased NT was 78% had double survivor at birth, 11% had miscarriage, while the other 11% opted for selective fetal reduction. In the additional scan findings group, we see 70% opted for single fetal reduction and all had survivor of the other twin. Whereas in the routine follow-up group, 10% had double survivor, 10% single survivor, and rest went for miscarriage. The analysis of the two subgroups, we see that 74% had abnormal scan findings in NT more than or equal to 3.5 mm. And here we see that almost 3/4 of the pregnancy where NT was more than or equal to 3.5 mm underwent selective fetal reduction. This could either be due to the additional scan findings or the patient's concern for uncertain outcome in this subgroup. Here we see that the adverse outcomes or at least single survivors was same in both the subgroups, and the genetic testing was opted in 13% in the first group and in the latter group by 21%. Limitations of my study was it is a retrospective study, genetic testing was not opted by many, and outcome was obtained telephonically. The conclusions are increased NT in one twin should prompt an extensive assessment of structural anatomy or referral to a tertiary care center. Uptake of genetic testing was minimal. Most of them who underwent selective fetal reduction declined for testing. About 85 to 90% had at least a single survivor in our study. Hence, pregnancies with one fetus with increased NT, around 10 to 15% may have an adverse pregnancy outcome. And from the perspective of handling twins, early fetal reduction has lesser risks and near-term delivery in the remaining twin. Thank you.
When you offer genetic testing for twins with discrepancy, do you offer it to both the fetuses or only the affected fetus?
So for a DCDA twin, we presume that most of the twins are dizygotic, but still 10% can be monozygotic. We offer the patients testing, but for the structural anomaly, we have to see what type of structural anomaly. We can offer it to the remaining twin if they are opting for selective fetal reduction, or if they are willing to continue the pregnancy, we can do it for both twins.
No, but in your series, did you offer it for both, and did you do for both or only for the affected fetus?
So actually, those who opted for selective fetal reduction, it was given to the remaining twin. The other twin, whether it was normal or not, and selective fetal reduction was done for the abnormal twin. However, if they chose to continue the pregnancy, we can do it for both the twins.
But this is an interesting dilemma, isn't it? Yeah. Because there's a small chance, although they're dichorionic, that they're monozygotic.
Yes, sir.
So, and there's a small chance that they could have a chromosomal abnormality, but different phenotypic expression.
Yes, sir.
So, I might make the argument that if they're going to have a selective reduction, they should at least have that twin karyotyped, because if the karyotype is abnormal, then you might want to reflect on that with the apparently normal twin. Yes. So I just wonder whether giving people the option of having karyotype in that circumstance, perhaps it's not an option. Perhaps
so
it's part of the deal. Yeah.
We'll definitely give them an option of testing both the twins.
Yeah, but perhaps what I'm saying is perhaps if you want to have a selective reduction, we are going to karyotype at least one twin. So.
Yes, sir, definitely we'll karyotype. We'll give them the option of testing both the twins, and definitely the normal twin has to be tested.
Yeah. All right, I think we...
I missed, maybe I missed, but in the outcome data, did the normal twin, any of them turned out to be abnormal on later testing or later follow-up? Because we've had situations where we have terminated the one, done a selective reduction in the abnormal twin, and subsequently at 25, 30 weeks, we find another abnormality in the normal twin.
So in our study, none of them had an abnormal structural finding. Yes, sir.
Okay. Thank you.
Thank you, sir.
Thank you very much, presenters and judges. We come to the end of this session for invited presentations today. We have a set of 3 presentations tomorrow morning. Thank you. Now we'll move on to the much awaited the Grand Sono quiz.
Sabarish Prabhakar, the violin sensation, the man man who simply creates magic from the springs.
Okay, before we move into the quiz, there was a window stall quiz was there, and we just got the winners, Dr. Gayatri, Dr. Sasikala from Chennai, and Dr. Sudha Rani from Vizag. Sudha Rani, please go and collect your, because it is a very beautiful OnePlus 10 phone, very expensive phone. Okay, and please collect them. So where are my scorers, please? Here. My scorers to come here. So how many of you remember any of the questions from the last cusp, 2016? Anybody remember anything at all? I want to know whether they remember from 2016. Because 18 is too short. Okay. Right. Lata, are you going to do the scoring? Okay.
Shall I call out the names?
Please call out the names of the teams.
Yeah. Team Champaran, Dr. Tejas Tamane, Dr. Deepika,
Yeah.
Dr. Anjali Malhotra. Can you please come on the stage and sit? Take your place. Dandi Group, Dr. Tazeen Khan, Dr. Jayalakshmi, Dr. Guna Preeta. Jansi Group, Dr. Swati Kumari, Dr. Geya, Dr. Rajesh Shanklesh. From Panjalan Kurichi Group, Dr. Radhika, Dr. Bhavya Sarin.
Okay. Oh, okay. We are short of one. Any volunteers? Yes, please come. Come. One. But you must promise me that you are less than 3 years in ultrasound. How many years experience? 6, 3 years. 4, 4 months. Excellent. We want you here. Absolutely fantastic. That's what. And please tell your name and where are you from?
Sir, I am Dr. Mayuri Sanjay Dikshit. I am from Pune.
From Pune. Well, good that within 4 months of coming into ultrasound, you have decided to attend CUSP. For that, you should be given an award. Okay, thank you. Okay, so the teams are all set, and I'll take you through some of the rules, and I also explain about the teams. There are 4 teams with 3 participants each. We may not do 6 rounds, we may bring it down a bit. The time is 30 seconds for each answer. There will be a timer. Hello? Who's timing? Pardon?
Timer on, please.
No. There should be a timer for 30 seconds timer. You can use your mobile phone to time, not a problem. Jayanti, you are coming for timing? You got it. So the moment the time goes, you please make sure the timer rings there. Huh? Yeah, you do that. And when you don't answer a question, we will pass on that to the next team, and that team will be given only 10 seconds for that answer. Okay, you also can't take 30 seconds because you already took 30 seconds from here, another 10, which means you are getting 40, which is good. So the question passes to the next team in order. So the round will start from here, 1, 2, 3, 4, and the next round will start from 4, 3, 2, 1. That's how the round will start, okay? So when you give 10 points for the complete correct answer, 5 points if you don't answer, you pass on, and the next team answers that question, they'll get 5 points. Okay, we won't give negative scores. Okay, we won't give negative scores. And then, so no negative points. My decision is absolutely final. Even if I say something wrong, you have to accept. It's like the third umpire in cricket. After that, nobody can question. Now, sometimes we pass on the question to the audience also. So, audience can shout. Okay? And if and only if the teams do not answer. Now, while the question is on, there is a very big learned audience here. You are very excited to tell the answer, but hold your hand like this so that accidentally you don't shout the answer. So, let's come to the next part. This time we have got names because we thought 75th year of India's independence, we should name the teams which is befitting that. So, Champaran, Dandi, Jhansi and Panchalankuruchi. So, let's see why we did this. So, the Champaran team who's here, the first Satyagraha in India took place in 1917 by Mahatma Gandhi in Champaran. So, you are very privileged to have that name. So, make sure you win. Okay. The Dandi, of course, everybody knows the Salt March. 12th March to 6th April 1930 at Navsari, Gujarat. So, Champaran was on the eastern side of India, north and eastern side of India. Dandi is on the western side of India. Then we come to Jhansi, and everybody knows Jhansi Rani. Okay, how she fought, a warrior. So Jhansi team, you are warriors, so make sure you get it. And of course, we chose this name called Panchalankuruchi. It's a little difficult to pronounce for people who don't know Tamil, but this is a place in Tuticorin in Tamil Nadu, where well before all these places happened and Mahatma Gandhi came here, there was a warrior called Veerapandya Kattabomman. This warrior, he was not only a warrior, he was a king. And he was a fantastic king. His subjects just loved him like anything. They had a beautiful land of his own, and he was a sort of a ruler which everybody liked. There was a guy, there was a British general called Jackson. Now this Jackson, as they were, the East India Company of course came to Chennai, and from there slowly they went into Tamil Nadu, different places. One of the places is they came close to this one. They found this very fertile land. This person is doing a lot of wealth there. So let me go and ensure I get some of it. So there was a person in this king's court who betrayed him to the British. Or the British called him and said, I will do so much thing for you. They bribed him like anything. You make sure that you go and tell your king that whatever he earns, he must pay a tax to the British. So when this man went and spoke to his own king, saying, so that Jackson is a very nice man, and they are willing to help us a lot, so why not we give part of it as tax to them? He got so furious. He said, you betrayed us, and he said, we will not even give an inch of land. There's a very famous dialogue which he does at the time. I don't want to repeat that now. But end of the day, the British brought cannons, and they came and they finally captured him and they hanged him. And this man is, Veerapandiya Kattabomman is very, very well respected and famous here. So in a way, that one of the earliest fights against the British, 1790. So you are the senior most people here, I think. So good. So every person got a unique experience. So now what are we going to do? We've got a few rounds here, okay? We've got what's called a cranial round, where everything is about the head, okay? Then we have a picture for diagnosis, where we'll give you a picture, you need to give the diagnosis. Then there is a cardiac round, and there is a buzzer round. In the buzzer round, unfortunately, they have not given you buzzers. They are supposed to keep one buzzer there. What you can do, you can bang on the table. Okay? If you know the answer, bam, right? Make sure the mic is there so that you understand who it is. And then we'll decide who gets to answer. And then we have a poetic round, where I'll give a small poem. From that poem, we find out what the answer is. Okay? So we have one round for the audience also, but that will be at the end. Okay? So let's go to the cranial round first. Shall we start with the Champaran team here? Okay? Timer ready? Okay? Scorer ready. So this is the cranial round, and I've given you 9 choices. You choose what you want. Any one you can choose.
Number 5.
Number 5. Okay. So what is the diagnosis and what is the differential diagnosis? So just to
Cyst in the caudothalamic groove.
Pardon?
Cyst in the caudothalamic groove.
Cyst in the caudothalamic groove. Okay. Can you qualify that? Because you've got 2 images there. Is it 1 or 2? So what kind of cyst is this? You need to be...
Periventricular cyst.
Pardon?
Periventricular cyst.
Periventricular cyst. Can you be a little bit more specific? What is the differential diagnosis you can give?
Could be infectious.
I'm not asking for etiology. Just I want the answer of what kind of cyst it is. Because a cyst is something which everybody can say. Okay? You need to qualify it what type of cyst it is. I don't think this timer is working. Because we've been having dialogues here. Pardon?
That the buzzer went off.
I didn't hear.
I think you have to come.
The buzzer is for me, not for you. So somebody can do, I don't know what happened to the buzzers. Yes, that looks better. Okay. So we'll pass on this to that Dundee team.
So,
10 seconds.
hello? Sir, appears like periventricular cystic.
Loud.
Conatal cyst. Conatal cyst.
Conatal cyst. Okay.
Periventricular.
We'll go to the next team.
Possible differential conatal cyst resolving GMH or pseudocyst of ventricles.
Okay. Next team.
Sir, periventricular synechiae with periventricular synechiae with dysgenetic corpus callosum maybe, or sequelae of CMV infection.
Sequelae of CMA infection. So anyway, I just wanted to give a chance to, because of the first round I went round. Let's see what the answer is and who gets the mark. Okay? Because we needed two answers. One is what is the diagnosis, second is what is the differential diagnosis. So the answer conatal cyst is right. Dundee team is the one which first answered it. Please give her a big hand. Now, periventricular cyst is what you said in the beginning, but we needed the primary diagnosis before we could do that. So Dundee team will get 5 points now.
Yeah.
Okay? So let's go to the next one. So now you can't choose 5, of course. You can choose something else.
6.
6. So what is the anatomical location of the cyst and what differential diagnosis has been excluded?
Cavum villi interposital cyst, sir.
Cavum villi interposital cyst. Can you tell me why you said that? Okay, you guys go to the next one. What differential diagnosis has been excluded?
Cavum villi interposital cyst only. The location favors that. Differential
Can be perineal gland cyst.
They automatically took over from you. I didn't tell them to. I didn't pass on the question, isn't it? Okay, doesn't matter. Simply you can answer. All of you can answer because this is a learning process. All of you can answer. Yes, next thing. So they said cavum villi she said cavum villi interposital cyst. You also said the same thing? And you?
Anatomical location is ESP only, and it is not in the cavum vergi. It has been ruled out by the...
Okay. Cavum vergi has been ruled out. So let's get to the answer. So this is cavum villi interposital cyst located anterior-inferior to the splenium or the corpus callosum and superior and posterior to the thalami. This is the answer I was expecting. So when you say what is the location, you need to be very specific in the location. And what you have ruled out there in the posterior is a vein of Gallard malformation. You switch on color, it's a vein of Gallard malformation. So we'll give you 5 because you said cavum villi interposital. So Dundee team gets 5 more marks. Now the question goes to the Jhansi team. You can choose one.
7.
7. So it's like 5, 6, 7. They seem to be going in some order. So what is the location of this lesion and what drains into this? I'm going to become a little stricter now. I need very specific diagnosis.
Location is in the posterior fossa of the brain.
Okay? Because that goes along with the diagnosis. It's not only posterior fossa.
Posterior fossa hemorrhage.
Posterior fossa hemorrhage. Next team.
Sir, the location is the superior sagittal sinus, the posterior fossa and the superior sagittal sinus drains into it.
Wait. What was the answer?
Superior sagittal sinus drains into it.
Okay.
The location is posterior fossa.
But what is the diagnosis? Now we have to come here. Champara.
Posterior fossa cyst, and the region is drainage of superior sagittal sinus, straight sinus,
Pardon?
The torcular region will drain into this. And the posterior fossa lesion. Yeah.
Posterior fossa lesion.
Yes.
Yeah, everybody said posterior fossa. But I want a specific diagnosis. Okay, can we push it to the audience? Yes?
Dandy is there. Torcular vein rings.
Torcular? Yes? Dural venous sinus malformation. So let's see the answer. The answer is dural venous sinus malformation, and the cerebral veins actually drain into it. There are only about 60 to 70 cases reported in the world, and this actually, when you switch on the color Doppler, you will see color only in the periphery, not in the center, and it can get into a thrombosis situation. So it can be a dural venous sinus thrombosis also ultimately. Initially it's a malformation, and then it goes into thrombosis. Yes, give it to them please. You have it with you?
Raghav.
Raghav, please collect your chocolate.
Sir, no score. Nobody gets a
no
score.
score.
Yeah.
So, last one. Which one do you want?
1.
1. So she goes to 1 now, I think. Are you aware that I started from the toughest to the easiest? 5, 6, 7, 8, 9, if you go, it's the easiest. 1 is the toughest anyway. Let's do that. Okay. Now here, I want you to tell me the anatomical, what is the diagnosis and what are the anatomical relationships. Because I think I've given you 2 beautiful images, one axial and one sagittal. So you must be very, very specific about the anatomical relationship.
So can we tell the anatomical relationships before?
You tell it first,
So
no
the
problem.
superior
Choices.
is the tectal plate, the posterior is the vermis, the inferior is the, so the lateral one is the hippocampal gyrus, the inferior one, I don't know, in the diagnosis. Porencephalic cyst.
Porencephalic cyst. So, Champaran team.
Arachnoid cyst.
Arachnoid cyst. And what are the anatomical relationships?
Superiorly,
No, tell.
superiorly the splenium of the corpus callosum, inferiorly the superior border of the vermis, and the anteriorly the posterior border of thalamus.
Can I push it on to the identity? You want to guess on the diagnosis?
Arachnoid cyst, sir.
Arachnoid cyst. Yeah. See, generally, the cysts in the brain, most of them are called arachnoid cysts. So it's a general term. It's like saying he's a man. Yes. Jansi?
Same, sir. Arachnoid cyst.
Pardon?
Sir, same, sir. It's arachnoid cyst only.
Same, sir. Everybody wants the arachnoid cyst. Okay. Let's go for the answer. Okay. So this is called as the ambient cistern cyst. Okay. Cyst of the ambient cistern. It's an expansion of the subarachnoid space located in between the posterior end of the corpus callosum, thalamus, and superior surface of the cerebellum. Okay. So this is an ambient cistern. So let's go back to the. So now this round is over.
I think no score again.
No score again. Let's go on to. This round is over. We go back to. Let's go to a picture for diagnosis. Okay, a picture for diagnosis, and let's see what we have in store for us. So we have to start from that side, isn't it? One round is over. You start from the Panchalam Ruchi team. This is a picture for you.
I think Jansi has.
Huh? Jansi has to start now? So only one round is over. So she has to start there, correct?
It's a coronal section of a fetal abdomen showing dilated bowel loops and the bladder.
Anything peculiar? Anything peculiar you are noting there?
Differential diagnosis, maybe renal.
Okay. Jhansi team?
Dilated tortuous ureter with bladder.
Excellent. Okay. So you got from bowel we have gone to ureters now. Dandy?
So bowel dilated loops only.
Loud, please.
So dilated bowel loops only.
Dilated bowel loops. Because dilated bowel loops is very obvious.
Oligohydramnios is also there, sir.
So, is oligohydramnios a final diagnosis or?
No, the main diagnosis is bowel, related to bowel only.
So, when the bowel is obstructed, should you not get polyhydramnios? Why should you get oligohydramnios when the bowel is obstructed? Anybody in the audience? It's a tough one. I agree, it's a tough one. But you need to think of that possibility before you can come there. Anybody in the audience? Pardon? Loud. Bowel loops are adherent. Okay. Okay, let me get you the answer. So, this is the case of intestinal malrotation. All the bowel loops are pushed to one side, and that's what happens in intestinal malrotation. And of course, there is a little bit of dilatation, but because all the small bowel is pushed to one side, it's a tough one, I agree. That, oops, what happened? Okay, let's go on to the next one.
Sir, half marks. Sir, score?
For bowel, half mark. Okay.
I think Panjal and
5.
Kuruchis, they said bowel loops.
5.
And while we put it on reporting, maybe we can't narrow down our diagnosis to intestinal malnutrition or...
So I set an initial rule in the beginning, no? Okay, that doesn't matter. Okay, so for bowel loops, I know everybody will answer bowel loops. We don't mind giving 5 marks for you.
Sir, Jhansi
very
said...
liberal, very liberal person I am.
So, but Jhansi said dilated ureter.
Yeah, but it is bowel loops only.
No. Everybody gets 5 points, is it?
No, for them. They only started first, no. They get the privilege. Okay, next one. Next one will be good. I'm sure you'll find out very well. Jhansi team, this is for you. Beautiful picture. Excellent diagnosis can be made out of it. And this is a recognized finding in this diagnosis. So it's not as complicated as the first one.
It's dilated stomach.
Yes.
Duodenal atresia.
Okay. So there's something here also, no? So you think it's duodenal atresia? Okay? Can I pass it to the Dundee team, please?
Sir, same dilated stomach.
No, dilated stomach, no problem. I want a diagnosis.
Sir,
Wait.
Pass it on, sir.
So GB is in the midline. So possible isomerism part. Heterotaxy.
GB is in the midline, so it could be heterotaxy.
Yes.
Okay. But what about the stomach?
So the space between the stomach and the bladder is reduced. Can be a diaphragmatic hernia in which the bowel has moved up.
Can be a diaphragmatic hernia. How did you think of it?
Yes, sir.
Why did you think of diaphragmatic hernia?
So because the bowel has moved up into the chest, so the space between the stomach and the bladder is reduced and they get approximately...
Please give her a big hand. Please give her a big hand. This is the classical case of diaphragmatic hernia where the bowel has gone, the small bowel has gone inside and the stomach comes down. When there is a low placed stomach, you can see the bladder there, low placed stomach, and here also the gallbladder has come down. This is the gallbladder you are seeing. It's a case of diaphragmatic hernia. So 5 points for the Champaran team, please. Okay, now this is the Dundee team.
Chaos.
Don't be in a hurry. You got 30 seconds.
Congenital higher airway obstruction, sir.
Congenital high airway obstruction. Okay. Now let me move to the...
Same, sir, with ascites and...
Yeah, I'm sure everybody will answer that. What about Panchalanguchi team?
Skeletal dysplasia.
Skeletal dysplasia, okay. Jhansi?
Chaos.
Chaos. Audience? Chaos. Once you see one lungs bloated up like that, you have to see chaos. But in chaos, what else have you to see? You have to see.
Kidneys.
No, in the lung only. So where is the obstruction? When you say chaos, congenital high airway obstruction. So what are the features of chaos?
Dilated trachea and bronchi.
So can you show me dilated trachea here?
Bronchi is
Can
dilated.
you show me dilated trachea here?
Trachea is not.
I'm able to see this bronchi.
Bronchi.
Anything here?
So, tracheal atresia.
So what is it?
Tracheal atresia.
Tracheal atresia. That's a good diagnosis to give, isn't it? Okay. So here you can see chaos on this side. You can see the trachea there. And here is tracheal atresia. And you can see the autopsy picture also showing you the tracheal atresia. Okay? Beautiful case, isn't it? Right. Okay, now let's go to the...
So anybody gets point?
I get the point.
Okay.
I'll claim my chocolate later. So now 1, 2, 3, 4. It's your turn now. Nice image. Take your time. 29th second you can answer.
Hypoplastic left heart.
Hypoplastic left heart. Okay, let's move to Panchalanguchi team.
Hypoplastic left heart.
Okay.
With cardiomegaly.
Cardiomegaly. Okay. Next.
Right to left shunt through the foramen ovale.
Right to left shunt through the foramen ovale. Okay. Dundee team. You want to take it?
Can this be tricuspid dysplasia?
Tricuspid?
Dysplasia.
Tricuspid dysplasia. Okay.
Moderator band is seen in the left ventricle.
Moderator band is seen in the left ventricle. So what do you think? Why should moderator band seen in the left ventricle? In which case?
CTG.
CTG. Okay. Audience? Yeah. Pardon? TAPVC, supracardiac. Okay. That means the image is really tough, I think. I thought it was an easy image to say. You can see the right atrium when you see. Are you able to see those little things there? You don't see that, no, normally. Those are the pectinate muscles in the right atrium. And usually this is seen in the appendage. And here you can actually see it very, very prominently. These are we have marked this right atrium only for that purpose. We wanted your eye to go there to see whether there's something there. Okay.
Sir, but isn't it there a cardiomegaly and the disproportion?
No. See, actually, there is a dilated right atrium. I agree that's a dilated right atrium. But we wanted here to see this is something which is unusual, which you see there. So the whole idea is when you look at the heart, the obvious is the obvious. That nobody will dispute. But what is something beyond that is what you need to see. You have to train your eyes to see in the image anything that is very unusual and you don't see. Right? Right. Now let's go back now. So, we have gone one round, we've gone the second round. Then let's go to the cardiac round. Cardiac, okay? Everybody okay with heart? Recently, did you attend the Cardiocon in Delhi? If you had done that, you would have answered all the questions. That's why you should go for conferences. Okay. Okay. Now, Champaran, you have to start from you only. Yes.
There is a reversal of flow from the left to right.
From where to where?
Left atrium to the right atrium.
Okay. Can you give a reason for it?
Increased pre-diastolic.
Increase. When you have increased flow on that side, it will get reversed.
Yes.
Okay.
Or could be this. PLS is veins we can see.
Dundee team.
Sir, shunting from the left atrium to the right atrium and tricuspid regurgitation.
Okay.
Differential could be dilated coronary sinus, that's not.
A little bit louder, please.
Yes.
Differential could be ASD or
ASD. What type? Primum, secundum? Is secundum seen in utero? Okay, now Dundee, Jhansi team.
Looks like septum primum ASD, but also the left side of the heart is hypoplastic.
Okay.
Left ventricle.
Mm-hmm.
Another thing could be because of the raised right atrial pressures, because of the compromised left ventricle. It's a physiological transfer through the patent foramen oval. Maybe, sir, the second differential being.
Okay, we have put in a lot of thought into this. Yes. Panchalanguchi team.
So hypoplastic left heart with aorta arising from the double outlet right ventricle.
Well, this is a lateral four-chamber view, and we are only showing you four-chamber. How did you come to the conclusion of the outlet? So I am only interested here, nothing else. Okay, audience? Foramen reversal of flow. So that's what our first team also answered. So foramen reversal of flow, agreed. I agree. Dysplastic mitral valve, is it? Okay. So there's a specific name for this. HLHS. I told you I am interested in the atria. I am not interested in the ventricle.
Aneurysmal dilatation of.
Pardon?
Aneurysmal dilatation.
Aneurysmal dilatation. No, we'll go to the answer. Okay, we'll go to the answer. The answer is called restrictive foramen ovale. Okay, this is called specifically called as restrictive foramen ovale, and you did identify the reversal of flow from the right to the left. So maybe we'll give them 5 marks for that, for answering that. Okay. For the Champaran team.
Sir,
Yes.
who gets it?
Champaran. Yes. So now we go to the second one, Dundee team. So here's another video for you. This should be relatively easier, I think, no? I want you to look at the whole picture, okay? And I'm willing to play this video a couple of times more. Maybe I'm pushing you all too hard. Okay, I want you to look at this area. Okay, let me play that for you, just to give you a clue. Just watch. Watch this and watch this. We'll go back and give you a still picture. Got it? Yes.
Pulmonary atresia with
Pardon?
Pulmonary atresia with intact ventricular.
Pulmonary atresia.
With intact ventricular septum.
So this is those structures are coronary collaterals. And
Yes.
This is hypoplastic right heart
So,
with
so
coronary collaterals.
coronary collateral. Okay. Let me. Who's the next one? You? Any guesses?
Tricuspid atresia.
Tricuspid atresia.
Tricuspid atresia with MAPCAs and the.
Okay. Nandi team already started that. Okay, right. So let me get you the answer. It's called ventriculocoronary fistula. Okay. So you got the coronary collateral, right? So we'll give that mark to you. Jhansi team gets the mark because it was a good thought to call it at least as a coronary. I think that was a good thought because you can see the path that it took and came from the wall into the ventricle. Okay. Okay, next for you alone, Jhansi team again. Again, look at this carefully. Yes. Now we'll go to the other view, sagittal view. There.
Parallel outflows.
I want you to specifically narrow down your thought here. Okay? I'm giving you a clue on that. Just find
AP
out
window, aortopulmonary window.
AP window. Okay, let's move to the next team, Dundee team.
Circumflex aortic arch.
Circumflex.
Top.
Oh, yeah, go ahead.
Tortuous ductus arteriosus.
Tortuous ductus arteriosus, okay. Yes, Champaran team.
So double aortic arch.
Double?
Aortic arch.
Double aortic arch, okay. Audience? What? MAPCA? So why do you think it's like that? Yes, arising from the aorta. So let's see the answer now. So this is MAPCA. Perfect. Please. What's your name? Pardon? Nivedita. Okay. Very experienced person, I think. That's right. Okay. Now let's go to the next one. Whose turn is it now? Your turn? Okay. Okay, here's the one for you. This is a fairly straightforward, I think, now.
Interrupted
Yes?
IVC.
Interrupted IVC. Okay. So watch here. Okay? There. Watch that thing.
TAPVC.
TAPVC. Okay. Next. Option. Pass.
This is.
Oh, once more. Okay, I'll give you, no problem.
This is PAPVC, scimitar sign.
TAPVC, scimitar vein. Who said TAPVC first? Did you say scimitar? You didn't say that.
Infracardiac VSAT, sir.
Pardon?
Infracardiac VSAT.
Intracardiac.
Infra.
Did you say intracardiac?
Infracardiac.
Infracardiac. Infracardiac. So the answer is scimitar. He gave the correct name. You came close to it. So what do you want? You want some points or? He has a rightful claim to it.
We started it.
Okay, but since you gave the, we'll give 2.5 and 2.5 to them. Only 5 allowed because it was a past question.
2.5.
2.5. Be happy about it, okay? Still it will add up to your core score, but right. Now finally, let's go to the buzzer round. Keep your mics so that it faces you. Okay, somebody has to watch. Ma'am, scorer ma'am. You please watch who's hitting, banging on the quickly. Okay, let's go to the buzzer round. Ready? Keep count now.
Oh my God!
I'm sorry. I haven't even played. You need to allow me to play the video, isn't it? That's I know your excitement. By now you'd have realized I've been very cruel and things are not as straightforward as they seem to be, isn't it? So let me play the video. Okay. Wait. Because let the video play fully. Jhansi team will give them the opportunity. Yes, now you can, because we'll give you the chance to answer the question. You only tapped first. Never count your chickens before they are hatched. Hey, mic is not working, please help.
Press and hold.
Okay, give this mic to them, let them answer. I'm waiting with bated breath to know what they are going to answer. Yes.
Looks like a double bubble sign, sir, duodenal atresia. But as you played the video, we could see a dilated structure.
Yeah, tell.
Dilated structure looked like, I would like to see the video again, but it looked like draining into the bladder. We stick with duodenal atresia.
Duodenal atresia. Okay. So now we will push into Panchalankurchi team to give them a chance to answer. They said duodenal atresia. Okay. This will be the last time I'll play the video again. I've been very kind. Jejunal atresia. Okay, now Champaran.
Cloacal abnormality with the other findings.
Cloacal abnormality. Dundee team.
So, anorectal malformation leading to bowel dilation.
Anorectal malformation. Okay. Audience? Duplication cyst. Okay. Now let's go through the video. Something interesting there. This is where we need the observation. Okay, I'm going to stop here. Okay, here is a double. Everybody agrees on the double bubble. Right? No dispute on that. Everybody agrees on that. So double bubble means the only thing that comes to our mind is duodenal atresia. Okay, automatic choice. And then you go here. So when there is a duodenal atresia, can you tell me what happens to the small bowel? Can it get filled up? Can the small bowel get filled up in a duodenal atresia? Cannot. Small and large bowel is usually not seen. So as you go here, you can see dilated loops of small bowel are there. Okay? And then if you go there, even a little bit of large bowel is seen there. So, in which situation where definitely there is something blocking the duodenum? Yes?
Hirschsprung?
Hirschsprung? No. Okay. So I'll give you this situation. I'll give you the answer now.
Annular pancreas?
Annular pancreas.
Annular pancreas is a good choice. Definitely a good choice. Because any extrinsic obstruction on the duodenum will not be a complete obstruction like an atresia. One is annular pancreas, the other is a band, a duodenal web. A duodenal web can be, this turned out to be a duodenal web. So the trick is to watch, put two and two together. Okay, that's what it is. So from this, what you have learnt a lesson, the subsequent videos, please wait, okay? Put 2 and 2 together and then come to the conclusion. Don't bang on the table because the table is very precious. Okay, so this is a still picture only for you, no video. So now you can bang if you want. I have no problem. Who did that? No, you if you have hit the post, you get it, no problem. I have no problem. I told you, no, Jhansi is always warrior, so they're already on the horse.
From the image, it is absent CSP,
Okay.
but probably the plane was not taken. Correct?
Yeah, probably plane is not taken. For absent CSP, why would I put a wrong image and ask to tell you that? I mean, have
Absent CSP.
have some consideration for me.
Sir, the near-sided posterior horn of lateral ventricle is visible, so maybe hypomineralization.
Please give him a big hand. You can see a completely visible near field. There are no artifacts there, usually visible, and that happens in hypomineralization. This was the case of osteogenesis imperfecta. Okay? OI. Beautiful. That's where you need to think.
Do they get 5 or 10?
Madam, for previous question, I answered annual pancreas, so 5 marks for 5 points for that and 10 for this.
Now he's having a private conversation with the scorer, leaving me out of the picture.
Quiz master's decision is final.
Okay. No. I think we'll put the to vote. It's a beautiful diagnosis he has given. Okay. So should we give him 5 or 10? 10. Audience has voted for it. I can't do anything.
Okay, 10.
Because everywhere audience is supreme. Okay. Now, whose choice is it? Champaran team, no? Oh, now it's buzzer. Anybody wants to hit? Body. Finally, I got an image where nobody's eating now, taking time to do that. It's a very unusual case. So I agree that. Yes. Allowed.
Transverse facial cleft.
Transverse facial cleft. Because I have written cleft there. Okay. So what is meant by
Sir, lips are also not seen.
Pardon?
Lips are also not seen for the fetus.
Louder.
Sir, lips of the fetus are also not visible and transverse facial cleft is seen.
Okay, transverse facial cleft. Audience? Any of you want to take?
Amniotic band.
Amniotic band, okay. I'm trying to get as many differential diagnoses as possible now. Okay, let's move and get the answer. So what is it?
Otto.
Yes. What is the answer?
Oro-digital facial syndrome.
Pardon?
Oro-digital facial syndrome.
Oro-digital facial syndrome. Just describe, no? Extension of the mouth?
Yes.
So can we call this as transverse facial cleft?
Yes, sir.
Can we give it that name?
Yes, sir.
Okay, then take 10 marks for you. Okay. Right. The fourth one. This picture came from Dr. Vaishaki from Surat. She gave us a beautiful picture. We have to give only one name for this. We'll give it to Dundee team.
Lower lip hemangioma.
Okay. Now you.
Teratoma. Teratomas.
Teratoma. There's a specific name for this, no? Yes?
Beckwith-Wiedemann. Beckwith-Wiedemann.
Beckwith-Wiedemann syndrome. Okay, that is macroglossia. Yes, Jhansi team, one chance to get 5 marks. Can we, you want a clue?
Yes, sir.
Think of the fifth letter of the alphabet, which will be the first word. Audience?
Epignathus.
Epignathus. Okay. Yes, audience, I heard. Epulis. Please give her a chocolate. So this is the very typical, it's called as the epulis. And of course we have a histological diagnosis for that also. It's a granular cell tumor. Okay. So our buzzer round is over. And finally, we come to the last one, which is a poem. Okay. So it's just a 4-line poem. You have to think what it is and give an answer. Now where do we start? I think we start from that side now, right? Okay. Some of you who might have seen this poem, please don't shout. So, honored am I by your visit, my little home full of surprises. Little things go a long way to bring a smile and make my mom's day. Honored am I by your visit, my little home full of surprises. Little things go a long way to bring a smile and make my mom's day. There are certain words there which automatically gives you the clue. Pardon? Yes, take.
Trisomy 21.
Trisomy 21. Does it bring a smile on the mom?
So early pregnancy scan.
Pardon? Yes?
Sir, early pregnancy scan.
Early pregnancy planning.
Early pregnancy scan.
Early pregnancy scanning.
Yes, sir.
How early?
Sir, like 7 weeks.
Who said that?
5-6 weeks.
Who's answering? Oh, you're answering. So sorry. Okay. You are very close. You are very
Fetal
close.
pole.
Uterus.
Uterus. No. Yeah. I think, yes.
GSAC. GSAC.
GSAC.
So can I describe?
You're going down. The next, already uterus has come. So.
Cardiac activity.
Cardiac activity. Okay.
Sperm traveling through the uterus to the tubes and to the.
Okay. Before the imagination runs wild, let me give the answer. I think we will give the marks to them because it is in a way early pregnancy, but it's actually the 11 to 14 week scan. Okay.
So was it a passed round or it was?
No, this is a regular. They're getting a marks. Please. So this is the honored am I by your visit. So that means somebody is visiting me, which means somebody is coming and scanning me. Okay. Little things go a long way. An NT is nice, nasal bone is present, heartbeat is there, and then all this brings a smile on my mom, isn't it? But if you say at 5 weeks and 6 weeks when heartbeat is there, it doesn't bring that much of a smile, but you actually show this baby and say smile is much better. Okay, right. Let's go to the next one, which is belongs to the Dundee team now, I think. People see me and people don't. People should and people must. Early sight saves trouble and time. Let's all sing this rhyme. People see me and people don't. People should and people must. Early sight saves trouble and time. Let's all sing this rhyme. No, I think it belongs to them now first. It'll come. Keep it. It might come to you. Keep it.
Dundee, right?
Yes.
Cardiac activity.
Cardiac activity, okay.
The nasal bone.
Nasal bone. Okay. She's got some nice, beautiful thought on the side. Yes.
Is it harder?
Yes.
Uterine artery.
Uterine artery, PI. So let's try to fit all this. So some people do uterine artery, some people don't uterine. That's what you meant, isn't it? People should and people must. Is it compulsory to do uterine artery all the time? Is it a rule of law? Early sight saves trouble and time. Let's all sing this rhyme. Anybody? Somebody said something there. CSP. Okay. Who said chorionicity? Please tell your name and claim your chocolate. Okay. So, people see me and people don't. Correct? And then what?
People forget and
People should and people must. Chorionicity is a must. Otherwise, you're not doing. There is no. See, some people see nasal bone, some people don't see nasal. That's not a problem. But chorionicity, you must. Early sight saves trouble and time. That is, if you say monochorionic, then she has come to come every 2 weeks. Dichorionic, go home, come back after 4 weeks. Okay? And let's all sing this rhyme that everybody must see. Everybody must see. Like that. Right. Next. Okay, this is a nice one. Caged am I, looking bright. Left or right, I am not a fright. Deceptive I am in appearance. My supply makes all the difference.
Fetal lung.
Okay, let's see. I want you to read through it, and
Heart.
so from lung it went to heart. Caged am I, looking bright. Does the heart look bright? Left or right, I am not a fright. Is there a left heart and right heart? No. Deceptive I am in appearance. My supply makes all the difference.
Thymus.
Okay.
Left or right? Left or right?
Ductus venosus. Where is it?
Pulmonary sequestration.
Who said that? Who said that? Stand up.
Pancha.
Why did you say?
Panchalan.
Who said pulmonary sequestration? You are?
Yeah.
You said pulmonary sequestration?
Yeah.
Please, I need some witnesses. Did she say pulmonary sequestration? Somebody is standing there. Because the light is too bright. Did you say pulmonary sequestration?
Pulmonary sequestration because it is caged and it is in the lung, and left or right, I am not right, and it should be, it is a differential diagnosis, and we differentiate it with the blood supply from aorta.
Please give her a big hand.
Thank you, sir.
And give her 10 full marks.
Full marks.
Yeah, full. Doesn't matter.
Thank you, sir.
Okay, that's a nice one. Okay, this is also a nice one. Now, whose turn is it? Their turn, huh? Okay. In the crown and back I remain, the steady walking domain. Citing me causes despair. An expert saves me with a flair. Okay, in the crown and back I remain, the steady walking domain. Citing me causes despair. An expert saves me with a flair. Yes.
Dandy Walker syndrome.
Pardon? Dandy Walker.
Dandy Walker malformation.
Yes.
So, Vermis.
Vermis. Okay. She said Dandy Walker. She said Vermis.
Spina bifida, open neural tube defect.
Spina
In the
bifida.
crown and in the back, I remain.
Okay.
The steady walking domain means it will allow us to walk.
Okay.
Citing me will cause despair to the person who is examining.
Okay.
And if we can diagnose it, so we can just prevent the baby with the spina bifida.
So spina bifida, an expert can save, no problem.
Fetoscopic surgery.
Fetoscopic surgery, wow. Wow, she's far advanced here.
Blake
She's
spout
far
cyst.
advanced.
A Blake spout cyst.
Who said that? Blake spout cyst. What makes you think that?
Sir, it is in the crown and back.
But
Citing me
actually,
causes despair. but
actually
if I
the
do that-
answer of Blake spout cyst came from the audience, right, first? Who said that first? Everybody said. So please cut the chocolates into 20, 25 and give it to them. Okay, it's Blake spout cyst. Because why I am saying an expert saves me with a flair, because the moment you say Blake spout cyst, keep quiet, don't do anything, reassure, things will be all right.
But sir, it's not in the back, it's in the crown.
In the crown and back.
Okay, that
In the crown and back. Correct? I mean, I went through a lot of thought process for this here. I knew there'll be people fighting. Okay, just for fun. Okay, just one more for fun and then we'll close. Round and round I do go, red and blue a steady flow. Doubling in agony my poor lady, to save in time and not tardy.
Umbilical artery flow.
Anyone? Round and round I do go, red and blue, a steady flow. So umbilical artery has got red and blue, huh? I didn't know that. Doubling in agony, my poor lady, to save in time. So why does the umbilical artery causes agony? Wait a minute. Yeah, this is for general, all four are over, huh? The rounds are over. Who said whirlpool sign? Explain. Ectopic pregnancy. Whirlpool sign in ectopic pregnancy. Not allowed. Ovarian torsion. Perfect. That's a whirlpool torsion. Please give her a chocolate. Okay, last one. This may be a little tough, but big is a problem, small is fine. Touch me only when it is time. Flood and pallor I do cause. If not treated, do fear a loss. Ayyo, who said that? Who said that? You said choreangioma? I thought this was the toughest. That became the easiest. Yeah, excellent. Please.
Who gets it?
Chocolate. Okay, I think we will stop here. We do, what's the time? Time's up, right? Time over, huh? We have, if you have time, then I'll go to the audience now. I got some beautiful pictures.
Yes, sir.
Audience. Okay, now you can make the scores and we'll just announce the scores after you do. We will now go to the audience. Now, somebody be ready with chocolates. I want instant to be given then and there. Somebody be around the aisle. Audience, first one. Now, those who want to answer, put up your hands so that we will know who's put up the hand first. Yes. Pardon? Yeah, tell me. Ectopia vesicae. Okay. Gastroschisis. Okay. Any more questions? Any more?
Body stock anomaly.
Body stock anomaly. Any more? Cord entanglement. Okay. This is a singleton pregnancy. I should have said that in the beginning. Okay. So let me give the answer. Bladder extrophy. I think Rachita can get the prize for that. Thank you, Rachita, for that. Okay. 37 weeks comes with loss of fetal movement since 1 day. 37 weeks comes with loss of fetal movement 1 day. Any guesses? Pardon? Who said that?
Ischemia.
Pardon? Who said coronary artery? Please announce your name.
So Dr. Neha, coronary arteries.
Why do you say that?
So it's coming from the center, going towards the probe, red in color. IUGR you said. So probably opening up of the vessels.
Did I say IUGR? Did I say IUGR? Where did you manufacture that IUGR? I said 37 weeks comes with loss of fetal movement since 1 day.
Cardiomegaly.
Pardon?
Cardiomegaly.
Cardiomegaly, yeah, cardiomegaly is there. But I think we have to give the prize to Neha because it is dilated coronary artery in acidemia. You can see that beautiful coronary artery which is there. Excellent observation. Okay, now this is very tricky. This is very tricky. I want you to, she is 31 weeks and 5 days, and I want you to look at from here to here to here to here to here. Not only here. Okay? That's where your clue is. This is only to make your mind see certain things in the image which you are expected to see. The moment you get an image, your mind must go to that first, just to drive home that point. Any guesses?
So high frequency transducer, sir.
Yes.
Congenital diaphragmatic hernia.
Okay, high frequency transducer. Who said that?
Sir, here in the quiz.
Oh, here. Sorry. Okay, so high frequency transducer, agreed.
So the small bowel is appearing.
Appearing what? Looks nice to me. Abdominal pregnancy. Oh, wow. That's a nice diagnosis to make. So let me point out what I'm looking for. I'm looking for this. I'm looking for an answer for this. The danger of using high frequency transducers. You are right about high frequency transducer because it's an L29 transducer. Okay, this, does it look like large bowel? Does it look like large bowel? It's been labeled as large bowel. Is it small bowel? But it's too far into the periphery. Psoas muscle, perfect. This is actually a psoas muscle, it's labeled as large bowel. That's what is wrong with this image. So please, give him chocolate. Beautiful. Okay, now this is fantastic, okay? Listen, see this video, it's a DCDA twin. And your eyes must be very sharp to pick it up. I'll play it again. So this is twin A and twin B.
So discordant Leica.
Discordant Leica, too simplistic for me to give it to you. You're all enlightened audience. How can I give you such a simple thing? Reversal of flow. How can you find out reversal of flow in this kind of cord which is going round and round?
Because the same place is showing red and blue color, alternating.
Where?
In the right side of the image, the same part of the umbilical cord is changing colors from red to blue.
Oh, let us play it. 1 minute. So, I'm stopping. Okay, I'm going to move frame by frame.
It's becoming red to blue.
So what's happening? So what do you call it as?
So the flow is changing direction.
So
It's a bidirectional flow.
Bidirectional. In the umbilical artery,
So it has to
bidirectional
be
flow means
so
what?
it has to be reversal of flow.
So what is it then?
REDF.
See, because whenever we put a Doppler on the umbilical cord, our mind is only going to the artery, isn't it? We are only putting the sample volume in the artery and is doing that. What's happening here? Look at this vessel. You got the artery, you got the two arteries and you got a vein. I want you to see whether there is a vein here at all. Are you able to see a vein or no? No. This baby does not have umbilical venous flow, it is showing only arterial flow. Baby was severely hypoxic. The flow in the umbilical vein became so low in velocity that it was not picking up at all. And next day, of course, the baby died. Okay, so this is a no flow that it is the twin was severely growth restricted and it didn't. So just to say that when you look at a standard pattern of color, everything must come to your eye. Last but one. This is a beautiful, very beautiful image. 16 weeks MCDA twin. 16 weeks MCDA twin. Okay? Yeah? Taps, okay. And? So how do you say taps?
Sir, MCA PSV is high.
MCA PSV for twin A. Did you ask me about what happened to MCA PSV by twin B? Just because one is high, can you call it as taps?
This twin
Starry sky appearance of the liver.
Liver.
So this twin is polycythemic.
Polycythemic.
So even without MCA Doppler, you are saying this is polycythemic, and this is anemic twin. So it is TAPS. Perfect. Who wants a chocolate? Somebody wants it, go and get it. Okay, thank you very much. We are done.
Can I say the final score?
Yes, final scores.
Okay. Champaran scored 27.5.
Okay.
Dundee scored 20.
Okay.
Jhansi scored 12.5.
Okay.
And Panjalankuruchi 15.
Okay.
So the winner is Champaran.
Very good. And then the second is?
The second is Dundee.
Dundee. Okay. So both of you get your prizes. Are the prizes ready now or we're doing it later?
Sir?
Because we need your names, right? So we'll have
Yeah, we have your
we'll
names.
give it later. Thank you. So meet you tomorrow.
Yeah, we have your names. So.
Coming. Yeah? Where? Okay, please, all of you can join us for a beautiful evening in Hall C. Okay? There's a nice music, isn't it?
Nice music followed by GL launch.
And there's a launch also. Please come.